This means that global principles may clearly affect the system and also associated with and stereotypes. So these are systems and conditions. They are influenced by the cardiovascular and cerebrovascular system, which includes the coronary heart disease, ischemic heart disease, stroke, and endocrine system, diabetes mellitus is one of the examples. And the reproductive system, it can involve the preterm low birth weight, baby, and preeclampsia, and the respiratory disease, COPD, and acute bacterial pneumonia. In neurological system, anemia is one of the commonest findings and rheumatoid arthritis. I'm going to discuss very briefly on this. So, cardiovascular disease, the common conditions are coronary heart disease, ischemic heart disease, and then the pectoris, myocardial infarction, and stroke. And the causes are reduction in the blood flow to the heart muscles due to partial or complete closure in arteries because of the thrombosis muscular. And how this is happening or how it is helped or influenced by the periodontitis. Because as the blood flow is involved or there is obstruction in the blood flow due to memory of the blood athletes. So don't matter how it's happening in periodontitis, bacteria or byproducts. They from the oral cavity they enter into the blood vessel and host response can lead to damage and atherosclerotic plaque formation. And second mechanism is that periodontitis enhances ongoing chronic inflammation. After mechanical periodontal therapy or even it occurs after the normal daily functions and oral hygiene procedures. And elimination of serum-oriented cytokines and acute phase reactants have many biological effects, leads to elevation in serum lipid levels, and systemic inflammatory state may adversely affect many organ systems, leading to systemic diseases such as chronic inflammation. So this is one of my study where I tried to find out whether where is the therapy affect on serum lipid level because serum is the or cholesterol level is directly affected or directly influence the coronary heart diseases or any other heart diseases. So we try to find out whether periodontal therapy it is an interventional study and whether it can help into find out whether periodontal therapy can help in the reduction or reduction in the periodontal systemic diseases like mainly heart disease. These are complete or we can say that in reducing the serum lipid levels, we can reduces the risk of associated systemic conditions. Now, our second system that is related to pregnancy, that there is increased level of estrogens and progesterone during pregnancy. And these hormones are responsible for increasing permeability of the capillaries and thus increases the mother susceptibility to oral infection. And method in method Molecular and physical managers are one of the characteristics of normal physiological pregnancy, which cause professionally to rise to a critical level and lead to induced labor, cervical damage, and initiation of the delivery. So these two conditions, one is the like pregnancy disease, is always close the entire gingiva is involved because of the deficiency hormonal levels. And considered as discriminate tumor group in Vinayaka, which is called pregnant tumor. This word terminology is misnomer because it is not a tumor itself. So in advanced pregnancy outcome, it includes the preterm birth, preeclampsia, gestational diabetes, low birth weight infants, and fetal death. The WHO criteria, according to this criteria, the preterm birth means that live birth is 27 weeks of gestation, or it may be very preterm birth that is below 32 weeks of gestation, and extremely preterm birth is below 28 weeks. And birth weight is considered as low when the weight of the fetus is less than 2.5 kg, and very low when it is 1.5 kg, and extremely low when it is less than 1 kg. So this can impact congenital anomalies, disorders, neurodevelopmental disabilities, behavioral problems, learning problems, cardiovascular diseases, metabolic abnormalities, difficult need to die, and account for two-thirds of the neonatal death. So this which our society cannot afford. And causes are preterm labor, premature rupture in the membrane, smoking, alcohol or drugs during pregnancy, inadequate prenatal care, low socioeconomic status, parity, short cervical length, high physiological and psychological stress and poor nutrition, hypertension, diabetes, maternal age like more than 34 years and less than 17 years, low maternal weight, genital urinary tract infection, and coagulation infection. So these are the causes of low birth weight infants. Then come to how periodontitis affects. Then Ophion in 1905, they found a link between the periodontitis and preterm low birth weight babies. So they say that the person or the woman who is having periodontitis, they are 7 to 5 times more to give a baby with low birth weight. That's four. 4.5 times more times to give low birth weight babies than the normal woman who is not without periodontitis. And the periodontitis, the mother having give the exactly low term birth rate, they have more bigger limbs than the woman with normal birth. And culture of amniotic fluid in women, which is normally sterile. It is in the in preterm mother, they found that preterm nuclear ducts and capnocytophagus, these are the bacteria which are present culture of the amniotic. So this is the mechanism of liver induction. The infection in the periodontia. Sorry. Infection, periodontitis infection, they can directly the endotoxin and microbial product they produce, they can directly act on the uh, uterus and cause the rupture of the amniotic fluid, and then this may lead to preterm low birth weight babies, and they also another mechanism that they can act on via liver. They produce these inflammatory cytokines, and they help in the rupture of the membrane and preterm delivery. So another condition, preeclampsia, which also occurs in pregnant women. So women with severe periodontitis during pregnancy has increased risk of preeclampsia. Mothers with healthy periodontia, only 3% can have, but mothers with mild periodontitis, they may have 5% of cases, and mothers with periodontitis at delivery, they may give, they may suffer 10% of the preeclampsia. Well, preeclamptic women have greater parental disease and insensitivity mediators compared to the mass control. So, international studies reported that incidence of preterm low birth weight babies reduced from 18.9% to 13.5% with non-surgical periodontal therapy. If we do the interventional study or interventional treatment, then we reduce the preeclampsia and at the same time preterm low birth weight infants. And therefore, similarly, suggested that if we go for 21 to 25 weeks gestation, if we go for periodontal therapy, it may reduce the from 6.3% to 0.8%. So, what is the link? Exactly, indicators may work as a bridge between the periodontal disease and adverse pregnancy outcome. Periodontal pathogens invade the uterus via hematogenous dissemination and causing adverse pregnancy outcome. Advanced increase of inflammatory mediators in the fetal placental unit will have premature rupture of membrane and uterine contractions which will result in premature birth or spontaneous abortion. Periodontal infection may interfere with normal physiological regulation of labor and delivery. The periodontal disease in pregnant women could be a risk factor for preterm low birth weight babies. So, American Academy of Periodontology reports in 2004 that expectant mothers should be counseled in the importance of oral health. So, it says periodontal disease and preterm delivery. It is not in the research. Now it can reach to practice. So, it is time for team approach. So, this is one of my study that whether periodontal disease and pregnancy outcome is correlative study. In the study, we suggested or we conclude that four vagina has definitely affect the pregnancy outcome. Now, another system which is affected by periodontitis, that is the diabetes mellitus, and it is the most widely studied aspect. Whether diabetes mellitus is affects the periodontal health or periodontal health affects the diabetes. It is complex. It is bidirectional aspect, and periodontitis affects the severity of the mellitus, and at the same time, it affects the severity of mellitus. This is a classification. Of course, I need not to talk in details. That is type 2 and specific types of diabetes, the causes and gestational. Normally, blood glucose is controlled. It is the food and blood glucose increase, and it results in more insulin secretion, and that results in the lower level, reduces the blood glucose level. And complication, as we know that retinopathy, nephropathy, neuropathy, these are the microvascular and macrovascular diseases are the peripheral cardiovascular, cerebrovascular system and altered wound healing. And another proud moment was that periodontal disease, which is also considered complication of diabetes mellitus in 1993. So this is the two relationship diabetes mellitus and periodontitis. Diabetes is there, hyperglycemia is when periodontitis is there, or periodontitis or any infection is in the body is there, it leads to insulin resistance, and there by that uncontrolled diabetes occurs. And we can treat it by combining with periodontal treatment and diabetic therapy. And by doing so, if we do the mechanical periodontal treatment, the periodontal pathogens will be reduced, and then thereby, in other way, insulin resistance will be decrease and thereby HbA1c, which is the main component of diagnosing the diabetes mellitus, will be reduced. So, periodontal treatment and diabetes, these are the concepts given by in 1960 that by doing diabetes treatment, we can reduce the periodontitis, and by treating periodontitis, we can reduce the diabetes mellitus, severity of diabetes mellitus. So, one of the another study where that we use an adjunctive effect of Gogawale, which conventional periodontal therapy in glycemic level of chronic periodontitis with type 2 diabetes mellitus. We found that clinically that adjunct use of doxycycline to conventional periodontal therapy provides additional effect in reducing glycemic level and improves periodontal health. So this is another study where periodontitis and gestational diabetes mellitus. It is a case control study we conducted, and in conclusion, we can suggest that gingival index, periodontal index, 50 periodontal pocket depth, and clinical assessment level more in the subject with gestational diabetes mellitus than those without gestational diabetes mellitus. Associated with the periodontal disease. So next system which can be affected by the periodontitis is the respiratory disease. This is respiratory diseases. They have a significant number of deaths occurs due to respiratory disease. This is very common, considerable starving movements, and low respiratory infection is a third cause of mortality. Chronic obstructive pulmonary disease is the sixth cause of mortality. So, upper respiratory tract, which is contaminated by organisms derived from the oral, nasal, and pharynx, and usually lower respiratory tract is strengthened. But due to host delayed factors and mechanical clearance, it remains sterile. And 50% healthy subject experience oropharyngeal contracts during normal sleep, and those different mechanism eliminates those bacteria. If body fails, bacterial leukemia can ensue and cause respiratory disease in individuals with compromised immune defense. And COPD, it is characterized by airflow obstruction resulting from chronic bronchitis, and there is less airflow in and out of airways, airway and air sacs losing elasticity. Walls between the air sacs are destroyed, and once the airway becomes thick and inflamed with more mucus secretion. And in pneumonia, alveoli are filled with pus, mucus, and other liquids. Oxygen exchange cannot take place. So, mechanism how the oral bacteria influence the respiratory disease. Persons with poor oral hygiene are 4.5 times more likely to have chronic respiratory diseases. These can serve as a respiratory infection. These can serve as a reservoir for respiratory infection. Oral bacteria from plaque come mixed with our salivary secretion and they aspirated into the lower respiratory tract and they leads to the pneumonia. And usually lung fluids, which are sterile in infected portion, it is found that P. gingivalis, B. oralis, B. bacillus, these are the bacteria from periodontal infection, and those bacteria are present in the culture of lung fluid. So it says that they are originated from oral cavity. So these are the mechanisms. Oral and periodontal bacteria may be linked to respiratory disease directly by into lungs causing pneumonia. And possible mechanisms are described by Skeptico in 1998. The mechanisms are pathogens produce enzymes. Then those enzymes like mannose Cellulitis, fucositis, and hexosamine disease. Because the mucous surface adhesion receptors which are present in the oral mucosa, and these enzymes they alter the mucosal surface so that these receptors are exposed into the oral cavity, and oral bacteria can adhere to those receptors. Another mechanism is that enzymes degrade the pellicle on the oral bacteria. So when this pellicle is destroyed, then they can easily adhere to the mucosal surfaces. Then another mechanism that is the enzymes degrade the salivary pellicle on mucosal surface. One is now it is damaging the mucosal surface. Previously it was a bacteria where the salivary pellicle is destroyed. So these additional molecule or receptors for the respiratory pathogen is exposed. Another mechanism that cytokines upregulates the adhesion receptors on mucosal surfaces, and they promote the respiratory pathogen colonization and then further infection in the respiratory system. So this is another word where we have tried to see the quality of life in COPD patients, because COPD patients are they are usually their their mental setup is very depressing, and so in that case we try to find out whether the between the scale of phase one therapy can improve their quality of life, and the quality of life was measured by St. George's Respiratory Questionnaire (SGRQ), and we observed that the phase one therapy and promotion of the oral health and knowledge by doing the phase one therapy may play an important role in modification of the quality of life in patients with COPD. So, pulmonary disease and anemia. This is another system whether periodontitis affects the occurrence of anemia or not. Periodontitis as a chronic infection, it can cause the as a chronic infection, it can affect the occurrence of anemia, and the correlation is observed between chronic periodontitis and decreased level of hemoglobin, hematocrit level, and RBC count, and suggesting that anemia is induced by inflammation caused in patients suffering from periodontal disease. This is one of the studies where rates and parameters were in smokers and non-smokers, how it affects in chronic periodontitis. This is another study where red blood patient with chronic periodontitis was measured. And now another system which is the rheumatoid arthritis. So rheumatoid arthritis is an inflammatory disease of joints involving an autoimmune attack of particular tissues, periarticular tissues, which may compromise the synovial fluids, joint cartilage, and bone integrity. Etiology is not known exactly, but activity of periodontal pathogens is related to the production of rheumatoid arthritis autoantibodies. So these are the similarities of periodontal disease and rheumatoid arthritis pathobiology. They both are chronic inflammation and chronic autoinflammatory disease, in fact. And there is genetic involvement, HLA and DRA, and environmental influences are there in both conditions. And there is increased interaction of TNF alpha, prostaglandin E2, the other factors which are common in both conditions. And there is TH1, TH2, and TH17 are involved in both the conditions. And again, bacterial DNA anaerobes and high antibody titers against the heat shock protein of P. gingivalis and P. melanogenicus and P. intermedia in both the cases. So, inflammation caused by P. gingivalis, which is a very common pair pathogen, and actinomycetes actinomycetum comitus triggers coupled responses and antibody production for further which leads to the rheumatoid arthritis. So this is one of the study where we have the effects of phase 1 periodontal therapy on rheumatoid arthritis. We found that poor periodontal health plays an important role on the severity of rheumatoid arthritis, which may be improved through the promotion of oral health care and awareness program. So this is very interesting slide, and I really like this slide. So you see, other side that is showing a one foot outside, where we can find the surface area is not more than 2 millimeter or 3 millimeter. But we have seen what we see, we are very much worried about this kind of incident when it happens to us. But this side, it is something one surface area of arm, which is more dangerous than this answer. Because this is a when we are having about more than 5 millimeter pocket there. The circular epithelium entire oral cavity, where if we add the entire circular epithelium, so it will be the size of our palm. But we know this area because it is not visible to us, so we do not care about this problem. We take more. So this is we should be the we should make the people awareness, increase the awareness about these issues because the potential problem, periodontitis, even if it is, we should not think that it is a local disease, it is present within the oral cavity, and if we need to, if any problems occur, we will go for extraction. So this is not the ultimate result. We should think about this that this problem is more serious because when we are having infection in the oral cavity or periodontium, that is more dangerous than having a diabetic foot ulcer. So, in conclusion, what I want to say is that periodontal disease may increase the risk for many systemic disorders. However, it should not be presented as a cause of some disorder. The emerging field of periodontal medicine offers new insight into the concept of oral cavity as one system interconnected with the whole human body. Then for many years, dental profession has recognized the effects of systemic conditions on the oral cavity. Now, however, dental professions are beginning to understand more fully the impact of periodontal disease on systemic health. A gradual integration of medicine and dentistry representing more responsibility of a dental surgeon in the management of the patient's systemic health and similarity. Patient systemic health and similarity and the physician's active role in their patient's oral health is the just last one. And periodontal disease can be since it is a preventable and manageable. Preventive and restorative periodontal treatment is safe also. So scientific evidence gathered so far that it appears that interventional periodontal care remains invaluable not only for oral health but also for general health. I'd like to acknowledge the 11th Organizing Committee of 11th World Dental Sciences and Oral Health Conferences, then CynoDent and Subharti and Indian Academy of Dentistry. Thank you so much. Thank you so much for patience here.
साइनेज करना मैं जा रही हूँ उसके बाद
Thank you so much, ma'am, for such an informative lecture. It's first Kuskurahaji, a celebration of the Kuskurahaji. With this thought, now I would like to invite our next speaker of the day, Dr. Imran Khan, sir, Professor, Department of Oral Maxillofacial Surgery, Faculty of Dentistry, Jamia Millia Islamia, New Delhi. Present his topic, Management of Complex Odontogenic Infection. Syllabus are Professor Dr. Acharya and Professor Dr. Vivekanand sir.
Was enlightening lecture, the first lecture by Professor Swami. I could listen to the second half of the lecture. Many of the systemic diseases are related to periodontology. So we have to be more careful with our gums and teeth now, with the slogan and the messages. Starting with my lecture, many of us in our day-to-day clinical practice will be dealing with patients like this. Or I'm not able to move my slide. What is that? Yeah. So at the point there is I'll try how to manage that. Yes. So many of us have to manage patients like this in clinical practice. Some patients are like this. Some are like this with limited mouth opening, swelling, pain. How do we go ahead in management of these patients? Should we, what should be the diagnostic step? How would we go further after diagnosis? Suppose if we have diagnosed it's an infection, how do we go ahead? Should we just give antibiotics? Should we do an IV? Should we refer the patient for a general dental surgeon? Or we are so afraid of the complications that we just refer the patient. And what about the post-op care? So, warm greetings from the Faculty of Dentistry, Jamia Millia Islamia, New Delhi. Today I am here to speak on this topic, management of complex maxillofacial odontogenic infections. I'm Professor Vivekanand, and I'm working in Jamia Millia Islamia for the last 15-16 years. It's a central university located in Delhi. This is my email ID. Yeah. So it's a big topic actually. I generally take 3 to 4 lectures to cover this topic in my UG classes. I try to do justice with this topic in the limited 30 minutes which I have. We should be, before treating such patients, we should be knowing the microbiology of the odontogenic infections. We should be also knowing the progression and pathways of odontogenic infections, followed by the management and life-threatening complications related to the infections. So I will be just covering it in these subtopics here. The foremost thing is that these infections are polymicrobial. These infections are polymicrobial. They are caused by bacteria. Some of these infections are also caused by viruses as well as fungi and spirochetes. We should keep this in mind. Most of these are caused by bacteria, and of the bacteria, most of them are anaerobic. Like 75% of the organisms causing these infections are anaerobic. 25% of these infections are caused by aerobic bacteria. Now, there's a standard textbook on maxillofacial infections by Ajay and Goldberg. Now, in the very first page, there's a picture of a wave balance, okay, which attributes the pathologic attributes of microorganisms, and there's a wave balance actually. So whenever the virulence of microorganisms and the quantity of microorganisms supersedes the most local, humoral, as well as cellular factors, the patient lands up in an infection. So it's an excellent diagram given in that book. I've just tried to elaborate that book. Um, Now, what are the local factors in the host which actually provide defense against these microorganisms? Have you ever wondered a patient of burns, patient who has survived or a burn injury, or a patient who has got a burn injury, has life-threatening infections? Why? The reason is the integument of the skin is the first line of defense. In the burn patient, the integument of the skin goes off completely and they are exposed to multiple microorganisms. So similarly, there are local factors in the oral cavity, that is the intact periosteum, the intact alveolar bone, the local blood supply, which will actually dictate the state of infection, whether the patient is having an infection or not. You may see multiple times the patient having a carious tooth and the patient is carrying that carious tooth for years and the patient is not having any infection. And similarly, even a small carious tooth in another patient giving him a big dental abscess. So this basically is because of the wave balance which I was talking about. Then other factors such as the humoral factors, the quantity of immunoglobulins, as well as the cellular factors, that is the lymphocytes, the phagocytes, and the lymphokinins in the patient's own host system or the immune system, which will actually work to help patient getting out of this infections. Now, there are certain factors which can alter the patient's immunity always. And Madam in her lecture about periodontal and systemic association pointed out a strong relation between diabetes and systemic health and periodontal disease. Similarly, diabetes is one of the commonest concerns in which the patient may have infection. Spontaneous growth, which is not doing anything, not causing trouble in the patient, can be medically compromised or having an increased blood levels. Similarly, patients who are on steroids, long-term steroid therapy, patients who are chronic alcohol, patients who have a history of leukemia, lymphoma, or chemotherapy. So there are certain local factors such as hematoma, traumatic surgery, pre-existing infection, chronic pericarditis, etc., etc. Yeah, these patients are more susceptible for these infections. Now, most of these infections are ototogic in nature, that is why we call them ototogenic infections. But some of these infections can also be secondary to a trauma surgery, secondary to implant surgery, or secondary to some, punctured or contaminated human nature. How does these infections progress? There are basically three stages. One is inoculation, second is abscess, second is cellulitis, and then an abscess. And sometimes this abscess may rupture or it may further spread. So, talking about the difference, one should always understand the inoculation stage or the initial stage, the microorganism content is mostly aerobic bacteria, if it is a bacterial origin infection. And the consistency is more jelly-like. If you calculate that swelling, whereas if it is a cellulitis, cellulitis is basically spreading. Okay, cellulitis is basically spreading. Consistency would be more like hard consistency. Okay. Also, in our accidents, chronic edema, question is basically increasing. The first is residual abscess where it may be absent in cellulitis as well as edema. And in abscess, the bacteria shifts now to the anaerobic state. So, inoculation is anaerobic bacteria most of the time, whereas in abscess it is an anaerobic bacteria. Now, this is a classic picture differentiating between cellulitis and an abscess. You can see in this picture on the left hand side, an abscess is more localized. You can see the shiny center, which is red. Okay. And whereas on the right hand side of the screen, cellulitis is spreading. The patient will have swelling in multiple places, and the patient would have more problems in the cellulitis, and of course, cellulitis is more dangerous. These infections will spread via the facial space. We'll just talk about the facial space in the later part of this lecture. They can also rarely spread by the lymphatic spread or by bloodstream. Again, it's rare. Cavernous sinus thrombosis is one of the complications where it can spread via the bloodstream and the infection can actually land under the middle cranial fossa, causing complications. If the patient, in the previous slide, we had three set of patients. If such patients land up to you in your clinic, what are the factors that, or what are the features that you would assess? History. See, many a times intraoral examination may not be possible. Why? Because there is limited mouth opening. Okay. So history that, okay, had you had any toothache दांत में दर्द था क्या आपके कुछ टाइम पहले? Had you had, was it the recurrent one? What did you do? Okay, Doctor Saab, I went to a medical store. He gave me medicine and the swelling, subsided, and I'm now again getting the swelling after 6 months. Or I was non-diabetic 1 year back. This gave me trouble. I took medicines. That was okay. I'm diabetic. My blood sugar HbA1c is 9 now, and I'm getting infections. Or even, I see lots of lady patients in their pregnancy. Pregnancy also basically hemoglobin decreases. Anemic patients. Okay, they come up with this infections. So you need to assess the proper history, the onset, the duration, and rapidity. History of any previous treatment, medically compromised, as I say. Headache infections are sometimes fatal. This is the only branch of dentistry or only pathology where patients will actually eventually die in school in case if you're not treating the patient well. The treatment is not well given. So it is very important to see if the patient is having toxic. Now, what do I mean by toxic? Patient is correct. If the patient is showing airway compromise, or if the patient is showing serious changes. I will show this in the next slide. Patient who are having dyspnea in about 3 weeks. Okay. Patients who are also saying, I'm not able to chew food because I'm not able to swallow. There's lots of difficulty with swallowing water also. That can be a sign of involvement of parapharyngeal space, and actually clinically it is very difficult to visualize parapharyngeal space on a dental chair. So the patient will generally tell you that I'm having dysphagia or inability to swallow. Patient will also have restricted eye movements or ocular movements. This is basically significant CNS involvement. And change in the quality of voice, increased level of consciousness. So these kind of cases should ideally managed in an eye clinic setting, not the open setting. Good hospital setups with ICU batteries and ventilator batteries. Okay, you should inspect the skin of the face for the redness. You could see you could check for the swelling injuries. You could see the fixity of the skin to the underlying tissues. Any signs of fiscal formation. You should palpate for the size, tenderness, localized temperature, fluctuation. You should check for the salivary glands because some of these infections can be because of the salivary gland involvement. That is, cyanodental. That is a different story altogether. Obstruction of the salivary duct and expansion of the underlying bone. Intraoral examination, as I said, is generally difficult because patients may show trismus, and because of the trismus, you actually cannot see much of the oral cavity. Localization of the involved teeth, localization of swelling and fistula, signs of tooth extraction, and effort should be made to visualize senses and Watten's duct, soft palate, tonsil, and uvula. This I have spoken about. Yeah. Now, okay. After the assessment, what next? X-rays, conventional X-rays. IUPs because of trismus may be difficult to make. Sometimes it is very difficult to get an IUPA there in the posterior part of the mandible because the limited mouth opening. So panoramic view is one good thing where with the limited mouth opening also you can actually get the visualization of the radiological structures. APU for neck. for the involvement of other spaces, a CT scan as a contrast greatly helps you. And CT scan translation sometimes can be helpful. This is a panoramic OPG, panoramic view, which is basically visual multiple cavity store. Introductory view of the leg, which is showing the arms there are showing the degrees airway space. This basically is on the left hand side is the axial part of the Mahadevan or the paraphalangeal area. You can see a circle which is compressing on the airway. So this way, these X-rays can be helpful determining whether the swelling or whether the infection is in the parapharyngeal space or actually compromising onto the head. We can see also. Think about this in a minute. Please see this video. This video was not especially for the undergraduate students. Now, this old lady was, traveling to various clinics and colleges for the last, few months. And I'm having persistent pulse discharge. And in the private clinics, I mentioned, okay, the sinus is involved, okay, go somewhere else. And antibiotics. Actually, relieve the symptoms. And then again, she was also diabetic. Now, the etiology was basically the impacted thermodor, which was there, which lots of inflamed pericordial tissue, which was removed as shown in the surgery. And this basically is a section of CT scan, CT, which shows how the sinuses are also, the mucosa of the sinus is also, hazy and and also the removal and irrigation and curator shown on the right, it was absolutely fine. So this video is just this shows the localization of infection of severe etiology. Patient with infection in a high risk patient, immediate hospitalization may be required. We also may have to secure the airway via tracheostomy. We should start with aggressive medical therapy, that is antibiotics plus supportive therapy, that is adequate hydration and surgical intervention. The most important thing, as I spoke about those factors, local factors, humoral factors, and the cellular factors, is correction of the host defenses itself. If the patient is having a high blood sugar levels or a vascularly compromised vascular supply, no matter how good antibiotics you give or no matter how good surgery you give, the patient is not getting antibiotics at the localized site because of the compromised vascularity. So you have to see that aspect also. Showcase this slide of almost again and again. This taken up for a textbook of the infection, but he very well says this. Antibiotics should be viewed as a double-edged sword. Okay, because the misuse of antibiotics will promote growth of infections. Understanding that the infections are ultimately cured by the host defenses and not by the antibiotics is very important while treating these infections. Antibiotics in certain situations which the host has been overwhelmed by bacteria or even by virulent bacteria involved. There are certain conditions which may not require antibiotic therapy, and we are actually happy to have trained in such an unfortunate that, like for example, in diaphragmatic case, they would never require antibiotics. So if the patient would require antibiotics, you're actually exposing the patient unnecessarily, those antibiotics may not work. Similarly, in this This is not something the patient will come and tell you, Doctor, Saban, antibiotic, Vivekanand. We should not entertain this. And medical instructions, also on the instructions, we write antibiotics never. Unaffected, never, generally never. Okay, even in diet, very problematic. Just use irrigation, mouth punch, I mean, that's it, as well as painkillers. So, even in brain, dental, other abscess, we may not require antibiotics always. How do you choose antibiotics? This is very important again. See, identification of a causative organism is very important. Now we know that. That if it is an abscess, it has to be an anaerobic bacteria. Majority of the microorganisms are anaerobic, so we should always have an ideal anaerobic coverage. Determination of antibiotic sensitivity is also important. Penicillin, very commonly. Okay. Approximately 5% of the patients have sensitivity to penicillin. One should know the previous history whether the patient had an allergy or not. So once we identify the bacteria and once we identify which antibiotic the bacteria is susceptible, try and choose the narrow spectrum. I don't want to expose my patient to a very broad spectrum so that other bacteria which are actually not involved may get resistant to that antibiotics. Knowledge of the patient history or radiology is important. Always try to use the bactericidal antibiotics rather than the bactericidal. For example, erythromycin, very commonly used antibiotic, is a bactericidal. Okay, whereas amoxicillin is a bactericidal. Of course, in Indian economics, it is very important. It should be affordable to the patient. And patient compliance. There are few medicines which you prescribe 5 times daily, and there are certain medicines which you give only once daily. So patient will be more compliant on a single dose. Okay. So these are all the principles in choosing the right antibiotic therapy. And the principles in antibiotic administration, again, I'll just take 2 minutes on this. It's an important slide. Now, we all write as a dental intern, I was trained to write blindly amoxicillin 500 mg, 500 mg for every tooth extraction and endodontic therapy. I never thought why 500 mg? Why not 700 mg? Why not 1050 mg? Now, I think you undergraduates also here, did this question arise in your mind also? I never thought until I was graduate studies. See, there's something called as MIC or minimum inhibitory concentration in pharmacology. If you go back to your pharmac second year BTS, okay. Now, for example, let me give you one example. One common antibiotic is syphilis. Okay. So the minimum inhibitory concentration of syphilis is 6 microgram per ml. Okay. And there should be at least 4 times of the minimum inhibitory concentration. So 6 into 4 is 24 microgram. And 24 microgram per ml corresponds to 500 milligrams for syphilis. So you should remember this MIC for a drug, which is minimum inhibitory concentration. The drug will actually take out the bacteria outside the host defense or kill the bacteria after 4 times. So that gives us the logic. Okay. Again, this is important. Why BD, why PID, why OD, why QID? It depends on the half-life of the drug. Now, I hope you, the undergraduates here, understand what is a half-life of a drug. Okay, it is basically the time taken by the body to half of the drug is basically taken out or metabolized by the liver or the kidneys. Okay. Now, generally, 5 times half, 5 hours will take out the drug entirely from the body. 5 hours, it corresponds to 95% of the drug is out. Okay. Again, coming back to antibiotics, commonly used cephaloxime. Cephaloxime basically completes its 5 hours in approximately 1 hours is around 1.5 hours. Okay. So 5 hours is around 8 hours. Okay, so we give it twice daily or twice daily. So depending on the half-life, plasma half-life, you prescribe this antibiotics duration, proper route of administration. Many of the times the patient will require an IV intravenous coverage. So we should know that when to start with oral and when to start with this, and there should be a consistency. There should not be that, we have given one loading dose of IV antibiotic and then we are following it up with oral antibiotics, or we are arbitrarily stopping this IV antibiotics, IV drugs. There should be a consistency in the root of the disease. Of course, combination antibiotic therapy. That is, we also have to give a gram-negative coverage or an anti coverage. I will just skip this slide. Coming to the principles of surgical therapy, we have stress and there is very important that it should assess the airway, breathing, swallowing, and voice, optimal function, current promotion, determination of the anatomical location of infection, evaluation of host defenses. You should also know that whether the patient has undergone some chemotherapy previously, because those patients have decreased immune response. Patient on chemotherapy or renal dialysis will also show the same. If the patient is showing any of these issues, that is high fever, airway issues, dehydration, need for incision and drainage, better to do in an IPD setup, better to admit the patient when we have a good ICU backing. So we have a young male patient with a big insurance service. That's another region. To explain versus what's coming. The setting was there for the last 12 days, what is told me. And it's also giving me a history of breakthrough pay. Because the impact is not over enough, so we are not looking into it, but infected. But let's see what we get. Absolutely. So the whole idea absolutely. Experience of you. I should look at everything. This is the technical for this. Secretary, super. Dheemahi. So final plus is called one simple movement. The only wide movement. This is why you have the not a regular movement 5 years or 3 years. So you have to go here and just using triangles. So something you can have studies and you can have a later or something that you can have some blood. So it's not a basic. So it is effective pathology. This is something you know. You can tell you the stuff as well as SOP. So why this video was shared? Because you can decompress the swelling by just by aspiration like this, and you can also know the specific microorganisms if the patient has not taken long-term antibiotics prior. If the patient has taken antibiotics, then probably you will get a sterile culture. But with this system in your syringe, you can send it in the lab. Basically, now you know that the charts variates most of the time is gram negative, gram positive, and dynamic, both the coverage you have to give. You can really send the specimen to the lab, get specific culture sensitivity, and start medicines accordingly. Principles of surgical therapy again. For such cases, incision and drainage are recommended apart from the extraction of offending tooth or removal of the odontology epitheliology. We secure topical anesthesia, we give surface anesthesia, this given by ethyl chloride or and the stabilization is made over a point of maximum fluctuation in the most dependent part and the healthy part of the skin. We use the sinus forceps or the mosquito or the curved artery forceps bluntly into the fascia towards the pus collection. Straight cavities explode bluntly and irrigated with hydrogen peroxide in saline or sometimes ozone solution, and there is a drain which is left in situ. The incision should be placed on the most dependent part, parallel to the skin creases. It should be supported by the healthy skin creases. And many a times these patients land up to general surgeons or ENT surgeons, and this is where our dental knowledge, is superior. I would say you have more knowledge than them because they forget to remove the tooth for the source of infection, and the patient will come back again with some swelling. Okay, so it's always you need to identify the etiology prior to the surgery, we are ready and okay to the according to the extraction or take the appendix out. Okay, we have to secure the airway. You have to check for the airway patency. Vital monitoring is important. That the patient calls and that's right. Remain the BP adequate hydration. Precipitation is important. Discharge when the patient is all right and rehabilitation. Given some local infiltration here on board video. I've given some local infiltration here. We are starting with the incision and drainage. Now, this is my mandibular inferior border. See this. Okay, this is my mandibular angle posterior border. Approximately 2 centimeters below the inferior border, that is here. Now, the skin here is not looking very good. So, if I give an incision here, I might actually reduce the skin. So, I'm just giving my placing my incision on a healthy part of the skin, which is here, which can actually break up this locule as well as this locule. So, it's not simple incision. It has to be approximately 3 to 4 centimeters. See this. See the perspective moving out. See the perspective moving out. I'm just compressing it. Just compressing it. Yeah. Compressing it. Okay. I'm not even going badly now. Just compressing it. See how fly first is moving out from the. Now this is a submandibular smear. In the submandibular triangle. I'm going to start. Sure. Okay. Now the second thing which I will be doing is placing my finger inside the cavity and doing a blunt dissection. Who does that? Jesus. Even necrotic material, bone, blood tissue, coming out. Okay. Now I need to clean it with this saline and silver. I use for the blood dissection. I use my finger. You know, it's a very safe thing to put a finger inside the space and just break the locule. Many of the times, this patient unfortunately will be shouting and in some pain because local anesthesia is not 100% effective. Luckily, this was one of my patients who did not make any noise. That is why I put this video. Many other patients are shouting and they are in pain. And of course, you also need to recognize the offending tooth or the cause of the infection. You have to treat the infection as well. In this video, I was actually just remove the locule which was because if I put my incision on the exact swelling area, then I might land that with a neck bone skin. That is the logic, just give an incision on the neck skin. Coming to facial faces, again, it's a big topic. Because boundaries, we have different spaces. I'll just cover it. Yeah, the space which I was talking about. Anti-medial diagnostic, post-medial diagnostic, the medial part of the triangle. Okay, this is one of the boundaries. Now, the important thing for students to understand here is the location. If it is a multigenic origin infection, the location of the root arises. Now, note lines top on submandibular space. So, what is the roof of my submandibular space? It is basically the myaloid muscle. Okay. And if my mandibular root arises, say, molar having a long root apices of 22 millimeters, mandibular first, second molar having long apices beneath the myaloid muscle attachment, I will get a kind of mandibular space involved. So if the root are little short, Then probably the first space which is involved is the sublingual space, because the sublingual space lies on top of the submandibular space. This is the picture which I was talking about. The root appendices. This is a medial myloid muscle. If my root appendices are beneath the myloid muscle, then definitely the submandibular space would be involved first. One more thing, posteriorly, the submandibular and sublingual space are in continuity. There is no boundary because the myloid muscle is scanty in the posterior part of the mandible. Clinical presentation of submandibular space is induration swelling in the submandibular area. We just saw how a submandibular space infection looks. It's a video. Angle of the mouth or angle of the mandible gets obliterated. Again, I showed you a video how to do an IND for such cases. Clinical presentation is something like this. The young child having this, and see the angle of the mandible which is obliterated because of the swelling. Coming to sublingual space. Now, if my mandibular anterior root appendices or if the root appendices of any tooth is above the attachment of myloid muscle, the first space which would be involved is the sublingual space. Sublingual space, my tongue would be opened up if the sublingual space is involved. Okay. Then there is a significant chance of significant airway compromise also in these infections. And we can give an intraoral incision also just close to the lingual surface of the mandible. But thing to understand, remember, is that we must always protect the lingual nerve, the vocal duct here, the submandibular glands duct here, while doing this. Then the submental space again in the anterior region. The patient looks like this, and just an incision, stab incision here on the chin can actually help or relieve this infection. Buccal space is another space which is very commonly involved in odontogenic infections. Now, this picture is there in multiple books. This is a very classical picture on how the anatomic barrier, dictates the spread of infection. Now, undergraduates, please try to understand that. See, this is my vaccinator muscle, right? This is my vaccinator muscle. If the root of the maxillary molar attachment is above the vaccinator muscle, the swelling will comprehend and show on the extraoral side. And if the roots are below the attachment of vaccinator muscle, however, swelling on a taut surface intraoral. Okay, one classic picture I have. Yeah, this was one of the picture taken from the textbook. And it generally may originate from infected root canals of the posterior of the maxilla and the mandible. One lady of buccal space, involvement of buccal space, classic buccal space. And this is not cellulitis, this basically is an abscess. Okay, because it's localized, it is not spreading. Okay, and treatment of such space infections can be very well done by an intraoral swab incision. By an intraoral swab incision. Nobody would like a swab here, right? Right in the center of the face. Nobody would like it. Okay, it is always, and while giving the intraoral incision, please make sure that you identify the pantry duct, that is the stencil duct, just allow it, you give, and bluntly either put a mosquito forceps or finger so that the entire tray, entire pump, and the fluid is drained out. The clinical presentation is a swelling of the cheek which extends from the zygomatic arch to the angle of the mandible, inferior of the mandible, in the anterior of the ramus. So this is how the lady looks after the treatment, after intraoral drainage. The patient is perfectly all right. Again, source has to be identified and to be treated immunologically or extraction of the tooth has to be done. Canine space, another important space. The infraorbital space is a canine space. We all know, we have been taught in first year anatomy that this triangle is a dangerous area of the face. Right? Right? Because infections here can travel through the volvulus vein and land up into the middle cranial fossa and give you a cavernous sinus thrombosis. So canine space infection has the potential to infections from here can spread to the brain. So they are basically from infected root canals of the premolar and the canines of the maxillary anterior region. The nasolabial fold is obliterated in these sort of infection cases. complication, one of the major grave complications of canine space infection is cavernous sinus thrombosis. I have unfortunately had one patient which was having a cavernous sinus thrombosis, and luckily we managed him well and he survived. The slide is not working. The slide changer is not working. Yeah, it worked. It worked. Thanks. So this is how we manage canine space infection. We know the intraoral incision, drain it, put a drain there, and leave the drain. Drain may be a rubber drain or a bedrose drain, and then of course the endodontic treatment or an extraction of that offending. There is one space which is very important to understand, the ITA for the infratemporal fossa or the infratemporal space. Now, the medial surface of the mandible, and the lateral surface of the skull base, okay, is the infratemporal space. Now, the patient having infratemporal space involvement would not show you massive swelling. Massive swelling, but the patient is in more grave danger actually. Okay, so you should be able to identify the infection of infratemporal space. And okay, I've been told that I'm probably a little late on my I'll just brush on the other slides. So make sure to the Christmas pain during opening of mouth, lateral deviation towards the affected side, impact the region, and leave which extends down the level of the eyelid. This is one of the extraordinary drainage of an infratemporal space, paratemporal space. I'll just skip all these slides now. Very important, most important, and one of the most, I would say, challenging cases for a dental surgeon to manage. The management of lymphatic angina, I showed you how to drain a submandibular space. We do it on the either side, both the sides, and we may also require central incision here in the submental space area. Okay, the management of areas is also important in lymphatic angina. There are complications of infection as well as surgical complications of lymphatic angina as given in the slide here. I'll just skip this.
स्पीकर जूम नहीं करना
Just my last part of my presentation is fungal infections. As we all saw this COVID era, post 2020 and 2021, there were lots of fungal infections which we had.
स्क्रीन मत कर पूरा स्टेज आना है
This lady from the main address part of the city, and she was referred to somebody to me in Delhi. Multiple surgeries were done, the hospitalization and the mastectomy was done, the patient was having repeated pus discharge. And the CNS physician has revealed that common it confirmed the clear source confirmed that the fungal infection was from mucormycosis or xylosis species. Mastectomy of the left side of the why I wanted to show you this video, today, this patient happened basically after extensive surgeries and life-saving surgery. She had a big defect in the maxilla. This is a post-op maxillary root preserver RA. Almost this entire section was removed, and we had a good prosthodontic team. We had Dr. Poonam, who is also a prosthodontist. He was talking about Dr. Saranjeet in my department, one of my Dr. Nafi, this patient with a good obturator, and Dentistry in my office with smiling with a good obturator. She's wonderful, fine. She has recovered fine and she's happy now. Mucormycosis can actually lead to death also. It's a very fast progressive disease, so constantly on antifungals and surgical therapy is important. So my take home message for this presentation to all here present is the head and neck space infections are common. They are challenge for maxillofacial surgeons, ENT surgeons, and the medical care specialists. All understanding of surgical anatomy advances in radiodiagnosis, pathology, new drugs, extremely important to treat such patients. However, patients should be treated on an emergency basis. Those patients who are medically compromised, the list I showed you, or having a decreased immune response should be treated on an emergency basis by a specialist in a tertiary care center. Airway control precautions is also always be kept in mind. Most common etiology primary odontogenic these infections. Prevention can be achieved by making population more aware of improving dental hygiene, regular dental checkups, and follow-ups. This is my faculty where I work. We have beautiful cricket ground just facing my faculty that inspires me a lot to play cricket. And we had Dr. Pavitra also from KGMC here. Welcome, sir. I have been lucky to visit KGMC and play cricket there also with the common friends. So this is me, my life besides academics and surgery, we play lots of cricket and we are involved in the various sporting activities. And this is also the picture here where we just won the USI Cup, the Association of Acceleration from India Cup, which was won by the state. I was lucky to be part of the team. Responsible to a teacher and mentor, Professor Karan, who taught me surgery and who made me where I am. I would like to thank always for the patient hearing. Thank you, the team CynoDent and ISG for having me here. Thank you so much. So now the technical my presentation.
I think it's such an enlightening and innovative lecture, sir. Now it would be time for us to call upon the stage Dr. Ashish Chandra, sir, Dr. Anu Varadana, Dr. Prabhati Rastogi, sir, and Dr. Masakati ma'am to participate our morning speakers. And we would also like to thank our chairpersons, Dr. Shikha Swami and Dr. Dipesh Saxena, sir, for their previous session chairpersons. I would like to call on the stage Dr. Swami Jyoti Das ma'am for felicitation. Principal, Private Dental College.
साइड से गिरे मैं मारूंगा यहाँ पे।
Dr. Swami Jyoti Das ma'am, Principal, Kalka Dental College. Can we have a huge round of applause, please? Thank you, ma'am. Now, I would like to call on the stage Dr. Imran Khan sir for the felicitation. Professor, Department of Oral Maxillofacial Surgery, Faculty of Dentistry, Jamia Millia Islamia, New Delhi. Thank you so much, sir. Thank you, all the dignitaries. Smile with pride because that unique curve sets the confidence right and an environment right. With this thought, I would like to invite on the stage Dr. Pooja Malik Shairawat ma'am, Professor, BDS, MDS, DWCOI, Prosthodontics and Implantologist, to present her topic on immediate versus delayed loading protocols in aesthetic science. Our chairpersons for this session would be Professor Dr. Malhotra and Professor Dr. Imran Khanster. Very good morning to all of you. It is a great pleasure and a great honor to be a part of such a big event as the 11th World Dental Science Conference. I would like to pay my sincere gratitude to all the faculty members and the dynamic young ladies who are a part of my life. Dr. Manurati ma'am, who has taught me what I am today, to Dr. Ashish, Dr. Namod, and all the faculty members present today, helping us to make this event a greater one. I welcome you all and thank you for being a part of it. Today is a great day. So what we are standing today is because of the great women in our life, both of my mothers. So I like to wish all the beautiful ladies out there, students, teachers, a happy Women's Day. Myself, Dr. Poonam Malik Sarwala, I am a prostate artist. I have done my diploma of advanced dental courses in implantology. And I want to speak about one of the favorite topics of my heart, that is aesthetics. In today's era, everybody wants to look beautiful, especially after the corona times. People want to stay beauty in one go. So there comes in the play of immediate versus the delayed implant placement in aesthetic zone. What is the current concept behind it? Are we losing something? Or we have to change our concepts while placing implants in those zones. Let us study a brief about it. So the topic is a very vast one. I'll try to cover the maximum. As Sir said, Dr. Imran, it's a vast topics are there, but let us make this thoroughly, briefly, and knowledgeable to all the students present here. I'll be covering the topic through two zones, that is aesthetic considerations in the surgical treatment area, in the diagnosis and the surgical phase, and the prosthetic phase, and finally, how the technology has changed and dealing with the case series. What is aesthetics? Aesthetics is basically a theory or philosophy to look beautiful, or beauty, especially with respect to the appearance in the dental restorations, advice in thought and form and color. When we talk about implant success rate, it's not only about the placement, but to study the case well. As just before it, Dr. Imran has emphasized in going through the history of the patient, whether the patient is diabetic, suffering from any future diseases, taking any antibiotics, so there the role comes playing of the diagnosis and the treatment plan. So first, examination, treatment planning, making the past medical history, taking it briefly, planning the case with the help of the dental imaging, surgical planning, prosthetic planning, and finally, delivering the case in the form of the occlusion or function. The long-term stability of an implant success comes in from the goal that we have set it, that is the quality and the safety of people, of the patient, accuracy of delivering the processes, and the most important perspective that changes, that is the time bound program. Because the patient has come today for getting a smile in a day. We are moving towards digitalization. There comes the role of aesthetics to be delivered in a day. Earlier, we used to follow a conventional approach, that is, the implant was placed. We would have closed completely the eyes with soft tissue. Countersink the implant, we would have waited for 3 to 6 months. Put the patient back, evaluated the bone, and there we have evaluated the soft tissue control. And where we would have loaded the implant after 3 to 4 months. This was a conventional approach which we used to follow way time back. Can we have a music? So basically, when a patient walks in the morning, he wakes up or any trauma he faces. Oh my God, what has happened to my throat? I need the dentist. I need to call my dentist. I want to do better. How can I go to the office like this? Man, I am a student. How can I drive? And how can I attend my college hours? But everybody is worried about the tooth that is specifically into the anterior region. So in those cases, we work as the game changes with the technology. So we need to examine the patient well, have to treat the patient both in the ways of psychological, because the patient is affected with the aesthetic demands, and also the missing tooth that is not there. So we need to understand what the patient wants. Here the challenges with the dental treatment arises is that is the length of the treatment time. They reduce the treatment time, so have to fulfill the patient demands in a way. So the current concept says immediate placement in the aesthetic zones requires have better patient acceptability, reduces the treatment time and the interval during the transitional period. Second, always help us as a guide while you're placing an implant. Maintain the soft tissue profile, very important in the aesthetic zone, because while we have extracted the tooth, we have lost the bundle bone and especially the cretinized gingiva around it. We need to look into that. So while we're doing it in the immediate extraction case, it becomes easier to maintain the soft tissue profile. Prevention of the bone loss is what's the vertical in the horizontal direction. So today patient wants from young, demand is the same, aesthetics. From the middle age, again the demand is the same, the aesthetics. The patient wanted to attend a marriage, doesn't want to go back with other two. Though he's in middle age, maybe the smile was not being into the lower incisor, but then he don't want to walk up to the clinic without a teeth. One of oldest lady who wants a perfection in her smile from the buccal part, though there are a lot of occlusal complications that we faced in this case, but then only requirement is aesthetics. I should look good. I should look the same, the natural way. All anti-dentist patient. In all these cases, the common part is aesthetics. So it's not that in every case he needs to proceed immediately. So where to take a call that we need to give the processes immediately, or we need to wait for certain amount of time. So indications include the grossly decayed, non-restorable or asymptomatic tooth where no any peripheral infection is there, complete loss of the teeth with minimum bone loss, teeth with no signs of active infection. Because if a natural teeth has been getting lost because of the active infection, how is the implant heal? We need to give time for those cases to heal out. Presence of the thick and stable keratinized gingiva, adequate healthy growth apical to the extractions of it, which helps to stabilize the apical part of the implant. That is the primary stability that we look into. So where the contraindication, we cannot proceed in those cases. Though with the amendments in the digital technology, in the latest technology, these are not the absolute contraindications, but yes, contraindications in the anterior regions. That is the separation, larger buccal dehiscence, long-standing peripheral radiolucencies, fenestrations, and these are not absolute, but yes, you need to modify your treatment plan in those cases. Thus, to achieve a successful aesthetic results, a good patient satisfaction, implant placement in the aesthetic zone requires a thorough understanding of the surgical as well as the prosthetic principles in those areas. So, from a comprehensive evaluation of the edentulous size must be performed. Pre-operative assessment, that is the diagnosis of the patient's expectations. If the patient expectations are to be unrealistic, you need to fulfill that. Try to understand the people that you are not the doctor. We can only give or fulfill your expectations within limits. We need to explain to the patients what are the limits, what are the shortcomings that we'll be facing during the procedures and after the procedures, and try to lower the expectations of the patient. Even though you can deliver better, but try to lower them a lot. So aesthetic considerations will be starting with the part one, that is the diagnosis and treatment planning. In the diagnosis, we need to first evaluate the implant site structure, that is the bone dimensions and anatomy. mucosa, soft tissue anatomy, and the occlusion forces. Implant sites definitely need to be evaluated because we used to plan the surgery before executing. So in case of anterior region, the bone dimension minimum of the 3 to 5 mm of the bone beyond the apex for primary stability is very critical. Unfavorable or favorable anatomy can be evaluated by the CBCT cone beam topography, or sometimes if we don't have that, we also use OPGs and IOPs. Well, nowadays technology has little bit changed. We have in those softwares that we can evaluate a bone dimension, but that are not accurate. For an accuracy, you need to go for CBCTs. Inadequate grafting procedures, if required, to be planned beforehand. Diagnostic waxer, it is very important to know the prosthetic demand, where the crown will be lying, as we have done in yesterday's lecture. How could we plan the prosthetic part in those cases? When the initial implant placement is done, this is a very beautiful classification that was given by Vivekanand, which describes you can evaluate the bone also with the placement of the tooth. That is, the class 1 tooth is centrally positioned within the ridge. You rarely find those early cases. Regular throat line, plastic throat line, tooth spacely positioned, or thick or facial vertical. In all these situations, we have the different dimensions of the bone, both vertically as well as palatally. Second is the evaluation of soft tissue. With the help of the fluidity, periodontal flow, we need to evaluate the soft tissue. Why it is required? It is required by replacing the implant. We need to evaluate the soft tissue that whether it requires to be the flap to be raised or not. If it is a thin mucosa, we should avoid raising a flap in those cases because as the treatment time passes, I will be explaining it in the further slide why it is required not to raise a flap in the thin mucosa. But first, how to evaluate the soft tissue comfort. With the right probe, we can insert it in the gingival circle so the minimum of 30 grams the force of the pressure. If it is not visible, if it is seen color to the gingival tissues, then it is thin. If it is not visible, we move to the second, that is the green probe, where it is visible, then it is medium. If it's still not visible, we can move to the blue one, where if it is thick, then the blue color will be only visible. If again it is not visible, the biotype is very thick. So we have three types of it, that is thin, medium biotype, thick, and very thick type. So we modify the treatment planning according to the soft tissue profile of the patient. How it influences our surgical procedures as requires to determine the post-surgical recession. The highly scalloped is much less resistant from surgical and restorative procedures, thus slightly more partial placement of the implant to give it is a thick profile, a more good emergence profile. We should avoid that and avoid raising a flap in those cases. Similarly, implants should be placed somewhat more apically to achieve, as I told, that is 3 to 4 mm to achieve a proper emergence profile and avoid. If we go more than 3 to 4 mm, then we end up again in a tragedy of making a ridge restoration. So after evaluating the hard tissue, after evaluating the soft tissue, we come to the functional part, that is the occlusal part. It varies in different individuals. We need to evaluate whether the patient is suffering from any of the bruxism habit. So we need to modify the treatment accordingly while we are giving the restoration immediately in those cases. In fact, their anterior region may not be functionally loaded. RPD should always be avoided because it causes more recession in those cases. Maryland or Essex appliance can be preferred where we need to give a final restoration in a like later period, maybe it takes around 3 to 6 months time. So after the surgical planning, the step 2 comes further. We have now evaluated the bone, the soft tissue, and the occlusal functional considerations. We move to the implant placement and soft tissue management in those cases. We have talked about it. Let us see the implant placement, how we should follow it. Implant positioning is the first step in gaining the prime aesthetic results as it influences both the hard tissue and the soft tissue. Pointer is not working. So here, yes, it's working. here we have two zones. One is the comfort zone, which where we should try placing our implants, and the two red zones are the danger zones. We should avoid placing implant in those zones. How can we avoid doing it? This can be evaluated through the three dimensions, that is the mesodistal, coronal-apical, and orofacial ones. Position involves the three things, especially in case of the maxillary central incisor region. How we can judge with the coronal-apical positioning? It is, we should always try to place 2 to 3 mm. Imaginary line is this is the imaginary which is connecting with the two adjacent teeth 2 to 3 mm below the cemento-nama junction. If it is less than 2 mm, then it will lead to a shorter ground. If it is more than 3 mm, it hinders the proper hygiene. We have to give a contact. Hygiene becomes very difficult in those maintenance becomes difficult in those cases. So placing an implant, it always should be governed between 2 to 3 mm. Imaginary line. This is the okay. Imaginary line is basically the line which connects to the two adjacent teeth. The cemento-nama junction of the two adjacent teeth is there. We should move 2 to 3 mm below it. Mesodistal position, again we look into the danger zone. The danger zone is present on both the adjacent teeth side, that is the root of the adjacent teeth side. It should be 2 mm wide in the back central incisor region. For the natural selection of the gingival comfort, implant should be placed slightly distal. Distance between the two implants, as we know, is 3 mm. That should be the one there. And if we don't follow these rules, then what happens if the mesodistal positioning, it either hampers the adjacent tooth periodontal ligament, the laminar dura gets infected, and patient keeps on complaining you about the pain in those regions. It becomes difficult. And the last third position is the tapioculture or the orofacial position. Then again the comfort and the danger zone comes in. The most important influence of this plane comes when we are placing the restorations. Then it needs to give the angulations in a restoration 30 degree, 15 degree. If we are able to place comfortably comfort zone, in the comfort zone we have to go more palpably. But the palpable direction should be governed. It should be within the comfort zone rather than into the danger zone. If you place it more palpably, then we have to give him a 45-degree angulated process, which is not with having a good abrasives or aesthetics. Moreover, the patient always complains of periodontal problems. Something implant positioning, implant sizing. Implant sizing is being governed with the help of the root. Especially in the immediate cases, it becomes very easier while we are extracting the root. We can measure the root and 2 to 3 mm apically we should proceed with that. This is the general that we have. Lastly comes the implant selection. Nowadays there are hundreds of the companies that have been available in India. How to distribute, how to judge that which company we have to go along with, especially in the aesthetic rooms. So there are again the thread sizes, there are the surface coating sizes, there is the texture and the shape of the implant. Regarding the shape, we should always prefer the tapered implant in those cases as they require minimal grip, and the primary stability in those cases become easier. As we can see the straight right, the thread is going straight. But in the tapered one, it is able to engage it in the less amount of hole and give better primary stability in those regions. So thread going for the tapered screws. The thread should be regularly self-cutting. That is the apical region should have an active thread and the passive thread shall be governed in the coronal part. So self-cutting or the deeper threads, there comes the role as some of the company talks about of the active implants. The active implants threads are actively engaging the bone. Texture, the textures mostly we have titanium surface or the SLA surface with all of the most of the companies, and it increases the roughened surface with the SLA or the surface coating of the implant increases the BIC, that the bone to implant percentage during the initial hole healing. So better also integration and better primary stability. Sizes, as I talked about narrowest, because we need to look into three factors: the biological width. I'll going to take it in the next slide. Platform switching and jumping distance. That's why we prefer going with the narrowest and widest implant necessary. Do not fill whole of the extraction socket. It's not that we have extracted the same root, same diameter. We are looking for the same root length, diameter. No, we have, as we know, when we extract it to the buccal bone get destroyed, and there is shrinkage in the extraction socket that occurs. So we need to give a room for that. That the jumping distance. Beautifully explained about the gingiva. I will not take it into the detail. We need to follow the biological way. As in the natural tooth, similarly, it exists in our implant also. So, any correlation the biological width? Biological width is a gingiva which always allows the lower bone not to come into the irritation part. If any irritation occurs to the bone, we always see the crestal bone loss. The crestal bone loss is related to encroachment of between in and between the implants or the implant two side. There comes the role of the three-dimensional placement, the apico-columnar placement. There the role comes in. So here we need to look into the biological width with the adjacent tooth and with the, in between the two implants. Significance of the platform stitches comes into the role. Platform stitching. What is platform stitching? As it's not like we are stitching the platform from a train from one platform to the other. It's a different view. Earlier, when I started my practice, when somebody used to talk about platform stitching, I was like, it's just like switching one platform to the other. But what's the role of switching the platform? It is the role of it plays a significant role in transferring of the distribution of the load around the implant compartment interface. In most cases, using a smaller compartment over a large size helps the jump in the product. Where we see most of the complication arises of the loosening of the screw is a source of irritation leading to the micro movement, which in turn causes the bone loss. Thus, the platform switching. The insect is coming to be, we are able to distribute the forces around the columnar surface of the abutment rather than transferring it directly to the body. And feel that the drill tries to goes into the socket itself, but we need to taper the drill away from the socket direction. That is the key to success in the apical region. So we need to use as facial cortical plate thin, because facially definitely after the extraction of the socket it will try to shrink. So there we can use a stent if required, or is a very key, I use a round burr. There's a round bar. You can make a purchase point of it and then try to move your first drill little palpably, so that we are able to position it more into the comfort zone rather than into the danger zone.
and the drilling sequence is followed. We have already planned the size, diameter, and the placement of the implant is done. After placing on the implant, definitely check for the primary stability. And if you want to give a restoration, try to give the restoration either immediately if you are doing it more digitally, or within 24 hours, because after the 24 hours the primary stability get jeopardized, and primary stability is only the key which help us to give a better stability in the secondary zone after the 6 weeks period. So primary stability starts from, it is highest in the first week and goes down in the 6 week time, and there the role comes in of the secondary stability. So you need not to touch your restorations or your implant system during this period. Either you can do it within 24 hours, the placement of the temporization you can do, or wait for that period to cross in and then go for the final restorations. As the primary stability, very important factor in immediate implants, ensures no micro movement, because if you are disturbing the implant during those moments, you're always causing the micro movements transferring to the body of the implant, so the healing does not start in. Higher the survival rate, impaired primary stability, jeopardize osseointegration. So the stability surgical trip is, under prepare your osteotomy site, use a tapered screws. Deeper self-taping thread should be used, that is active threads we should use in. Bicortical stabilization, we should feel it, and the lateral bone condensation, which helps in the better bone formation and osseointegration around the implant surface. Soft tissue management. After, if you're raising a flap, supposedly you have decided to give a graft, in those cases, while we are raising a flap, you should always make, to avoid, give a full thickness flap. Try to have a partial thickness flap in those regions. So during the secondary stages also, the gingival margin around the implant can be corrected and improved to a greater extent, but in an Indian scenarios, it becomes difficult to help the patient understand that why we are doing a second stage surgery, that is a soft tissue surgeries. But in the European countries, it's very common that we used to perform for the first stage surgery, the hard tissue surgery, and then the soft tissue. But in Indian scenario, we try to do the both the things together. So lastly, that comes into the play. We have planned the surgical plan. We have done the diagnosis, prosthetic treatment planning. Being a prosthodontist, you must be thinking why I'm talking about the process, because I need to make you understand first how does it proceed. But again, this rule comes in the first part. That is the, as the grabber says, restoration driven implantology. We should focus on that, and restoration driven site development. It helps in the future, it decreases the amount of future complication that you can face it. To always plan your restoration with the help of temporization, or digitally you can plan where is the socket screw coming, where it is buccally placing, or it is lingually placed. You can plan it before the surgical procedures. The cervical contours and abutment selections. In the cervical contours, you need to configuration of the peri-implant soft tissue, which is transferred, look alike. Patient wants a natural look, so try to give the same in the patient mouth. Vital oral tissue through transfer abutments. Healing abutment should able to give support to the keratinized gingiva around the extraction socket. So that's why place it 2 to 3 mm below the extraction site. Fabrication of the temporary abutment can be done depending on the primary stability of the implant, and final abutment selections depending on the availability of the system should be done. So provisional restoration, I prefer giving provisional restoration immediately in certain cases, but yes, depending on the primary stability of the patient, I modify my cases accordingly. So this is a this was given by ITI, that is when to place, when to load. This is a very good classification that you can go through with. And most of the people follow this nowadays. So everything we have planned in, we have done in, but what have changed after Corona? That is the technology. Technology has changed. We have CBCTs, we can do a planning on the chair side with the scanners, we can make a stent and immediately deliver the processes. This is what we have changed with. This is what we have emerged with today. So finally, summarizing in that part, immediate implant loading. Check for the biological factors, patient selection, mechanical factors, soft tissue, implant size, design, and then plan the case well. So with this, I will be having my certain cases which I have been doing at my clinic. Learning is always never ending. So every case is a different, and I try to learn from them and try to improve them if I find the aesthetic demands are not been met. Can we have the music over there? Huh? It's it has to be clicked on. It's not coming. Are the connector of the volume connected with it? Volume also connected with it? So we don't have the music. So basically, this is the male who has reported to the clinic with an endodontically fractured teeth in the region. We planned the surgery well. This is the pre-operative photographs, X-ray. It appears to be very healthy with the buccal mucosa, full keratinized gingiva is present, but we can see the fracture line in the X-ray. So we planned the case, removed the surgical, we extracted the first the tooth and the root and tried to preserve the buccal bone. Here we have taken the depth of the implant that we need to place. Again, I'm trying to place it more palatally. Surgical planning is done, implant placement with the final drill, and this is the implant placed. I have given with the temporization on the same day itself because the gingiva was thick, the primary stability was good. So I've temporized it on the same day itself. So within hours, the patient was happy to take the smile. And this is the post-operative healing after 3 months. We have given the final restoration. You can very well evaluate the buccal mucosa in this region. The fully keratinized and the anatomy of the teeth is we are able to replicate the same in the patient mouth. We have given a screw retained restorations. This is the final smile, close up one. This is the preoperative OPG, immediate, and the final restoration. Final restoration. The case 2, this patient, we modified our treatment because there was a periapical infection. We modified in the processes in this case, though the patient has don't wanted to go back because he was with the maximum aesthetic demand that he has. That's why he has walked in for such a long from Punjab. He has walked in to do the case actually. So we placed the implant immediately. But here, since the buccal bone thickness was very less, we grafted it, we raised the flap, and we were unable to give the patient immediate temporary, though we give the Essex in this case. After 3 months, here we have a compromised thickness and length of the soft tissue. So we need to plan a second surgery since the patient was not convinced. So we have gave a crown with a gingival collar around it. Patient was happy with it also. This is the final smile. Uh, Again, look, it's not there. Huh? Can we raise the volume a little bit? This is another case where the buccal defect was there. That a tooth extraction was done around 10 years back. Patient was wearing an RPD because of which the thickness of the buccal bone was very less. So you've done the grafting those in that case. I've again placed it more distally, and we have given a cement retained restoration in this case. Final smile after 3 months that we have given the final restoration. So kindly bear with me. This one last case. Actually, we are running short of time. This is the last case. This we do it in today with a totally digital protocol that we try to proceed with. Can you play that? Chapo. Huh? You have to play it from that. The small icon that was becoming. Yes, the line that is coming just above it. You have to put the cursor around. Yes, yes. That's the patient has a good, healthy crown actually, but patient was biting from the front, so it fractured. Patient want the similar contour in the final smile as well, so we have taken a pre-operative assessment in that case. Have splintered it. Try to do it with the soft shield technique. We are preserving the buccal plate. Initial drill length has been measured. Extraction, preparing the osteotomy site. The jerk over here, that's the primary stability plate. Healing collar we have placed just to check the placement. And on the same day, we did the scanning. Actually, it becomes very traumatic after removing of the teeth. Patient does not wants to walk off the clinic like that. It appears to be very traumatic to go without a teeth or a smile like that. So we have tried doing with a scanner on the same day itself. Freehand also you can plan with the help of the CBCT. Forward. Little bit forward, yes. It's very difficult to record at the stage because of the bleeding, everything. We need to be very much perfect in the scanning part also. It's not that scanning can capture everything at one go. This is the next day, and we have given him the temporary crown and that. So, what is the clinical or the takeaway message with us? Implant placement loading protocol should be planned prior to the tooth extraction. Alternate treatment modalities should be in place as a part of the planning and the consequent process if you require any grafting procedures. Patient centered benefits should always be taken into bite, but it should not be governing your treatment plan. And finally, the conventional loading is well documented and recommended, but with the early implant placement. Late plant placement is least desirable option in today's era. So, due to the risk of alveolar bone resorption, early loading and conventional loading are well documented protocols for the late implant placements. I would like to thank you, all my mentors, because of which I'm here. I'm my patients, my team, which has given me the courage to speak on this podium with all the knowledge, whatever I have gained through this life. Thank you, everybody.
Thank you for such a wonderful session, ma'am. Framing smiles that matter on a dental journey we share together. Today is Dr. Manu Rathi, ma'am, Senior Professor and Head of Department of Prosthodontics, PGI Rohtak, to present her topic on 3D printing in prosthodontics. Chairperson for the same are Dr. Anamika Sharma, ma'am, Professor, Dental Wing, Lala Rajpat Rai Medical College, and Dr. Swarga Jyoti Das, ma'am, Principal, Kalka Dental College.
This is for the next slide, for the previous slide, and this is the pointer. It is not when the pointer is not working properly right now. For the next, for that things.
Allow me a moment to check the technical connections, please. Good morning, respected chairpersons and delegates. At the onset, I would like to extend my thanks to the Scientific Committee of 11th World Dental Science and Oral Health Conference, and specifically CynoDent, Society of Dentistry, and Subharti University. I understand that we are running a little behind the schedules. I'll try to stick to the time. I will not exceed the allotted time to me and try to catch up for the lost time. I'll take a moment over here to wish a very happy Women's Day to everyone over here and particularly to the women present over here. I understand that the majority of the audience is students. I acknowledge the presence of senior faculty members in the audience. However, I would like to discuss my presentation keeping in mind that the majority of the audience is students. I request the technical team to kindly help how to move the. Yeah, yeah. So this presentation is a brief overview of a technology that is 3D printing, specifically prosthodontic, because that is my domain of expertise. And currently, this presentation, through this presentation, I'll be discussing what is the current status and what are the basic technologies, the printers, the materials, so that it enables the audience to be in a position to decide what is the best favorable availability currently. I'm finding it difficult to monitor over here. So, what is 3D printing? Uh, if we have a look at the contemporary way of clinical practice, that has been the clinical and laboratory based, and laboratory also the manual techniques have been utilized. And primarily, the techniques have been the not the additive ones, but the subtractive ones. First, any restoration is digged out of any substrate of a suitable substrate. However, keeping in view the drawbacks of the subtractive technology, the additive manufacturing has been observed to be beneficial over that because of the obvious reasons of not losing the material, the very costly material unnecessarily. So it would be the best technology which allows us to use the material in the very optimal way, and that is the form of the additive manufacturing. And 3D printing is a type of additive manufacturing. I'm sure that your students are very well aware of the CAD CAM technologies, and that is also a digital technology. However, this 3D printing is one step ahead of the digitalization in the dental practice. In prosthodontic, it has a wide array of applications. But why the technology, or why do we favor the 3D printing? It is specifically for the reasons of customization, because a master's treatment would be which is specified or customized for one particular patient. That is the best treatment instead of giving a very prototype of the treatment. So this technology allows us to print or to fabricate the prostheses which are specifically customized for any clinical situation for any individual patient. And another biggest advantage is the precision. I'm sure any student of the dental practice or the practitioner is well aware of our limitations of dental materials. There is no ideal material. Every material is having a one or the other drawback, and one of them is the dimensional instability. So whenever any restoration is planned from the making the model till the last insertion of the restoration, multiple materials are utilized, from the impression to the model formation, mold formation, pattern formation, and the final fabrication. And at every stage, because of this limitation of the dimensional stability, some errors are or some dimensional changes are introduced. Though we try to compensate for them, but the contemporary dentistry does not allow us to fully compensate for that. And here is the biggest advantage, because whatever is captured at the initial stage, the size, the anatomy, the topography remains the very same till the final restoration. So we have one of the most precise restoration, which overcomes the limitations of the contemporary practice due to limitation of the dental materials in use currently. Definitely. I'm sure anybody who has worked in prosthodontic lab or any prosthodontic restoration, it is quite evident that it is a laborious task. Long working hours are to be spent into the lab. So, through this digitalization, it overcomes that manual labor. Though there might be the time may be the same, but uh, in person spending the time is not. Once the command is given, then the person is free to attend to the other duties. So that's how it improves the efficiency and speed of fabrication of any prosthetic or the any dental restoration. How this is transforming when we compare it with the traditional methods. Definitely the contemporary methods are labor intensive processes, and it is more of, we may say that it is a automated one, not the fully one. There are human interventions required or human interface is required, because in the treatment planning and execution specifically, but the laboratory part is more or less automated alternative, and definitely the outcome is more precise. But dear students, don't take it that it will be precise if I'm using it. It will be precise only if the human interface has planned it precisely. So this technology can be utilized to form a variety of appliances range. See, currently it may not be covering the all of the restorative modalities, but majority of them can be fabricated, and it finds a wide application into the field of dentistry. Materials also, we have certain materials available because the for 3D printing restoration we would be requiring printable materials. And dear student, there's a lacuna that printable materials are not a part of the curriculum if we see the science of dental materials. However, if we see practically, there are certain materials which are printable, and medical grade printable materials are available for application into the for dental restorations. So moving to seeing the am I directing it at the, please correct me if I'm not using the pointer correctly because I find it difficult. Do I have to point to that side? Thank you. Thank you for that help. So now to understand first, what is the technology? And then we will to know what are the different technologies in use that will enable us, this understanding will enable us to pick up which one is more suitable for my this clinical condition. Currently, see, printing is in use. I'm sure everybody knows about the 2D printing. They are there since before the birth of all of us, the paper printing. However, 3D printing, what different technologies are there? A few of them I'll be discussing each one by one. Fuse deposition modeling, FDM, stereolithography, DLP, selective laser sintering, multijet fusion, and electron beam melting are few of the technology which find their applications into the medical field. Yeah, I'm lagging behind this. I think I should speak like this. Yeah. I didn't want to face it. I wanted to face the audience, but I think this technology is not allowing me to address properly. Yes. So picking up what are the basic technology in 3D printing. First one is the SLA that uses a laser to cure the layer of the resin, creating a precise and the detailed parts. And this gives us a very high resolution outcome, and it has the ability to produce the complex geometries with the fine details. I'm sure this video, if I can play, kindly click on the play button. Yes, dear student, over here, in contrast to the conventional fabrication techniques, there is a printable material that needs to be printed or activated. The source of the activation could be different, and the printable material is cured in, if I may use this word, cured or printed in a very thin layers, and layer by layer the geometry of or the topography of any structure is developed. And there could be a different source of curing. However, the precision of this restoration will depend how fine layers are finished. If the layers are going to be quite thicker, then the outer geometry or the surface will not be very fine. So you can compare it. If the pixels are smaller, we have a very fine picture. Same way, if that these layers are very fine, in that case, we will be having a very smooth surface structure that will require less of the finishing. And in addition to printing, though I said that it is an additive technology which utilizes the material to print only the required restoration, but it is not truly so, because in during the process of printing, some amount of the support structures are also required. So another form of the technology utilized is the selective laser sintering, which is a powder-based technology. Over there, um, the material, the printable materials comes into the different forms, maybe in the liquid form, powder form, or in the filament form. And depending upon the type of the material, the suitable printer is picked up, and a suitable activation or printing technology is utilized. SLS is a powder-based print, and it uses a high-powered laser to fuse the small particles, and this also gives a reasonably good surface details and fine restoration. Another is very more commonly utilized technology is the FDM, that is the fuse deposition modeling. And this utilizes the extrusion process. Extrusion means, and the material utilized for this technology is a filament. The filament is moved and it is softened, and then the it is cured in layers. This is one of the more common type of the technology utilized in 3D printing in dentistry. Next is the digital light processing or the DLP technology. And it uses a digital light projector to flash a single image of each layer across the entire platform at once. And it also enables a rapid printing of highly detailed parts. Another technology which is available is multi-jet fusion or MJF process. This utilizes a power fusion technology and uses fusing and detailing agents applied by a printhead combined with fusing energy from a heating element to produce the functional part. It offers the advantage of the speed, precision, and the ability to produce a very strong and detailed parts. So just briefly about what is the process of 3D printing. So we know what are different types of technologies. It means rest all will be depending upon any of this technology. All the printers and the materials will be following any one of the technology. So what is the generalized process for fabricating a 3D printed restoration? First is it will be easy to understand that if we compare it with the conventional one. So what first one is the design creation. It is comparable to the pattern fabrication stage of any restoration. So first thing is that we have to have a model, but here the model is also digital that can be utilized from the scanning. And after that, the planning of or the designing is also done in a digitalized way. Computer aided designing, various software are available which give us a freedom to design or customize the restoration according to the requirement or the clinical conditions of the patient. And after that, this digitalized model is there. There's nothing manual or in hard form is there. So this digitalized form is to be transferred to the lab. This transfer is also in a form of digital format, but that format has to be specifically the STL format. Only then the printers will accept the digital data only in this format. So this, after planning it is converted into the STL file. And after that, printer will accept the STL file of the designed restoration. Then we have to decide what material is to be utilized. Current status of the availability of the material is quite limited. However, the benefit from prosthodontic point of view is that one of the very most commonly utilized material, the polymethyl methacrylate, a medical grade printable PMMA is available. So that serves a purpose of wide variety of the restorations. And after that, once the material selection is there, then for printing, we have to customize the parameters for given to the printer. It means what would be the layer height of each curing layer. This is one of the most critical one because this gives a very precision to the surface. Infill density, because like restoration, generally the outer anatomy is important. We might keep the inside content of a restoration maybe hollow or less dense. That has many advantage of like reducing the weight of a prosthesis. So this technology gives us this advantage of making up restoration hollow from inside with very conveniently in a very convenient manner, which is a very cumbersome lab process in case of the conventional prosthodontics. Also, the print speed can be decided, though it is not fully in control of the operator to decide. Otherwise, everything we would like to do it in a click of the mouse. However, to some degree, there is some leeway or some control over the print speed is also permissible. Hope the slides are not changed. I'll have to keep. I'm so sorry for this technical gap. Yes. So after,
You have to find.
where do I have to?
I'm towards that mirror.
Okay. Okay. Which mirror, dear? This side?
Control.
That side. Okay. I'm really sorry for the technical hitch. Yeah. So once the designing is decided and the command is also parameters are also decided, another critical factor as I discussed was the slicing the CAD file. This slicing will determine the thickness of each layer. Also, that will be reflected in the speed of the printing. And it is observed that the more intricate is the design, it takes more time. Even a smaller design of intricate design would take more time as compared to the bigger design of a very simple shape. After that, the layer by layer building is done, and this is the additive manufacturing. Yes. After processing as contemporary, the final step is the finishing. Same way over here also. Another step is that printing is done, as I discussed earlier, also not only of the restoration, but certain supporting elements have to be there because of the varied shape. More diverse is the shape, then the also we can control the number of supports also that will control the printing speed. However, certain minimum number of support are required so that we can have the economy of the material as well. And after the completion of the printing, these support elements are removed and surface is modified. Surface is checked for the its quality, and the final product application it is finished as the conventional manner. So this is in general what is the process of 3D printing. And however, currently there are certain challenges in the 3D printing. The resolution limit is one of them, and a high resolution is necessary for the detailed precision and smooth surface finishes specifically required in the intraoral restorations. 3D printing is an established technology in the industrial field. However, in the medical field, we require more of the precision, specifically in the dental field. Material property, as I discussed, there are not much in availability of the diverse materials with the diverse properties. Like one of the limitation is the color of the material. We don't have many colors available. Also, the mixing of the colors for single restoration is not permissible currently. Same with the mechanical properties of the material and customizing and fitting. The production time and the cost is one of the factors. Also, the 3D printing applications into the prosthodontics specifically or in dentistry in general are not regulated by certain regulatory standards. So the standardization element is not very robust. I think it's the volume low. Could you please minimize it? Yeah, minimize it. I'm so sorry. Yes, I would be sharing few of my personal cases which have been done. Yeah. So, 3D printing is applicable and currently in use in a very range of prosthodontic restoration. Complete denture is one of the very commonly utilized restoration, and it offers a very more efficient workflow for fabricating the complete denture. And in case of custom implants and surgical guides, the 3D printing can be utilized to make a very precise surgical guides. I think previous authors also speakers also mentioned about the implants. A great degree of precision is required, and it would be best that there is no dimensional change in the treatment planning in the mock surgery, and we execute actually clinically. So this printing technology offers us this advantage, and not only printing the surgical stents, because we have a technology at a click of the mouse. So everything mock surgery, the whole model, the prospective surgery, planning of the stints can be done in a designing stage in a digitalized form, and that can be varied to see what is the best treatment outcome for the patient. A few of the cases, I will just go quickly through the cases. This is in case of the overlay denture. This is a young boy. He came to me when he was 3.5 years old, and now he is 17 years old. And in this, it is a case of enodontia and the mandibular arch and the partial enodontia in case of the maxillary arch. For this, earlier he patient had the experiences of multiple conventional treatments since the age of yeah very young age, and now since over the past he is a patient for over the past decade, so the technology has developed, so this was utilized for this patient. Digital impressions were made and digital jaw relations were carried out. Yeah. So this was done, fabricated, two-part processes was fabricated, and those were then joined, and this was the final fabrication inserted to the patient. This is a young patient in which there was a uh, case of the cleft, and the nose was like not. The plastic surgeon has referred this patient for the nasal stent, and in this young patient, we had to make the intranasal impression to a depth could not be made, because this one of the limitation of scanning is that we cannot pick up till the depth of the restoration. So the intranasal and the extranasal impressions were made in the conventional way. However, further the processing was digitalized and the impression was scanned. It was convenient to pick up the surface anatomy, and this designing was done in the software, and this gives us a very convenient way to design it. Specifically, the main challenge for the nasal stent is the centralization of the nasal patency and orienting it appropriately so that the lung growth of the child is not affected. So we could conveniently align the patency and with minimum thickness of the prosthesis, and when it was fabricated and inserted to the patient, it gave us a very balanced outcome. This is another case of aesthetic rehabilitation of the anterior single missing tooth in a young crown through a Richmond crown. And in this, the yes, intracanal, the tooth preparation was done. However, the because capturing the intraradicular anatomy through the scanning is a challenging task. We don't have the currently highly sensitive scanners which allow us this. So a conventional impression was made. However, impression was scanned and the digital model was created. And after that, the designing was done as per the requirement of the patient, and the it was the Richmond crown was cemented and patient was rehabilitated. Definitely saving some time of the patient was one of the greatest advantages. Another case of simple case of cantilever FPD in case of the aesthetic rehabilitation of the patient. Over here, the tooth preparations were done. 1112 and 21 were affected. And here, picking up the intraradicular anatomy was facilitated by use the reamer, utilizing the light body impression material and backing it up with the heavy body. The composite impression was picked up, and then the digital model was obtained, and picking up the PMMA, and the restoration was fabricated and inserted. So it gave us a reasonably good, I won't say it gives the best aesthetic results, but a reasonably good aesthetic results. Some of the extraoral prosthesis fabricated is through the finger prosthesis, patient having a defect of multiple fingers over here, and the anatomy of the over here we have scanned. If I go to the previous slide, over here we have scanned the model of the patient's hand, gypsum model. However, here we can combine the intraoral scanning with the extraoral scanning. That is also successful. Facial scanner can be utilized to scan the hand of the patient, and then I'm not changing it. Yeah. So after that, the designing was done, and it designing was in maxillofacial is specifically helpful because manually designing it is a very cumbersome and a lengthy process. So in the digitalized process, we could make the changes very easily. And for this, a surface mold was created because capturing the surface finer details of the skin of the hand was one of the challenge. And to make it more aesthetics, mold was fabricated, and the processes was finally fabricated. One case of the complete denture, digital denture. For this, yeah, limitation regarding the impression making remains there, because for the any mucosa borne prosthesis, we have to capture the anatomy in a very composite support, and the pressure control is not there in digital scanning. It can very well scan the hard tissues, but the soft tissue compressibility is not captured. That's why the conventional impression was made and the models were scanned, and after the jaw relations were taken, sorry, and teeth arrangement was done virtually, and the denture was fabricated. Currently, there is a limitation, as I discussed, limitation of the mixing of the color. That's why the white tooth portion and the foundation tissue in the pink color cannot be printed together. They are to be printed separately and then joined. Briefly, uh, so these are a few of the cases which I've discussed. Finally, how do we see it in the current scenario? What are the strengths of 3D printing? So it provides us the ability to produce a very highly customized dental prosthesis with a very quick turnaround. It saves times. Time is everything. So that is the biggest one of the advantage, and accurate fit also, because that remains the challenge to any dentist. Also, there is conservation of the material and reduction in the overall treatment cost, this being a additive technology. However, there are certain lacuna also, because the significant investment and the equipment is required, and there is a definitely a very long learning curve. I can see that initial my few of the patients I had to redo. The redo rate was very high initially, but definitely it goes down with time or with more of a learning. And opportunities, this is here for the budding dentist and those who are with a curious mind. So there could be like one possibility, if some in office printing solutions are available, that could be wonderful. However, as I discussed, there are regulatory hurdles. Currently, there is no legal or the statutory or regulatory control over it. So it is quite liable to go hayway till the time standardization is achieved. And integrating the printing into the curriculum, though it is currently 3D printing in dental practice is in use, but it is not in training part of it. So if it is included in the training, that the training will become streamlined, and that will be helpful, because it seems that in the it will be a part of the practice in the current future. And how can we prepare for this transition? You all will be practicing this after say couple of years, so we have to prepare for this. How can we achieve this transition? We have to be practice readiness has to be there. Some budget allocation should be there, and comprehensive training for the staff, not only the dentist, everyone, so that the staff is prepared to take up this technology into the practice. Patient education also, because if a technology is available and the patient is not aware, it is of no use. Nowadays we see that every patient knows about dental implant. 30 years back patient didn't know about it, but now they are aware, and they ask, when they come they ask for it. Similarly, no patient, I hardly see, less of the patient maybe in my practice, that they don't come up, say they say give me some digitalized restoration. So it is part of our profession to make patients aware about this digitalization and newer technologies. Only then it will come into the practice. That way we can prepare ourselves for this applications of the future. So another word, what can be the directions for the future? This I talked about the 3D printing, but the future application could be the bioprinting of the personalized implants. And definitely there has to go side by side industry growth into it to support this practice. And the future direction could be, though it seems to be not to be a near future, but definitely a distant future, which is bioprinting. That is, means now all of you have done yourself the 2D printing, you know about 3D printing. Then what is 4D printing? 4D printing would be, then it will be when it is a biological component is added to it. Instead of printing the materials, 3D printing I've talked about non-vital materials. 4D printing is when it is a living material is printed. Means here there the living cells are incorporated into the scaffold, and they are utilized at a lacuna or wherever a restoration is required. But it has its own challenges also, because cells have to be living into that scaffold. Here we have bio, for 3D printing we have materials in the form of powders like this, but for bio printing we need to have bio inks with the living cells in them, and they have to be. And another challenge is that, because oral tissues are not actually tissues, rather they are organs in itself. Complex structures are there. So not that one type of tissue is to be printed like a skin or mucosa. There is a complex, multiple tissues are to be printed, are required for dental structures. That's why it is more challenging to bioprint the oral tissues. And in if we talk about bioprinting, a newer dimension would come into place. 3D printing is means three dimensions in space are printed. But over here, when living cells are utilized, then their behavior in the time, varying with the time, how the cells will behave at one particular time, and later how they will behave, maybe there will be differentiation. So some signaling happens at a time dependent way. That's why that is the 4D dimensions of the printing. That is the future, that is for the young budding dentist to ponder upon this idea. I thank you all for your patient listening, and your queries are welcome.
Thank you so much for this wonderful lecture, ma'am. It looks like dentistry, but is more of an artistry. And with this thought, I would like to invite over our next guest speaker, Dr. Gurkirat Singh Sir, Professor and Head Orthodontics, Sudha Rastogi College of Dental Sciences and Research, Faridabad, to present on his topic, aligners. I would kindly request the audience to please give a round of applause for Sir.
Thank you so much. It's great to be on stage, especially at Subharti. I have a long association with Subharti. In fact, I did my first course, conducted my first course at Subharti. Can I have the slides, please? This is the problem with technology. It's very easy to adopt, but very difficult to implement. And Dr. Manu Rathi, you know, explained about it. A lot of failures initially, but in due course of time, I'm sure we get the hang of it. So as we get over the technical difficulties, let me carry on. I think so. My topic is rather very simple because it's a new buzzword. The generation that's sitting at the back is the young generation, and this generation is the selfie generation. I call you guys the selfie generation because you spend more time on the screen as compared to uh, paper books or magazines or whatever. But because you guys are so much on the screen, you take a lot of selfies, and a social platform makes a lot of difference in your lives. In our lives, it started making a difference, but very late in our lives. So, since digital world is the new buzzword in even in dentistry, and Dr. Manurati established that quite a bit. Pen drive is with you. I think they deleted my presentation. They said, cut this guy out. He talks too much. So the in thing today in orthodontics is aligners. Everybody's talking about aligners. Why? How many of you have actually had braces put? Yeah. Anybody wants to put braces again? That's the question. That's very important. You see, what happens is that nobody wants to put braces again, and that's why we are talking about aligners today. And I always put up this slide, and it's a quote by Lord Buddha that whatever I say, don't take it as the gospel truth. Make your own assessment in your own world, in your own practices, learn, relearn, unlearn, and practice what works for you. So, what works for me might not work for you, and that is the universal truth. So, I have spent, I think, 18 years of my life here on the first floor. I know each and every chair in which the water comes, in which the water doesn't come. And a lot of you might have gone through this if you have spent some time in the library. I did never sell the digital rights of this book, so you will not get it on PDF. And yeah, I mean, I'm 32, but my experience in dentistry is 25 years plus. Very difficult to change. Started dentistry very early. I was into the 3D world much earlier than quite a few people. Smuggled my first 3D scanner, intraoral scanner, into the country, and told the custom guys that it was a gun for my toy gun for my daughter, and they accepted it. That time it was 28 lakh rupees. Now you get a scanner for as less as 4 and as much as still 28 lakh rupees. So basically, I'm here because of the passion of aligners, and I'm sure that this technology is going to be there to stay. And the earlier and more you know about it, the faster you will involve it, and the better you will have an understanding and explanation to the patients that you're going to treat. So, what are aligners? They are basically removable, invisible, no dietary restrictions. They are bracketless, wireless, no impinging, no breakages. You can use them less. Uh, you can lose them also, but they are as expensive as diamonds. So you better not do that. Okay. Um, what are the processes involved? Basically, involves a scan or a good elastomeric impression, followed by its simulation is prepared. Then the simulation has to be approved by the clinician, and then you fabricate your aligners depending on the two techniques that you have. I'll describe them in very, very short detail. And of course, the most important thing with any removable appliance is patient compliance. So if your patient doesn't wear it, it doesn't work. So unlike what can be cemented or what can be bonded, this is patient-driven technology only. So a lot of companies don't get waylaid by the companies and the brands because everybody has a charge and everybody has a margin. So some will give you discounts, some will not, some will have short turnaround time. Don't get carried away. The most important thing is understanding their technology. And there are a lot of softwares which you can use. Some of them are pay per use. Some you can actually buy and put it in your own comp. Some you can use only on the internet. Everything is there for you to learn from if you decide to learn. So the choice is yours. This is what a presentation look like. Could you play the video, please? So this is what a simulation is. Could you play the video, please? Yeah. So this shows you the number of steps, the movements that are taking place, and everything is basically science driven. Try to understand one basic fact. You create space, you can move a tooth by applying force. The force might be used, can be produced by plastic, elastic, wire, night eye, stainless steel, TMA, that depends on your choice. Okay. So, but if you do not have space, if you do not plan your case, I'm sorry, you cannot achieve results with any orthodontic appliance. So, your knowledge is the key. 3D printing, ma'am was talking about. These are very good 3D printers, especially for aligner models. You can print your model, step models to fabricate something like this. So you get these models, and on this, you actually do a pressure molding or a vacuum forming and make, this is all in every department. I'm very sure that Subharti has one of these machines. I've been there very, very frequently, and I'm very sure that they have multiple machines actually. So what is more accurate, vacuum forming or pressure molding? So pressure molding is definitely more accurate because you are actually putting pressure and the material is actually sinking into your model. So pressure molding gives you a better grip, a better attachment, and that is why the anything that is done by pressure molding will give you better corrections or it will follow the results more closely to what you have planned. Once you've done that, then comes down to the materials. So there are up-team number of materials. A sheet starts from about 20 rupees and goes up to 450 rupees. So some things are positive, some things are negative with each material. And now what we are using is a combination. And also now you have 3D printed, direct printed aligners using this material called TC85. Okay, the first CE marked product which is available and it is FDA approved. So that's very, very unique, very new in the market, but it is there. So what is the positive versus braces? Of course, you can start the treatment anytime you feel like because there are two different arches. You're not, if you have a deep bite, you can't put braces because of course the upper teeth will hinder the braces. So nothing of that sort. It prevents chipping. Your patient has a boxing match, you don't have to remove, whereas you can't wear braces and go into a boxing match. Common sense things. What happens post your bite? You will get some amount of open bite with aligners because of the thickness of the materials. You get some intrusive forces. Whenever you put anything in your mouth, you will tend to bite more frequently, even if it is a night guard. And anybody who's wearing a night guard, I'm pretty sure some of our people, the front benchers who have a lot of stress because of the back benchers, I don't know. But this is very common. I carry a night guard because I do get stressed and I do bite. And that stress can be generated not just by the students, but also by the patients. And people in private practice know that the patients in, uh, NCR are very, very finicky. So overbite increases, overjet decreases. You can play around with the mechanics, which is very, very simple. But always remember that what you plan is not 100% executed. What did your parents tell you? Try to score 100 and you will get 90. So here, the percentage might vary. You might try to achieve 110 here because you want to achieve 100 here. That is what the patient expects from you, because you're not selling a Maruti, you are actually selling a high-end Lexus car. That's what the difference between conventional braces and aligners today is in terms of costs, mind you. What about correction of deep bites? Deep bites can be difficult to correct. Extrusion of posteriors can be difficult. So certain movements are easier, as with any other orthodontic appliance. So when you were doing back tipping was very easy. When you were doing edgewise bodily movement was very easy. And now with aligners, we need to know what are the strong points and what are the negatives. So let's go down to real thing. The first question I asked those guys who wore braces: are you ready to wear braces again? No. If you don't want to wear braces, then aligners are for you. So this is a case that came all the way from Pune. And trust me, dentistry in Pune, Mumbai belt is far better than it is in northern India. I'm sorry to say that, but it is the unfortunate truth. So she had minor relapse. She's an all four extraction case, but she had this minor relapse, and you can make out, a lot of things happening, a bit of crowding coming in. It's not a bad finish anyway. You look at the molar relationship, everything is well settled, and she looks good. So I don't want to change anything in the face. She comes in and look at the date. It's February 1st. I take all my records. That includes a scan as well as x-rays that we require. Can you play the video, please? And this is what one of the companies that I work with sends me. So they actually send you a kind of a video of what is likely to take place. And it is pretty neat because you can actually see it in all planes of space. They show you a pre, they show you a post. So it depends on what you're looking at. So what you need to do is you need to spend more time in front of screens, because you need to be sure that what you are trying to get or what the company is supplying to you is going to meet the demands of the patient. So that's where the screen time is so important. So you'll not be spending chairside time, but you'll be spending screen time. So they gave us this kind of a simulation. Everything is good. We do some IPR. We have some attachments. There's small composite blocks that we put, and then we delivered the aligners. So it took us 21 days for the aligners to come through. Now the turnaround time is less than a week. So things have become much better. And there are still some companies which take 5-6 weeks. So depends on whom you are working with, that matters. And we did this, give the whole box of aligners. These are sequential and they are serial ordered, numbered. So we gave the whole box. The patient went back to college, and this is the photograph with some IPR here. You can make out I've done some IPR next to the lateral. That's just to create space. Like I said, always create space, then move teeth. And then she comes in exactly 6-7 months later, and everything is done. I'm lucky here. Please don't think that this happens in every case. It doesn't happen in every case. So all I did when she came in was put in my bonded retainers, say thank you, ma'am, collected the balance fee, which was hardly anything that was left because I carry most of my burdens I take earlier. And once you're done with that, she's gone, and she hopefully will never come back. Okay. So this is how simple aligners can be. So when somebody tells you, uh, that why should I get aligners? The convenience factor for the clinician is very important. Don't forget that as you grow older, the time becomes very important, because you want to spend time doing certain other things, spending time with some other people in your life whom you have ignored. Um, some of us have ignored, and you need to catch up. So that catch up time is given when you spend less chairside time. So this is how we finish this. This is post retention. She came in 2 years later. She had broken her retainers, so you can see some relapse there. But overall, she's good. This is another case, class 1 dentition with tongue thrust, generalized spacing, peg laterals, and the patient did, uh, is a he's working in the government services, very high post, doesn't want anything to be visible. Uh, got these, You can make out that there's a certain amount of open bite because of the thickness of the material. And this is how we finished. So if you plan right, if your patient is compliant, you will get results. So if somebody tells you that the results that you get with aligners are not as good as with braces, I'm sorry to say it depends on the practitioner, on the clinician as well as on the patient. So when we do braces, part of our treatment is in the hands of the, most of our treatment is in the hands of the clinician. But when we put aligners, a lot is in the hands of the patient. So how compliant your patient is, how motivated your patient is, matters. So this is what it looks like. I took a managed to take a close up. So look at the finish. It's as good as any braces finish that I give, which I was taught. Unfortunately, aligners were not there when we were students. In your generation, you are lucky. You are exposed to implants as well as aligners, and we were not exposed even to implants earlier. So this is what the patient looks like. He's very thrilled, and I think his wife is even more thrilled because she didn't like his gaps. So there's another case. I'm showing you, I'm going slightly from simpler cases to some tougher cases. Maxillary arch with midline diastema, again peg laterals. He's a class 3 case. I'm using this case as an interdisciplinary case because it will be of more interest. So you see, this guy is only bothered about the midline diastema. And you can make out this peg laterals. He's got a class 3 tendency. So, when the orthodontist in me takes over, he says, I want to take your lower arch back. I want to put in some tads. I want to take out your third molars. But the patient sometimes really doesn't want such extensive treatment. He just wants that midline diastema to be closed. So I said, okay, I'm going to close the midline diastema and I'm going to get the laterals built up. So if you want to build up the laterals, 3 things that you can do. Composite, always a green thing, has a shelf life in the sense that it will get some crazed lines or it will get some discoloration over a period of time. And then you have something called componeers, which are preformed composite veneers. And then you have ceramic veneers, the most expensive of the lot, with a much, much better lifespan. But the patient had already spent money on aligners. And this is, of course, we take records for all our patients because of medical legal reasons. You better have your records. And the next generation, please have your records because there'll be people like us in panels and they will be after your life if you do not have the right records and consent forms from your patient. So this is what we did, gave aligners, and this is what we finished with. And you can make out, we gave 2 componeers here on the laterals. They are prefab composite veneers. You just prep the tooth very, very lightly, etch it and bond it with flowable composite and shape the veneer as it comes. And the bonded retainer is very important. Don't forget the bonded retainer. You always need to have a bonded retainer for all the cases that you have orthodontic cases. And this is what it looks like. This is 2-year follow-up. You can make out some amount of gingival, inflammation is there. We need to polish up the teeth. But otherwise, the malocclusion correction is perfect. So results will be stable as long as your retainers are there, your planning is right, and your patient is compliant. So this is what your patient looks like. He's very happy, thrilled with his treatment. And incidentally, I treated his wife also. So with a different appliance, of course, but they got married because they met in my waiting room. And after that, I had to change all the lights in my waiting room. It was giving that dingy feeling, romantic. So it depends how you want to practice, actually. So this is what he looks like. Pretty smart guy. Now he's based in Singapore, and his wife is was teaching for the British school there. Specific intrusion of extruded mandibular anteriors. So look at this smile, okay? So I wanted to, she has a short upper lip, so she's going to show a lot of upper gum. But she was very bothered about those 2 rabbit teeth and a bit of deep bite that she has. You can make out, you can hardly see the lower teeth. They are in a pretty bad shape, a lot of supra eruption of the lower anteriors. So when you have cases like this, you can always combine things, you don't have to be very exclusive with the liners. So I started with the liners. We got everything sorted. We got the crowding corrected. You can make out lower crowding is like good 4-5 millimeters. We did some IPR, did some expansion in the lower arch. And at a particular stage we reach, and then we realize that upper arch is almost done. And this is where she's, and majority of my patients are very compliant. I select patients only where compliance is guaranteed. If it is not guaranteed, I charge 100% cash down. So my money is sorted. They come or they don't come, they wear or they don't wear. It's their call. Okay. And this is where we reached. Everything in the upper arch is more or less going as per schedule, but the lower supra eruption of the lower anteriors is very difficult to correct with without flaring. So you can always flare them and do a relative extrusion or intrusion, but without flaring, it's difficult to achieve. So this is the 6th month, and what we did is upper arch was done. We went ahead. We put for one appointment. We put one wire and 12 braces. Okay, and see what happens after 3 months. Everything is sorted. See the bite opening, see the amount of deep bite correction, see the alignment. So sometimes braces are, don't forget your braces. Old school, yes, but lower arches, usually patient doesn't mind wearing part-time braces and they work. And this is what she looks like. She's very happy. She's thrilled. And this is the difference that we made. So look at the time frame that we took. 8 months, out of which maybe 2.5 months was with only lower braces. Rest everything was done with the liners. So the patient could attend or be available for any social function without being burdened with braces and having a wire poking or breakage of brackets, which usually happens with orthodontic therapy. Deep bite along with fixed braces and tags. So class 2 div 2 classical, very difficult. This is one of the earlier cases that we did. I think this is 2014 when we started this. This guy's a model. Uh, he flies in from Jammu, comes to Delhi, gets treatment done, flies down to Mumbai, comes back on the way, and that's how he is. So I said, see, I've never done a case. By that time, I'd never done a case of such deep bite in 2014. Now, of course, we do on a regular basis. So I told him I need to put braces for a couple of months. So you decide when you are relatively free, when you don't have any assignments, and I'll put braces and I will actually start with aligners as soon as possible. So he gave me a time frame. He came to me. Uh, of course, these are of some relevance, but we are talking about only treating the upper arch. So this is what we did in Feb, and we had 3 months or 2.5 months, something like that. So I put in these tags. There is a intrusion force from the E-chains to intrude my incisors. Part of it is going to be relative intrusion because I'm going to flare my incisors. I do want to flare my incisors. And we reach just one wire. So you got to be very careful of how you do it. So this is March. And at this stage, we just took impressions in April. And by May, he was on aligners. So majority of my correction, the difficult movement was the intrusion of incisors, which was managed using tags and bonded appliances. And coolly, we managed to go into aligners and 5 months of treatment, and he was done by November. So this is August. You can make out some attachments there. And this is November, and we are done. So always remember any deep bite case, the retention protocol doesn't change in orthodontics. It's long-term retention with an additional anterior bite plane, nighttime wear, and patient's occlusion is perfect. Results by the grace of God and his compliance and some amount of planning by me are fine, and you can make out. We can just carry on with cases like this. This case is very dear to me because for once the father of a child came and said, I want the most expensive appliance that you have to be worn by my daughter. I love such parents. This was the condition. She was technically a class 3 skeletal pattern with everything happening in her mouth. Divergent, convergent roots for the centrals, crowding, spacing, rotations, class 3 tendency, growing child. Now, this is what is important. Okay. How you tackle these patients. So, my only question is I will take anybody's money, but if I do not deliver the results, I'm the worst dentist in town, right? So I have to be very sure that the patient is going to be compliant. And she was a model patient. Trust me. Whatever we gave her, she wore it. This is where the aligners come in. And she wore it very, very diligently. She's on the 13th now. This is the stage when we realized that the upper incisor was, the right incisor, central incisor was extruding. So we took a refinement scan. We gave her the aligners. And this is the refinement stage. And this is how we finished. If somebody can tell me the difference between this finish vis-a-vis braces finish, in my practice, both results will be same. It doesn't matter which appliance I use. The finish is given by me as a clinician. So if there will be no difference, and there should be no difference. So if somebody tells you that aligners are superior to braces, no, they are not. Some ways they are more convenient, yes. But are braces giving the same results as aligners? Absolutely yes. Certain malocclusions will be difficult to treat with aligners, and certain malocclusion will be difficult to treat with braces. So you are the clinician, you have to make the choice and guide the patient right. This is how we finish. This is September, and you can make out the difference. The root position, the root parallelism, everything is sorted. So if somebody tells you that, you can't correct roots, you can't correct deep bites, they are lying. They have not used the braces or the aligners properly. This is the last case for the day. This is an interdisciplinary case, and that's why it's here. So this gentleman came to me and he said, I'm going back to Riyadh and I want my teeth fixed. And look at his teeth. Yeah. He's got everything, a congenitally missing tooth, a canine, a peg-shaped tooth, the works. So I discussed this case with my endodontist and she said, Guru, I can't do anything unless you give me an overjet. If I put a crown or a veneer, this guy's just going to break it. So I had to distalize the lower arch. Okay. Only the lower arch is the criteria. And that is why you can see, and of course, the discoloration is fantastic. I mean, the teeth look as if he just had pan and come back. So this is, can you play the video, please? So this is again a way of showing to the patient what is going to be done. Could you play the video, please? Just click on the slide. Hello. I think I put them to sleep. This happens sometimes. So anyway, basically the lower teeth will go back. Nothing that you need to be worried about. We'll have to do some IPR. And this is what we did. And we realized 3 months down the line that teeth are not moving the way we wanted. So we did some more IPR, put the patient on refinement scan, and we managed to get this result. So there's a good 2 mm overjet and overbite is near perfect. We did some composite work, not composite, these are ceramic veneers and crowns. We prefer crowns over veneers sometimes, especially when you have a peg lateral. So this is where it is. Some monolithic crowns are put on the lower molars. And look at the change in the smile. And when this guy came actually for the final photographs to my practice, he had got a hair transplant done. So you cannot imagine the kind of transformation that you actually do by improving patient smiles. So this is the difference. So if you show this to a dentist, yeah, you know what is wrong, what is right. But when you see this is what the patient sees. Don't forget, in a public view, the patient sees only his smile and not a close-up and an intraoral view with retractors. Okay? And he's super happy with his smile. He's referred more patients to me than I think quite a few of my patients. And practice only picks up when you have referral of patients. We'll sometimes lecture on practice management tips. To conclude, very simple. Diagnose right. Your patient deserves it. So if somebody tells you that diagnosis is not important, trust me, till date, diagnosis is the most important thing that I do in my practice. It is irrespective of the specialty that I practice, but the diagnosis is the most important thing. Know what you do and do it well. That is what your patient deserves. If you are not delivering the best that you can produce or what is available in the market, you better hone your skills. You need to attend, you need to upgrade, and you need to relearn what was taught to you. The only way to improve is to make an effort and learn, and no one else can do it for you. So if you think that you can learn without making an effort, I'm sorry, guys. Don't live in a fool's paradise. The more harder you work on your skills, the better you become as clinicians. Thank you so much. Anybody interested in learning more about aligners, you're most welcome. Give me a buzz. I'm available 24/7 on WhatsApp. At least that's what my wife tells me. And of course, it's always a pleasure to be in Subharti. Thank you so much for the invite.
Thank you so much for this enlightening lecture, sir, and presenting aligners as the futuristic approach to dentistry. We would now proceed further with our felicitation of our guest speakers and would like to call upon the stage Dr. Anmol Bagaria ma'am, Dr. Ashish Chandra sir, Dr. Pavitra Rastogi sir, President UPDCI, Dr. Nikhil Srivastav sir, Principal Subharti Dental College Meerut, to extend a felicitation vote. And also, we would like to have on stage Dr. Vinita Nikhil ma'am to kindly felicitate our speakers for today.
I would like to call on stage Dr. Poonam Malik Sehrawat ma'am for felicitation, Professor, BDS MDS, DWCOI prosthodontics and implantologist. Can we have a huge round of applause, please? Dr. Poonam Malik Sehrawat ma'am, Professor, BDS MDS, DWCOI prosthodontics and implantologist. Please give a round of applause. Now I would like to call Dr. Manu Rathi ma'am for felicitation, Senior Professor and Head Department of Prosthodontics PGI Rohtak. Dr. Manu Rathi ma'am. Thank you ma'am. Now I would like to call Dr. Gurkirat Singh sir for felicitation, Professor in HOD Orthodontics, Sudha Rastogi College of Dental Sciences and Research, Faridabad. Dr. Gurkirat Singh sir.
Thank you, sir. Extending our gratitude to all the dignitaries and guest speakers for today. We would now like to hand over the ceremony to our next speakers and the masters of ceremony, Dr.
Samriddhi Singh ma'am and Shubhangi Garg.
Good afternoon, everyone. Warm greetings to each and everyone present here. I, Samriddhi Singh,
And I, Shubhangi Garg,
your master of ceremony for today, welcome all our respected dignitaries. We welcome our chief guest, Dr. Pavitra Rastogi, sir, President Uttar Pradesh Dental Council. We welcome our guest of honor, Dr. Abhay Shankaragoda, sir, Pro Vice Chancellor of Subharti Vivekanand, Subharti University, Meerut. All our eminent speakers, respected principals of colleges from NCR, heads of various departments, respected faculty members, assembly of students, organizing team members of CynoDent, Subharti Dental College, and our dear delegates to the inauguration ceremony of our 11th World Dental Sciences and Oral Health Conference.
theme of the conference is Bringing the Future of Dentistry Now and Beyond, organized by CynoDent International and Subharti Dental College Meerut and Indian Society of Dentistry at prestigious Swami Vivekanand Subharti University Meerut.
We wish you all a very happy Mahashivratri and Women's Day. The divine coincidence of celebrating Mahashivratri and Women's Day together symbolizes one of the most potent forms of Lord Shiva and Ardhanarishwar.
It represents the synthesis of masculine and feminine energies of universe, Purush and Prakriti, and illustrates how Shakti is inseparable of Shiv and vice versa. I hope our show continues to bring the viewers the same enlightenment as it has now. Now we present you with the inaugural dance.
या शुभ्रवस्त्रावृता
ही वृद्धि होती हाँ तेरे ही आने से और सुंदर ये सृष्टि होती हाँ तेरे ही आने से ओ हाँ
गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गणेशानाय धीमहि गणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि and maybe next phone actually maybe we try tell me where to go man for not to make me चारों दिशाओं में की सब छाया की भुजाएं पतले कथाएं आखिरत तेरी तरफ शिव जी चले देख जरा ये विचित्र मान चल प्रभा छाए माथे चंद्र विराजे तनना ना 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 तनना ना 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 तनना ना 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 ना
Thank you so much for such a wonderful performance. We request you all to wait for a few minutes till the time we set up the stage. We heartily welcome our respected dignitaries. I request all the dignitaries to grace the dais. Firstly, I would like to call upon our chief guest, Dr. Pavitra Rastogi, sir, President of Uttar Pradesh Dental Council, Deputy Registrar, King George Medical University, Lucknow.
Now, I would like to call upon guest of honor, Dr. Abhay Shankar Goda sir, Pro Vice Chancellor of Swami Vivekanand Subharti University, Meerut.
Dr. Nikhil Srivastav, sir, Principal and Dean, Subhati Dental College, Meerut, convener in the chief of the conference.
Dr. Anmol Bagaria ma'am, founder and CEO of CynoDent, President Indian Society of Dentistry and organizing chairperson of the conference.
Dr. Ashish Chandra, sir, co-director of CynoDent, Vice President of Indian Society of Dentistry, organizing secretary of the conference.
We once again welcome you all to the prestigious Swami Vivekanand Subharti University, Meerut, and are immensely graced by your presence amongst us today for our conference. This conference will focus on latest trends and updates, latest advancements and treatments developments in the field of dentistry. It will bring together stalwarts and delegates from a wide range of discipline and meet and greet and new learn things.
Yesterday, we had conducted 9 pre-conferences focusing on recent advances in dentistry of various branches of dentistry. These pre-conferences had provided a great opportunity to students, clinicians, and academicians to learn and enhance knowledge and skills. Today, we have started with keynote lectures, scientific presentations, followed by panel discussion, and in the evening, we'll be having cultural nights, award show, gala dinner, and DJ. We also look forward to hearing from our delegates through the numerous scientific presentations on their breakthroughs, advancements, and trends in the field of dentistry.
One of the highlights of the conference is that we have organized a Meet Your Author session where you will be meeting some of your favorite authors.
Ma Saraswati, the Hindu goddess, represents education, creativity, and music. No academic event can be implemented without Ma Saraswati's blessing. Thus, I kindly request all the dignitaries to come forward for the lighting of the lamp.
शास्त्रामृता यावे आवरचित्तमण्डकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्कर प्रभृतिभिः नमास्तु सरस्वती भगवती निःशेषजाड्यापहा
Thank you so much, sir and ma'am. I request dignitaries to take their seat.
Ladies and gentlemen, this international conference is brought to you by CynoDent International, Subharti College Meerut, and Indian Society of Dentistry. Guru Gobind Singh Subharti Dental College of prestigious Swami Vivekanand Subharti University, which is ranked among India's top 10 of universities. The university is a NAC-A accredited and has gained various national and international awards. Swami Vivekanand Subharti University is the creation of great visionary Dr. Atul Krishna sir and late Dr. Mukti Bhatnagar ma'am of Subharti KKB Charitable Trust, Meerut, which has obtained a commendable record of service in education, healthcare, and social welfare. Subharti University mainly aims to foster growth among the young generation of learners, thereby making them the future changers of the world. Subharti Vivekanand Subharti University has its main objectives reflecting and abiding by the principles of Swami Vivekanand, a beacon of discipline, eco-friendly, coordination through teamwork, passion for excellence, trust and transparency. Our vision aims to provide practical and professional knowledge, skills, research, and innovation well suited to worldwide scenarios.
Now, let's have a quick look on CynoDent and Indian Society of Dentistry. CynoDent International and Indian Society of Dentistry was founded by Dr. Anmol Bagaria ma'am and is headquartered in Mumbai, Maharashtra. Our national state college teams are spanned all across the country and are led by our very vigilant board of directors. We also have a team of eminent international and national speakers. Our patrons and advisors include the very renowned Dr. Stephen Cohen, legendary endodontist in USA; Dr. James Gutman, legendary endodontist in USA; Dr. Pavitra Rastogi, sir, President, UP Dental Council. With the blessings of Almighty, CynoDent soon expanded to countries across the globe, with having members from 15 leading countries of the world. Our purpose here is to address global health issues, increase awareness about patient safety, create opportunities for dental and medical professionals, and very importantly, to reduce the gap between research and clinics. CynoDent has also launched a unique digital healthcare platform, which is the first of its type in India. We are also working for social welfare and humanity to enhance the quality of life by providing healthcare services, raising awareness and providing free treatments in orphanages, old age home, and underprivileged sections of the society. Done 250 plus camps with completely free of cost treatment, trained 500 ASHA workers, and have also organized blood donation camps. Also have launched oral health program in 2022, 2023 and 2024 with a vision to spread awareness. Also collaborated internationally with WHO, UNICEF and UNDP. CynoDent has done 150 plus free webinars for young doctors to update their knowledge and skills. Launched the textbooks of Grossman and periodontology on our platform. Has patents, copyrights, books, scientific papers, and journals to the credit. CynoDent has organized 15 plus international conferences at eminent universities and 3 conferences on facial aesthetics to share knowledge regarding the recent advancements and state of the art technology so that the lag between the research and the clinical application reduces and better care to be provided to our patients and also to enhance research in field of dentistry by scientific presentations.
Indian Society of Dentistry is recognized well-known society that believes in providing the best dental education which is at par with international standards, maintaining high standards of teaching and promoting research activities with a strong foothold in the Indian dental industry. But ladies and gentlemen, अभी तो असली मंजिल पानी बाकी है, अभी तो हौसलों का इम्तिहान बाकी है, अभी तो है मुट्ठी में जमीन हमने तोलना अभी सारा जहान बाकी है. We promise to serve you with the best of our abilities for the times to come. It's an eternal bond that we share. A bond so beautifully nurtured that there shall be no stronger a bond than this. Ladies and gentlemen, please put a round of applause for CynoDent and Subharti Dental College Meerut.
Now I request Dr. Nikhil Srivastav sir, Principal and Dean of Subharti Dental College, Meerut, convener in the chief of the conference to come forward for a welcome address.
Thank you very much. Jai Hind, good afternoon to one and all here. My colleague in Subharti University, Pro Vice Chancellor, Dr. Abhay Shankar Gola, Pavitra Rastogi, the Registrar of the Dental Council, or President of the Dental Council, and Dr. Anmol, Dr. Ashish, my friends here. I can see a lot of faces who are not from Subharti, but then who have come here, spared their time. Um, Keynote speakers. Yesterday, we had a lot of pre convention courses, the mentors, delegates, students, dear ladies and gentlemen. Uh, on behalf of Subharti family, which includes Subharti Dental College, I very warmly welcome you all to this 11th International Conference, which is exclusively meant for upgrading and updating the knowledge. Uh, I appreciate this initiative of CynoDent, Dr. Anamol, that nowadays in dentistry, many of the conferences, or in fact, you can say 80% of the conferences are exclusively meant for the postgraduates. And you will find very few academic events which are taking place for undergraduates. So this is one of its kind one of its kind conferences where you have a lot of undergraduates participating in this, presenting the paper, posters, and listening to the stalwarts of dentistry. Uh, Yesterday we had the jam-packed pre-convention courses, and as I said yesterday also, that the learning happens at three different domains: the psychomotor, the cognitive, and the affective domain. And yesterday, what we saw, what we witnessed, was the psychomotor domain, where you enhanced your skills of learning these steps by doing yourself. So that was the hands-on. Now, today and tomorrow, you are going to listen to the stalwarts that will enhance your cognitive skills. And of course, when you get to meet your colleagues from different colleges, different parts of northern India, then obviously your affected domain will also be enhanced. I get to learn that more than 10 or 12 colleges are participating in this convention or conference. And of course, there are too many people, including some from Chhattisgarh, who are joining us online for this. So I think this is going to be one of the very meaningful conferences and academic event for all of you. And you're going to learn something which is new, which you have not heard so far. So with these few words, I once again wish this conference a great success. And I must acknowledge the efforts put in by few important people, particularly Dr. Sumit Goel from my college and Dr. Abhinav and the entire team of undergraduate students for holding this conference in this venue, which is little away from our dental college, because in Subharti University we have so many auditoriums depending upon the seating capacity. And then we have the liberty to choose whatever we wanted. So this is a relatively newer built auditorium, and everyone liked it. And then when Dr. Anmol, Dr. Ashish were visiting here earlier, then they decided, let us hold it here only. So this is how we have decided. But I request all those who have come here for the first time, you must come to the dental college, visit, and see how we are teaching, how we are, taking care of the patients, and you can give your inputs also. So once again, I wish this kind of conference a great success. Thank you very much.
Thank you so much for your kind words and constant support, sir. Now I request Dr. Anmol Bagaria ma'am, founder and CEO of CynoDent, President Indian Society of Dentistry, and organizing chairperson of the conference to address the gathering.
A very good afternoon to one and all present here. Warm greetings to one and all. I would welcome you all to the 11th World Dental Sciences and Oral Health Conference. I would like to welcome our Honorable Chief Guest, Dr. Pavitra Rastogi, sir, President, Uttar Pradesh Dental Council, our Honorable Guest of Honor, Dr. Abhay, sir, Pro Vice Chancellor, Subharti University, our respected Principal, sir, Dr. Nikhil Srivastav, sir, Dr. Ashish Chandra, Organizing Secretary of the Conference, all our principals of nearby colleges, HOD members, faculty members, organizing team members, and all our dear delegates who have joined us physically as well as digitally. Yesterday, we had 9 pre-conference courses, as Sir said, and courses were houseful. And the seating capacity was also not enough for the delegates. And it was a really great thing to see that people want to learn and they still want to learn the recent things, and the lag is still there. So we would also try to incorporate more things in our upcoming events. And today we have started with the keynote sessions, and after the inauguration we'll be having a panel discussion and followed by the scientific events, and evening we are planning for a cultural event and awards. So this learning experience is for the budding dentists as well as the practitioners. Has this is a multi-speciality conference focused for UGs, PGs as well as the faculty members. As we know that the theme of conference is bringing the future of dentistry now and beyond. So we are moving towards the future dentistry where we are learning the latest treatment developments and also the research activities of various branches. So I hope you are enjoying the learning experience with us, and I hope the speakers who have given their valuable time to us, I would like to thank them to enhance the knowledge and skills of all our delegates. And I would thank all the delegates for traveling so far and visiting this prestigious Subharti University. I would thank everyone from the organizing committee to make this happen. And especially, I have few names to thank. I would thank Dr. Nikhil Srivastav sir, Dr. Vinita Nikhil ma'am, and Dr. Sumit Goyal sir for making this happen. And two of the just passed out students, Dr. Devansh and Dr. Sakshi, to force everyone to conduct this conference and make this happen. Thank you so much, everyone. I wish you a very happy day and happy conference ahead. Thank you.
Thank you so much, ma'am, for your constant support and wonderful words. Now I request our chief, our guest of honor, Dr. Abhay Shankaragoda, sir, Pro Vice Chancellor of Swami Vivekanand Subhati University, Meerut, to come forward to address the audience.
Jai Hind, all the esteemed guests who have come here off stage and on stage. The Swami Vivekanand Subharti University is a great organization, and in this great organization, if there is a jewel in the crown, the chief jewel in the crown, that is the Subharti Dental College, which organizes such wonderful events for enhancing the knowledge, supporting the extracurricular activities, or enhancing the knowledge for the PG students, faculty, as well as UG students. Now, these kinds of activities are very, very important to upgrade our knowledge. And I have been told that yesterday there were a lot of pre-conference sessions, and uh, many were highly appreciated. They were jam-packed full, and there are other sessions also going on today, and I think maybe tomorrow also, sir. And also, I am told that distinguished guests from various parts of the country have come here who are internationally acclaimed resource persons who are going to give their knowledge to us. And I congratulate Subharti Dental College for organizing this event, as well as I congratulate the Indian Dental Association. Is it CynoDent and Indian Dental Association, which are organizing this event here. Thank you very much for choosing Subharti as your platform to share this knowledge. I wish this conference a great success, and also the delegates are very. I hope that they're very, very comfortable here in these 2 or 3 days, and I wish them all the best in their future. Thank you.
Thank you, sir, for your kind words and guidance. Now I request Chief Guest Dr. Pavitra Rastogi, sir, President Uttar Pradesh Dental Council, Deputy Registrar, King George Medical University, Lucknow, to come forward to address the audience and inspire us with a few words.
First of all, a very warm and hearty good afternoon to everyone present here in this really vibrant and a beautiful auditorium of Swami Vivekanand University, Subharti University, where there are really nice lights and a beautiful use of fine arts. It's a beautiful audi. Very, very respective dignitaries on the dais, Pro Vice Chancellor Dr. Abhay Shankar sir, and the Dean Faculty of Dental Sciences, Principal of this beautiful college, and my senior Professor Nikhil Srivastav sir, very energetic and dynamic organizing chairperson of this conference, Dr. Anmol Bagaria, and very humble Dr. Ashish Chandra, organizing secretary of this conference, and really dignitaries of the dais, my seniors, Professor Pradeep Raghav sir, Madam Vinita Nikhilji, Dr. Anamika Sharma ma'am, Dr. Seema ma'am, Dr. Manu Rathi, and I'm observing Dr. Shalu Batla. Everyone who is present here, a very warm afternoon. As we all know that today we are gathered here for this inauguration session of 11th World Dental Sciences and Oral Health Conference with the aim of bringing the future of dentistry now and beyond. We know that this is the era of evidence based medicine and evidence based dentistry. So, we all are bounded to the code of ethics. We have to provide the best available treatment to our patients. So, for this, we have to update daily, daily, and daily for ourselves for the betterment of the what treatment we provide to the patients. So, as Dr. Nikhil Srivastav told, that change is the only constant of the life. Nothing is permanent. And according to the Bloom's taxonomy, the three basic domains, that is cognitive, affective, and a psychomotor. And this type of conference, which is basically meant for the undergraduate student, so for them, there is a key to become how to become a good doctor. You are here not to become a doctor, you are here to become a good doctor. And ये good doctor कैसे बनेंगे? So for this, you have to follow, you have to stick the 4 A's, that is able, affable, available, and affordable. So you have to strong your cognitive domain with your affective domain and the psychomotor skills. So you have to need this. So this is the need of the arts. These continuing dental education programs and these conferences for the updation of these types of things. One thing I want to tell another, the words of APJ Dr. Abdul Kalam for the updation, how we become, everyone wants to become Amitabh Bachchan or Sachin Tendulkar of his career. But how? कैसे होगा ये? This is just with the help of not only hard work, with the true hard work, with a perfect aim and objective, with a perfect methodology. If you are having the good aim, good objective, with a perfect methodology, we will get the job done. So, by these words, again, I wish all the success for this conference and hope you will get more and more knowledge by this conference. Thank you. Thank you so much.
Thank you so much, sir, for your wonderful words and blessings. Moving on to the felicitation ceremony, it is now time to honor our dignitaries with a symbol of respect in order to remember this momentous occasion and to express gratitude for their valuable time. Firstly, we would like to call upon Dr. Nikhil Srivastav sir, Dr. Anmol Bagaria ma'am, Dr. Ashish Chandra sir, and sir to please present a memento to our honorable chief guest, Dr. Pavitra Rastogi sir.
Now, we would like to present a memento to our guest of honor, Dr. Abhay Shankara Goda sir.
Now we would like to present a memento to Dr. Nikhil Srivastav, sir.
Now, we would like to present a memento to Dr. Anmol Bagaria ma'am.
I would request the dignitaries to please stay back for further felicitations. As we know that today is International Women's Day, so we would like to felicitate the inspiring women in the dentistry present over here. Firstly, I would like to call upon stage Dr. Vinita Nikhil ma'am, Professor and HOD of Department of Conservative Dentistry and Endodontist in Subharti Dental College.
Dr. Vinita Nikhil ma'am. Now, we would like to call upon Dr. Swarga Jyoti ma'am, Principal of Kalka Dental College, Meerut.
Thank you so much.
Dr. Anamika Sharma ma'am, Professor at LLRM Medical College, Meerut.
Dr. Seema Chaudhary ma'am, Head of Department of Periodontics, Kotiwal Dental College, Muradabad.
Dr. Manu Rathi ma'am, Senior Professor and HOD of Prosthodontist at PGI Rohtak.
Dr. Roma Goswami ma'am, Head of Department of Prosthodontics, Subharti Dental College.
Dr. Upasna Sethi ma'am, Professor and HOD of Oral Medicine and Radiology at Shree Baki Bihari Dental College, Ghaziabad.
Dr. Poonam Malik Sehrawat ma'am, Professor of Periodontology and Implantology.
Dr. Shalu Batla ma'am, eminent periodontist and known author.
Dr. Malika Sethi Rishi, ma'am, eminent periodontist.
Lastly, our very own Dr. Anmol Bagaria ma'am, founder and CEO of CynoDent. Thank you so much, sir and ma'am. Now I would like to call upon our organizing secretary and vice president of CynoDent, Dr. Ashish Chandra, sir, to deliver a vote of thanks.
Very good afternoon, everyone. I want to extend my heartfelt gratitude to Dr. Pavitra Rastogi, sir, President, Uttar Pradesh Dental Council, for his valuable time, support, and constant blessings. Special thanks to Dr. Abhay Shankara Goda, sir, Pro Vice Chancellor, Swami Vivekanand, Subharti University. My deepest regards to Dr. Nikhil Srivastav, sir, Principal, Subharti Dental College and Hospital, Meerut, for his great vision, efforts, and constant support. Thank you, sir. Special thanks to Dr. Anmol Bagaria, ma'am, founder and of CynoDent and Indian Society of Dentistry, for bringing the best of the learning process for the students and delegates. Special thanks to the pre-conference course mentors, speakers for delivering the best to the delegates. I hope it was a great learning experience yesterday. Special thanks to all the keynote speakers who are delivering the lectures from the morning. Special thanks to all the head of various departments, faculty members and volunteers of Subharti Dental College. My deepest regards to Dr. Sumit Goyal sir, Dr. Avinav sir, and the volunteers, Dr. Sakshi. A special thanks to Team Sinodent for day and night efforts in making this conference a great success. I want, I want to thank all the dear delegates for making this conference a great successful event. We will be doing the upcoming conference in the future and keep the learning and sharing process continued. Thank you, everyone.
Thank you so much, sir.
We know that everyone is hungry, but we would like to call Dr. Nupur ma'am for a 10-minute discussion on stage. Please, ma'am.
So, Jai Hind and good afternoon to one and all. Before moving on, I would like to thank all my dignitaries on the stage. Kindly take your seat. I know it's too late and it's high time for all of us to get our lunch. But before that, we will have a very short and a crisp panel discussion with all our panelists. So moving on further, I would like to call upon our panelists. First and foremost, I would like to call Dr. Vinita Nikhil ma'am. Ma'am, please kindly come and join us at the stage. Next, I would like to call upon Dr. Pavitra Stogi sir once again. Sir, please, could you join us? Dr. Manu Rathi ma'am. And my dear students, I would like to please clap and give a round of applause for all our dignitaries that are coming up on the stage. Dr. Pradeep Raghav sir. Dr. Seema Thakur ma'am. Seema Chaudhary ma'am. And Dr. Upasna Sethi ma'am.
And once again on the stage, we have the women power with us. So we are in the ratio of 4:2. So please, a huge round of applause for that International Women Day celebration on the stage itself. So, as we all know, that the theme for CynoDent is bringing the future of dentistry now and beyond. So, I would like to just brief up my panelists that I'm going to ask you single questions in which you would have to just give a brief insight about your specialty to the upcoming students and the budding students who are sitting out here. So, I will begin with ma'am, Vinita Nikhil ma'am. Ma'am, we know that when we all talk about endodontics, it is basically we are dealing with access cavity preparation and obturation. How good is your obturation? But I would like to talk about today the advancements in the irrigation system that have come out. And ma'am, what do you think? How much weightage should we give to these irrigation systems that have come recently?
Jai Hind, and thank you, Dr. Nupur. It's such a valid question you have asked. In fact, that's the most ignored portion initially. First of all, she talked about endodontics and saying that I'll be telling you about something recent about my specialty. I again want to reinforce that my specialty is conservative dentistry and endodontics. And it is no, it's not apologies because being this specialty is nowadays only recognized because of endodontics. But that's not correct. We have a very vast portion of restorative dentistry also, which is being covered, and it's very important. Now, as far as this question is concerned, that importance of irrigants or irrigation. See, initially it was a simple thought that root canal, as we say, root canal. She asked the question also. So that means there is a canal inside the root and which we have to treat. But the thing what has changed because of the our upgraded knowledge is that it is never a cancer system. It's a root canal system. The complete word is system. And system means there is a lot of complexity. And we do endodontics, root canal treatment in endodontics, whenever we find that the pulp is irreversibly damaged and there's infection in the root in the canal system. So, for removing the pulp, irreversibly damaged pulp, and removing the infection, we are using irrigants. Because the file system which we use, either the hand file which is being taught during undergraduation, and also you are taught about the rotary, but usually you use the hand files. They simply create a canal or a space which simulates their own shape. But if I say complexity in a root canal, that means it is not a canal, it is something irregular in nature. And that cannot be cleaned without something which can come in contact with it, and that should be a fluid, and that's why we use irrigants. Now, the changes in the irrigation systems are twofold. Number one, we try to find out the best irrigant which can remove or dissolve all the pulpal remnants, as well as it can kill whatever bacteria is there. Okay. So, and the second change is that we want this irrigant to reach in every nook and corner of the root canal system. So, we have nowadays hypochlorite. It has been used since long, since ages. It is still continuing and it's a gold standard. However, the strength of hypochlorites keeps on changing right from 1% to 8%, depending upon your clinical scenario and the type of patient you are doing. And as far as irrigation devices are concerned, initially we have been using a hypodermic needle just to irrigate the canal. Then we thought of why not to move this irrigant. We started using our gatta parcha or the file itself to agitate it. But recently we have so many devices which are there which can agitate or circulate this irrigant in this whole system by using either ultrasonics or endosonics and then agitating this not only leaves this material in contact with all complexities, but also increases the temperature of these irrigants, which further enhances these irrigant system. So the advancement, if Dr. Nupur, you ask me, I'll say the advancement is that they have thought about using the different type of protocol, like alternative use of hypochlorite with chelating agents. Then एक और मजेदार बात आपको बताती हूँ, किचन में जितने प्रोडक्ट्स हैं, हल्दी, धनिया, मिर्चा, गरम मसाला, जीरा, जो भी आप सोचते हैं, everything has been tried as irrigant. Everything. Only toiletries are being left. Only toiletries, I'm telling. But till now, the best always remains hypochlorite, which we are using. But the devices, we have so many beautiful devices, handheld devices, convenient devices, and now the devices which are within our approach we can purchase to be used for agitating this one so that we can properly disinfect the root canal. This is the upgradement of this.
Thank you so much, ma'am. Next, I would like to hand over the mic to Pavitra Sogisa. So we know that perio is always considered as something which is related to gingiva, and gingiva. So I would like to ask you that how has implantology changed and revolutionized this periodontics department or periodontology?
First, I would like to say that perio, as the name suggests, there is the surrounding structures of the tooth. And such a specific thing, periodontitis is a chronic infectious disease which affects generally all the humans since the dawn of the history. And it's a multifactorial disease, and every multifactorial disease depends on the five multiple factors, that is microbiologic, immunologic, systemic, genetic, and behavioral.
Yes.
But we all know that no one is devoid of a type of a periodontitis. As you say, no gingivitis, it's an earlier form of gingivitis and the later forms of gingivitis which goes towards the periodontitis. But we have to think that is a specific, uh, that is the main specific thing is the epithelial attachment. With this type of attachment is the unique attachment in the body which is directly exposed to the external environment. So that is why this particular point we got a disease. And now you're telling that as the what is the role of implantology. That is a type of a rehabilitation of the oral cavity. We know that the loss of tooth depends on caries and a periodontal disease, where the periodontal disease above the caries. When we think about the implantology, I always used to say that a person who is not able to maintain his natural teeth in the oral cavity, how he will maintain this artificial implant in the oral cavity. Yes. So first, we have to think, we have to think of ethics that first we have to try this save the natural tooth. The first, as the endodontist, a conservative shows, first we have to think how to save the natural teeth. But one more thing, अगर सुबह का भूला शाम को घर लौटाए तो उसे भूला नहीं कहता. डजंट मैटर कि अगर
जी
उसके
सर.
दांत नहीं है तो हम इम्प्लांट, आई एम नॉट अगेंस्ट द इम्प्लांटोलॉजी, we are using implants from 2004. I completed my PG in 2004. But maintenance phase is an utmost important part of all the treatment methodologies. It doesn't matter it's a surgical periodontal therapy or non-surgical periodontal therapy. It all depends on maintenance phase. If a maintenance phase is strong, then all types of implant is okay. So it's all depends on the, you have to maintain the natural tooth or the artificial tooth, which is an implant.
And everything lies on the gingiva. The
Absolutely.
gingiva has to be strong, healthy,
We have,
so that it supports the implants and any other procedure that we do in the oral cavity.
absolutely, we have to think about the biofilm.
Exactly.
That is a film which contains the biological microorganisms in the oral cavity.
Yes, sir. Okay. Thank you so much, sir. Moving on next, we have Dr. Pradeep Raghav, sir. Sir, if we talk about the treatment efficiency and outcomes, how have these self-ligating systems, brackets, and temporary anchorage devices, they have revolutionized this branch?
Thank you, Dr. Nipur. Uh, Firstly, I would like to start with that. As we all know, that orthodontic is supposed to be one of the most ancient specialty in our AGODO, that is American Journal of Orthodontic. It is supposed to be the first specialty. That means orthodontic treatment has started since 1900. And after this, there has been so many innovations, so many inventions, so many modifications. But still, till today also, we are every day we get new modification, or new technique is getting involved. Now, regarding your self-ligating method, when we started with the orthodontic treatment, at that time we started with metal braces. Now, metal braces, as we all know, you all may have read about angle. Now, when metal bases started, at that time we used to use wires, that also stainless steel, rigid wires, and the maximum tooth movement was taking place by sliding of the brackets within the wire within the brackets. And whenever there is a sliding, there will always a factor of friction. That means one of the major deterrent of orthodontic tooth movement was the friction. And till now, I am not saying that the self-ligating bracket has brought some revolution in the orthodontic treatment, but yes, at that time, because of the conventional orthodontic treatment, when there was sliding and friction, so there were a lot of hindrances in the tooth movement. So at that time, in orthodontic treatment, the major motive of orthodontic treatment was to reduce friction and to reduce anchorage. That means to reduce the unwanted tooth movement. So with the grace of time, with the time, the latest modification which came was how to reduce friction. Then by with developing that concept came the self-ligating system. Now, normally when we slide or when we tie a wire into the bracket slot, we normally use a ligature wire. And whenever we will use a ligature wire, it will always press the wire into the bracket. And definitely it will cause some more friction. So the involvement of self-ligating bracket was basically to reduce the friction. So in this, what we do, that normally there is a wire, we have a bracket wire, and then we do not have to use any ligature wire or modules. It has got a door-like of system, means as you place the wire and you just shut the door, and thereafter the wire is kept within the thing. So self-ligating brackets has definitely increased the efficiency of orthodontic treatment, but more so for an orthodontist. Now, here I would like to say that as a dentist, now since the science is a evolving process and the research is taking place at such a fast level, and at the same time, there is a lot of marketing pressure also. Market will say it because a lot of commercial companies have come into the market. Now they will sell you something. This is the best treatment. इससे बढ़िया कोई bracket नहीं है. This by this you will reduce the treatment time. You have Google. You just go and search what is the research says. Self-ligating bracket. What the company claims nowadays, definitely it is one of the most commonly used bracket system. But it is mainly advantage is that it reduces the chair side time. Now the time we used to tie the wire into the bracket by ligature, it is not there. You just place the wire, you just shut the door, that's it. So it has reduced the time. Definitely it has reduced the comfort level for the patient also, because now patient doesn't have to tackle to the problems of the nicking ligature head, which are normally there whenever we put the ligature wire in there. So that is the advantage. Now, second thing which is there, the companies they claim that it reduces the treatment time. Presently, there is no research. There are most of the systemic reviews, meta-analysis, they have clearly stated that there is no difference between the treatment duration of the conventional orthodontics and self-ligating brackets. So that is about self-ligating brackets. Second is the what you have asked about the mini screws. Now, mini screws definitely they have revolutionized the orthodontic treatment. I think if somebody would ask you which is the one of the most in, important invention or which has come in orthodontic, I would say mini screws. Why? Because one of the major, as I just told in the initial part of my talk, that whenever there are two basic deterrents of orthodontic tooth movement, one is friction. Second is anchorage loss. Anchorage loss means whenever we will use a force, there will be always unwanted tooth movement. So by putting a TAD, that is temporary anchorage devices or mini screws, we have reduce the unwanted tooth movement. That means now we can achieve the tooth movement to our best of efficiency, to whatever goal we have achieved, we have put in front of us, that this type of tooth movement up to this we will move the teeth. That is what we will achieve by pads. So that is, I think, pad has really done a great job. And second advantage is, previously there was always a limit of orthodontic tooth movement. As if you may have remembered, that there's a term called as envelope of discrepancy, which limits that how much tooth movement we can do by orthodontics only. But by with the advent of TADs, temporary anchorage devices, or the mini screw, which have now come into orthodontics, now we can, the limit of tooth movement has increased almost two folds. That means initially we could intrude the teeth only by 2 millimeters. Now we could intrude the teeth by almost 4 or 6 millimeters. Similarly, in all the domains, in transverse dimension, in sagittal direction, in vertical direction, now we can move the tooth to a greater extent. And many cases which previously we used to do with surgery only, now we can do with the use of TAT. So these are the two things which I think are, that's a very relevant question. Thank you so much.
Thank you so much, sir. Next, we have Dr. Seema Chaudhary, ma'am. Ma'am, what are the major challenges encountered when dealing with pediatric patients and how can we overcome them?
Very good afternoon, everyone. Dr. Nikhil Srivastava sir is here. So, as a pedodontist, Dr. Nupur Kaushik is also a pedodontist. So, first important thing is that we are dealing a child patient. ठीक है, and in pediatric dentistry, we are doing the work of all the specialties. It's an age specific specialty, not a technique one. So here we are doing restorative, pediatric restorative dentistry, pediatric endodontics, pediatric orthodontics, and most importantly, the child psychology and behavior management. So what I think is behavior management is the most important and most challenging thing to a pedodontist. So, what we have to do, personally, I think that first we should try the non-pharmacological means, that very important. So, we have to do all the thing like virtual reality, and so many Vitol is there, and so many things like hand over mouth technique, tell show do techniques. So first we'll try that, and if the child is very fearful and anxious, then we have to go for conscious sedation. And now all the periodontists, they are practicing conscious sedation. It's a very important thing, and I think very effective also for the behavior management of a child patient. So just we should avoid general anesthesia unless and until it is mandatory to go for a general anesthesia, and we should try to manage the child non-pharmacologically. Otherwise, we can go for conscious sedation. Thank you so much, Nupur. Thank you very much.
Thank you so much, ma'am. Dr. Manu Rathi, ma'am. Ma'am, how has CAD-CAM technology revolutionized the field of prosthodontics and what are its key benefits? CAD-CAM.
Thank you so much, Dr. Nupur, for the question. And as I understand in the beginning, the answer is directed towards the undergraduate students.
Yes, ma'am.
And I'm sure every student in this hall is having a smartphone on their palm. So it means everything is digitalized. So how can the prosthodontic practice remain behind? So earlier, the contemporary or the conventional prosthodontics, that was manual, and CAD/CAM means everything. The designing part as well as the manufacturing part has utilized the digital technology. As I said earlier, also that it does not replace the human element. However, the execution of treatment planning, designing specifically, and manufacturing of the restoration, or I would say fabrication of the restoration through the digital technology, has simply escalated. It has just given a rocket speed to the conventional lab processing procedures. Not only it has increased the speed exponentially, also it has made the fabrication very clean and quick method. So primarily clean, quick and precise are the newer dimensions which the CAD-CAM has given to the restoration in the prosthodontics. Thank you.
Thank you so much, ma'am. And now I would like to ask question from Dr. Pasna Sethi, ma'am. Ma'am, what are the recent imaging techniques employed in dentistry and how does CBCT proves advantageous in your specialty?
Yeah, thank you so much. See, as far as the modern dentistry is concerned, it is all about replacement of the dentition or the edentulous area with implants, and then performing absolutely accurate root canal treatments. There are many patients that we come across in our day-to-day practices where whenever we are following conventional root canal therapies or maybe periodontal surgeries, we find that patients do come to us after a certain amount of time with post-operative pain. If we just have a quick visualization of the intraoral periapical radiographs or maybe or OPG, we see what we see is that the root canals have been done so perfect and everything is absolutely bang on, but then still the pain persists. Perhaps we've missed an accessory canal which is not visualized on a two-dimensional radiograph. So here comes the role of CBCT. Uh, as far as the replacement of teeth are concerned, we all know that implants are the something which is very in these days. So the initial guidelines by the European radiology team, they said that probably just the conventional mode of treatment investigations like your IOPAs or OPGs are sufficient for planning implant therapies. But then now the latest guidelines which have come by American Academy also, they say that CBCT is of prime importance, and considering the reduced amount of dose that we have these days with the newer modalities of CBCT, newer machines of CBCT, now it has become imperative for all of us to initially go for CBCT before planning any implant procedure. And one more thing I would just like to add, which is certainly not asked to me, regarding oral medicine and radiology as a branch. We have always considered oral medicine radiology as a non-clinical branch. So here I would just like to add one small bit to it, that orofacial pain, especially the chronic orofacial pain, is one branch of dentistry which is now merging with oral medicine and radiology and is coming big way. To an extent that in America now, it's been now 2 years that it has got a specialized recognized status. In India, it is still yet to come. But then, considering the detailed history that an oral physician takes, I feel this is the need of the hour for our branch to consider orofacial pain along with the radiology part, that is CBCTs and MRIs that are available to us. Thank you.
Thank you so much, ma'am, for that wonderful answer. Now that sums up the session for today. Yes, ma'am, please.
Sorry, I just wanted to share one thing that as she asked one question regarding the irrigants, I want to tell you the importance that it is so important that just simply by irrigating, if you irrigate the canal nicely, if you disinfect the canal nicely, and you give a cornel seal, that is the excess opening, you have closes nicely. Even the cases has been seen that without obturation also it runs. And this concept was coined by our own Indian fraternity member, Dr. Naseem Shah, by the name Seal Bio. And she has shown long term case survival, and the outcome was fantastic. That without obturation, if you irrigate the tooth canal system nicely, you will get success. And for my undergraduates, I just wanted to tell you that if you want to become a multimillionaire, you just do one research, find out a substitute of sodium hypochlorite, get it patented. I'm telling you, within few days you'll be a multimillionaire, because there is till date we don't have any substitute for it. Thank you.
Thank you so much, ma'am. So that sums up the session for today. You all are waiting for the lunch, so we'll move ahead. But before that, I would like to call upon Dr. Anmol Bagaria, Dr. Nikhil Srivastav sir, and Dr. Ashish to kindly felicitate our panelist. And I'm sorry, Pro VC sir. Sir, sorry, please, sir. A huge round of applause, please.
We would like to felicitate Dr. Seema Chaudhary ma'am, Dr. Upasna Sethi ma'am, Dr. Vinita Nikhil ma'am, Dr. Manu Rathi ma'am has already been felicitated, so thank you so much ma'am. Dr. Pradeep Raghav sir, Dr. Pradeep Raghav sir, Dr. Pavitra Rastogi sir,
Manu ma'am has already been felicitated.
and Dr. Nupur Kaushik ma'am. Thank you so much, sir. Thank you so much, ma'am. We now request all of you to please rise up for the national song. Vande Mataram, Vande Sufla, Malaya Shitala, Sashamala, Mataram, Vande Mataram, Subrajotsa, Ulekitaya, Varnavati Sumita, Dhamakadashodani, Suhasini, Shurapanash, Sufidam, Subhasini, Sumadhura Gopashini, Sukhanam, Thank you so much. I request you all to proceed for the lunch.
Okay. All the delegates who have registered can kindly proceed for lunch downstairs in the Audi, and registered with hospitality delegates can proceed to the Audi downstairs for lunch. Go the open ground for lunch, and all the other delegates can please wait here as the lectures will proceed shortly. Sorry.
Thank you so much, all the dignitaries. Now, I would like to invite upon our next speaker for today, that is Dr. Anamika Sharma ma'am, Head Department of Dentistry, Lala Lajpat Rai Memorial College, Meerut, to present her topic on surgical management of periodontal defects. I would kindly request all the participants. We would all may please proceed to lunch. We would resume with Dr. Anamika's lecture at around 2:30. So kindly please be seated for the next lecture.
crown repositioning, and orthognathic surgeries. Crown lengthening basically is done for restorative as well as aesthetic purpose. So, whenever we go for crown lengthening, we have to take into consideration the biologic width. What is this? This is the actual sum up of the junctional epithelium and the connective tissue. So, whenever we are going for crown lengthening, we have to consider the biologic width, because if this is intervened, then inflammation sets in and which causes discomfort to the patient. So you have to have a width of 2.04 millimeters whenever you are going for crown lengthening. Case 1, here severely treated teeth, go for root canal, and then you go for crown lengthening, and then crowns are placed for aesthetic purpose. Lip repositioning is done when your gummy smile is less than 8 millimeters, means around 5 millimeters, 5 to 6 millimeters, you can go for this procedure. This is a case where the patient had a gummy smile of at least 6 millimeters. So in this, using an indelible pencil, we mark the mucogingival junction, we mark the utmost extent of the alveolar mucosa, and then by partial thickness flap is raised and the tissue is removed. Here you can see the third slide where the tissue is removed as in unison. This is how the area looks after removal of the epithelium. Then this epithelium is sutured at the mucogingival junction. So you have to take into consideration that the first midline suture is very, very important for aesthetic point of view. So this is how the patient looks, and the patient is happy, and the gingival display has reduced and it has come down to around 3 millimeters. Another case where laser has been used, procedure is the same, where you mark with indelible pencil, you remove the partial thickness flap, you suture it, and this is the difference after 1 month. Another same case, you can use any modality. The procedure remains the same. Electrocautery has been used, and this is what we get 1 month post-operatively. Interdental papilla reconstruction, very, very fine procedure. Microsurgical procedures can be used, but here, those who are periodontists, they must be knowing about these 3 techniques where we can go for interdental papilla reconstruction. The first technique, hand and Tekai, here a semilunar incision is given, connective tissue procured from the palate. It is placed in this pouch. The pouch is sutured, and this is the difference which you see 3 months post-op. Very, very fine surgical procedure, but very, very aesthetic procedure for patients who really don't want these black triangles. Another case where the tissue has been taken from the palate, it has been, the papilla has been displaced from the palatal aspect, sutured, and you can see the difference pre-op and 3 months post-operatively. Now, if patient doesn't want to go for any surgical intervention, or if surgery is not possible, then these black triangles or interdental space can be treated by gum veneer. So this is just an acrylic plate which is placed on the buccal aspect of the gingiva. The patient can remove while sleeping, and this is how the patient looks pre and post operatively. Happy patient. Yeah. Now this is a case where you can see that it seems like fenestration, but once you open the flap, it is dehiscence, right? So the marginal bone is also lost. Here, the area was debrided, roots were root planed, and then graft was placed, membrane was placed, the area was sutured, And this is the difference which we see 1 month post-operatively. Coming to pre-prosthetic surgeries, these are done whenever we want to place any crowns or fixed partial dentures. So we need to extend the length for better retention. Here, the soft tissue mucosa has been excised, and then bone recountering has been done to have an adequate length and to maintain the biologic width. This is a case where the vestibule is shallow. Here, the free gingival graft has been used to increase the depth of the vestibule. The tissue procured from the palate, it is placed at the vestibule, and you can see the marked probing difference 3 months post-operatively. Ridge augmentation, very, very important. Nowadays, implants are in, right? So all the patients want implants, but you have to have sufficient width, length, and width. So for that, you need to go for ridge augmentation prior to implant placement. Here you can see the incision is made, graft bed is prepared, bone is procured from the symphysis area, and the blocks, they have been tagged at the side recipient bed to increase the width of the bone. The graft is placed, and on that we have tagged the bone blocks. The area is sutured, and then you can see the amount of gain in width of the bone, ready for implant placement. So to conclude, we say that successful regeneration is assessed by periodontal probing and radiograph, but histological evaluation still remains the gold standard for any kind of periodontal regeneration. Thank you. This is my alma mater, and I am really thankful to my alma mater KGMC. Because of this, I stand here before you. Thank you.
Thank you, Dr. Anamika Sharma ma'am, for such an enlightening lecture. Now, I would like to call upon Dr. Vishal sir and Dr. Sumit Goyal sir to felicitate Dr. Anamika Sharma ma'am. I would also like to call Dr. Shalu Batla ma'am on stage. Dr. Anamika Sharma ma'am.
Thank you, all the dignitaries.
So I'm the next one to speak out. Yes, great.
I don't want to waste the time. Thank you for that wonderful lecture, ma'am. Now I would like to invite over Dr. Shalu Batla, ma'am. She is an eminent periodontologist and a renowned author. Thank you.
It's just jumping up. No, I'm not in so much hurry. Is it something with the display or the switchover is from that side? From this side only. Just help me out. It's moving faster. You need to help me out for that. I need to go back to the first part. You said first. First slide. That's why I need to go to the first slide. Should I go into it or I want to? Okay, I need to say it. Okay. That's fine. So, very good afternoon to all. I know it's going to be a very dull session. Post lunch are always dull, but nevertheless, we'll try to. Uh, well, I'm very thankful to Subharti Dental College and CynoDent for giving me this opportunity to share my little view and little experience about microsurgery, which all I have right now. And just excuse me for having that post lunch session with all that sleepy presentation, but I will be just showing all my cases which I've done with the loops and doing microsurgery. Um, Okay. May I know how many of you are using loops or any kind of microsurgical techniques or instruments or whatever? Or the micro? Oh, that's great. So obviously, the peri people loves to have loop with them. Um, to start with, microsurgery is not only to have a fancy loops and the microscope with us. It's more than beyond this. It's microsurgical is basically it's a triad. You have to have the magnification, you need to have the illumination, and definitely the precise surgical skills, which all we have. More or less, we have those skills. But there we need to have to use microsurgical instruments also. And so this is a basic loop which I have been using since long. Um, it is 3.5x. It has a camera over it. I'm not promoting any company, very frankly. That is a disclaimer. I'm not promoting anything. But yes, it's a basic loop which I really love it because it records everything, whichever I do, whatever procedures I do. So it records, and I can see in my laptop or in my phone itself after the procedure. So wherever I went wrong or where I could improve. So that's a kind of Um, like the cameras you have, you just click the photographs, and every time you click the photographs, you see where you went wrong or where you could have gone in a better way you can do the surgeries. So that's a loop with the magnification of 3.x. And then talking about the microsurgical instruments, the only difference with the conventional and the microsurgical instruments are that you have that these instruments, they are refined, they are finer, and one most important thing, दे आर मैट फिनिश्ड. अगर आप अपनी कैस्ट्रोवेज निडल होल्डर देखेंगे जो मिनी वाली है वो मैट फिनिश होगी एज कम्पेयर टू द नॉर्मल निडल होल्डर्स और अदरवाइज ऑल्सो कैस्ट्रोवेजो का आप देखेंगे तो वो मैट फिनिश होगा बिकॉज अभी जैसे ये ग्लेयर ये इल्यूमिनेशन ज्यादा मेरी आंखों में लग रहा है आई एम नॉट एबल टू सी मच ऑफ द पीपल अराउंड हियर सो सेम इज दैट व्हेन यू आर यूजिंग अ लूप्स magnification is there, and if you use a glossy or a shiny surface of the instrument you won't be able to see the other things. So that's the reason the microsurgical instruments, they are matte finished. Then they are smaller in size, they are finer, they are sharp, and you use which number blade in your normal routine surgical procedures? we use 15 or 11, right? But I just request you to use 15 C. It's a wonderful blade. And in case if you can get ophthalmic knives, they are wonderful. They're very mini. They are much smaller in size. They are hardly 11 or maximum 12 in size. So they are very micro in sizes. So these are the numbers of the blades. Then sutures. Normally we use 50 or 40, but in microsurgery we use 60 or 70. That's maximum you can use it. That's just the comparison to see the difference between the micro holder, the conventional micro holder, and the the other micro holders which we use in microsurgeries. Now the retractors, we use a very bulky retractors, but in microsurgery we use the smaller retractors. The tissue forceps also. The only thing we need to take care while you do a microsurgical procedure is that in your dominant hand, in your working hand, you have to have a needle holder. Let's suppose you are doing a suturing, so you need to have in your this thing dominant hand, you need to have a needle holder, the micro needle holder, and in the non-dominant hand, you have to have a, that is mandatory, to have a micro forceps, just to pick the tip of, not the tip, the body of the suture needle. I'll show you. I have the picture how you have to do the suturing. So micro curates, you can use mini curates, which is available in our must be there in your departments. So you can use those curates, micro curates. It's not moving. Okay. Then micro scissors. Again, all the instruments needs to be smaller in size. That's the nutshell. Yes. And then you cannot use, in microsurgery, you cannot use a round cutting body needle. You have to use a reverse cutting needle. Then there are spatula needles are also there. It's approximately 6 in size. That's a 6.6, precisely 6.6 in size. So you can use these microsurgical instruments and do microsurgery. You can do many things. You can, from incision to sutures to sinus lifts to what all procedures you can do with your eyes, you can do with the loops, or you can do with the microsurgical instruments. So there are some examples of it. So before placing the implants, you can go for socket preservation. You can use these loops wonderfully to place the graft, to place the membrane. Very frankly, Anamika ma'am ne mera kaam aadha kar diya hai by telling all the procedures. So I'm very happy with that. So I can save another 10 minutes out of it. So you can place the grafts, you can suture well. You can use 60 or 70 suture. Then at the time of the implant placement for giving incisions, you can give a paracrystal incision, you can give a mid-crystal incision. Like if you have a heel ridge, you can give a mid-crystal incision. And in case if you don't have a well-defined ridge, you can give a paracrystal incision. Or in case if you want to give, in such cases, in the last one, you can see there is deficient ridges there. So there you can give a paracrystal incision. But although mid-crystal incision is the most desirable, ideal incision to be given if you have a sound ridge. And this is the most common finding, once you age. The only thing is why we encountered such things is when we have placed abundant of the bone grafts, because हमें सबको आदत होती है overgrafting करने की. Overgraft कर दिया है, हमने उसके ऊपर membrane भी लगाना है, हमने बाकी सबकी उसको bulky कर देना है. But the thing is, what we forget to give is the releasing incisions, the horizontal periosteal releasing incisions हम देना भूल जाते हैं, because this horizontal releasing incision, basically what it does is just to it increases the length of the flap. So it just advances the length of the flap. So we need to give that. And this is now jumping over to the full thickness flap. the success of any surgical procedure lies on अगर आपने full thickness flap दिया है, आपने पूरा retract होना चाहिए आपका epithelium, connective tissue and periosteum all together should be there in the flap. Otherwise, if you don't give a incision touching to the bone, you're not going to raise a full thickness flap. अगर आपने बोन के साथ खेलना है, रीजनरेट करना है, उसमें रिसेक्ट करना है, बोन के साथ कुछ भी करना है, तो आपको बेयर बोन दिखी होनी चाहिए. You need not to have periosteum over it. So the moral of the story is that you have to have the incision touching the bone, and then you have to raise a full thickness flap having the periosteum in the flap. So here you can see a bare bone. अगर आपका बेयर बोन नहीं मिलेगा, अगर आपने कनेक्टिव टिश्यू में पियर्स कर दिया है, तो आपके पास ब्लीडिंग उतनी ज्यादा होगी. साइनस लिफ्ट में always have, it's not about sinus lift, it's about anything. If you want to do with the bone, you need to have a full thickness flap. So this is a basic difference between a full thickness flap and a partial thickness flap. Yes, with the loops, partial thickness flap बहुत प्यारी तरीके से रिफ्लेक्ट हो सकता है. आप बहुत अच्छा दे सकते हैं, partial thickness flap रेज कर सकते हैं with the help of the loops. So this is a case where we thought of giving the implants, but we found that the ridge was very thin and there was a shallow vestibule. So we increased the depth of the vestibule, but just by giving a partial thickness, we raised the partial thickness flap, we apically displaced it and suture it. And this was the wonderful result we got. That's a simple lateral displaced flap case. This was the case where the bone was deficient, the buccal dehiscence was there. So what we did was we reflected a full thickness flap, decortication करते हैं ताकि blood supply improve करने के लिए, and then we put the graft and then the membrane over it, and then you can get a very healed ridge. So the clinical tip lies here is that the scalpel, the blade needs to be perpendicular, should be touching to the bone. And yes, for giving a releasing incision in the periosteum, the scalpel needs to be parallel. Mid-crustal incision, yes, it gives a best healing incision potential. It has a best healing potential, and yes, that's the takeaway message. Keep on repeating the blades. I know that approximately 15 number blade जो है आपका 50 पैसा या 1 rupee cost करता है, and your 15C blades hardly cost 7 rupees. So at least waste 6-7 blades. So 35 rupees is not a much cost of it. So if you are doing a periodontal plastic surgery, or if you are placing implants, or if you're doing any regenerative procedure also for that matter, try to keep 15C blade in your hand and repeatedly change the blade. The thing is, as soon as the blade comes in contact with the blood, it gets blunt off. So in case of root coverage procedure, you need to change it repeatedly. So for grafting, I won't go in much of the details of the grafting, but yes, with loops, with microsurgical instruments, you can improve your grafting results, definitely. So this is a case of epithelial graft. The suturing of epithelial graft is totally different. So you can enhance your suturing practice. You can practice it well with the loops. This is a case of procurement of the connective tissue. This is a trapdoor technique. Now here the microsutures were used to cover the black triangle. These all cases have been done under loops. Vista technique, well, you can give a very precise incision with the loops. This is another case. Instead of going horizontally in the tunnel, you can go vertical also in the tunnel. Again, for direct sinus lifts, you can use loops for making, but I would advise, if you are a beginner, please don't use loops while going for a direct sinus lift procedure. You need to practice. Your brain needs to be accustomed, your brain needs to be trained, your hands needs to be trained while using the loop. So please don't use your loops just for the most difficult procedure for nerve repositioning or for sinus lifts. Don't use it there itself. Start with the root planing and then go further. So for nerve repositioning, you will be able to see the nerve and you can retract the nerve, and then lateralization can be easily done, but not as a beginner. So yes, you can use these microsurgical things in second stage. Unnecessary, in the second stage, we give such a big incision and then we uncover the cover screw. That is not at all required. This is not at all required. You can just give a minimal incision and you can uncover the cover screw and you can place the healing abutment. I will show you the pictures. So you can just give, I need to back the, please back करिएगा, slide को back करिएगा. Somebody is there? Yeah. So you can see a plus shape incision is given, just a plus shape incision, but that blade should touch the cover screw. That's the thing. And then you reflect a full thickness, all the four squares, you need to reflect it. Then put the healing abutment. Here the point is you need to just take care of it कि आपका जो soft tissue है वो healing abutment or implant के crust के बीच में नहीं आना चाहिए. That's the only thing. Use a very thin micro retractor, periosteal elevator, and then reflect it nicely away from the healing abutment and put the healing abutment. That's it. You don't have to suture it. You don't have to give us such a big incision. I don't know why people give such a big incision. For a single implant, a plus shape or a I shaped or even a H-shaped incision can be given. You can reflect it and then put the cover screw, can put the healing abutment. Then if you have placed 2 implants, you have placed multiple implants, you can give a U-shaped incision. Fine. And you can, deflect this portion onto the buccal side as shown in the third figure. That's it. Nothing. You don't have to do it. Let the Mother Nature take care of it. And you will get a beautiful gingival collar. So moral of the story is that you are going to save your time. The patient अगर सूचर लगाओगे डेफिनेटली वो अगर नॉन रिजॉर्बेबल रहेगा तो वो दोबारा सूचर कटिंग के लिए आएगा. हीलिंग इतनी अच्छी पोटेंशियली, अगर आपने इतना ज्यादा बड़ा इंसिजन दे दिया डेफिनेटली यू नीड टू सूचर इट ऑल. But if you've just raised it, you can easily, give such a minimally, very small incisions you can give. So this actually comes under minimally invasive surgeries. That's a beautiful concept which was given by Mish. And the way you give a U-shape incision, the Mish asked us to give a cut in between, create 2 fingers, and then suture it on the each side. So that's a split finger technique given by Mish. That's another technique which was given by Palachi. I know it's little beyond the scope of this thing, so I wouldn't go in details of it. Then suturing, you will appreciate, you can see all the faults and the things where the suturing get wrong. If you use these loops and you use these micro surgical needles and all that. So you can see, here the suture was not proper in this area. The circumferential suture was not proper. This you can easily see once you have those magnifications. So you can easily see those faults. So this is the conventional needle holder. The light one is the way you are going to hold the needle holder. This is a conventional way to hold a needle holder. This is the way you hold a micro or a Castrovision needle holder. It's called as a precision grip or an internal precision grip. Grip. There was a video, but I will like to skip it up. These are the various, yeah. And for implant dentistry, please don't use those direct loop or a figure of 8 suturing technique. Try to use horizontal mattress suture. नाम बहुत बड़ा है but बहुत simple है. एक 2 direct loop sutures जब आप एक साथ दे दोगे, this is the middle one, the second one is a horizontal mattress suture. So by giving a horizontal mattress suture, जो आपका thread है वो cover screw के ऊपर नहीं आएगा. अगर आपका कवर स्क्रू के ऊपर जितना थ्रेड आएगा उतना आपका इन्फेक्शन का सोर्स आप बढ़ा रहे हैं. अगर आप बोन ग्राफ्ट कर रहे हैं, सूचर लगा रहे हैं, so always try to use first a monofilament suture. The second thing is try to use this horizontal mattress technique. Very frankly, just tell me, have you ever tried any other suture apart from that, or no, no, none of you? सारे लोग या इधर और इनके अलावा कोई और सूची नहीं करा. Believe me, if you do it in implant industry, your results are going to improve like India. जितना हम सिर्फ सूचर यूज करते हैं, सिर्फ सूचर is a multi-filament suture. Please don't use those silk sutures in your implants. I know the cost is going to be high if you use a poly or a nylon suture. Nylon suture आपका थोड़ा महंगा रहता है, poly आपका थोड़ा महंगा रहता है. Please use your nylon or the poly one. Don't use those silk sutures. Nylon. Where disadvantage? If you are going for a regenerative procedures or if you are going for an implant cases or for full work, use your poly suture or nylon. Has anybody felt this? कभी use किया कभी से poly? So, try to use those proline and the nylon sutures because they are monofilament. Simple सी बात है. जो आपका nylon suture है, monofilament होगा, उससे बैक्टीरिया की इन्फेक्शन जो है कम जाएगी टिश्यू के अंदर. मल्टीफिलामेंट होगा तो उसमें बैक्टीरिया भी सीख करेगा और माइक्रोऑर्गेनिज्म करेंगे टिश्यू के अंदर. So always try to use a monofilament suture. Or you can use PTFE sutures also. But again, handling is difficult. That was the case of Vista technique, and then we sutured it and put a composite button over the, just for coronally advancing the flap. So try to use a square knot or a surgeon knot, preferably surgeon knot. In case if you're using proline, the thing is that you give a surgeon knot and then over top of it you can give a square knot. But surgeon knot is much more than sufficient. So surgeon knot is the preferred knot to be used in when you're using when you're doing any regenerative or implant dentistry. So the clinical tip lies here. This is more for the perio people. I feel perio people are there. Okay. So this is the suture of choice. If you're just doing a simple flap procedure, yes, you can use a silk suture. If you're going for, again, repeatedly I'm saying it, that अगर आप माइक्रो सर्जरी कर रहे हैं, रीजनरेटिव सर्जरी कर रहे हैं, इम्प्लांट डेंटिस्ट्री कर रहे हैं, या आप जो भी मिनिमली इन्वेसिव सर्जरीज कर रहे हैं, तो always try to use the nylon or a proline suture. Then definitely, if your patient is, my husband is a psychiatrist, so I need to put one word psychiatry. So, in psychiatric patient or in medically compromised patient, yes, you don't want that the patient should revisit unnecessarily. You don't want that the patient should come to your clinic again and again for just suture cutting, so you can use the resorbable sutures as such. But yes, resorbable suture attract more of the microbes, so you need to be very meticulous in giving all the post operative instructions also. So you can read the microsurgical things in my book. That's a textbook of periodontics. So these are the suggested readings. If you want to go in details of the magnifications, if you want to learn about more of about the loops, then these are the suggested readings. Well, that's all from my side. I have my Zenith Academy, and we have been conducting the courses there related to perio implants and more of lasers. And there we have didactic lectures. It's not only the lecture thing. We do have the preclinical exercises there. And then, yes, we do on patients also. We make the delegates to do on patients, but definitely under the guided mentorship. And this is just a glimpse of the workshop. So these are the fabulous delegates which been there in my academy. So we celebrated 1 year of our academy last year. So ultimately, what we want that our patients should be happy, and so we are. So that's all from my side. Because of the shortage of time, we won't be able to play a game. It was a very, it was good enough, but I don't have a laptop and anything, so excuse me for that. So that's all from my side. I'm really thankful to Subharti Dental College. Um, I was a student in DAV when Nikhil sir and Vinita ma'am was there, and they both of them they taught me, and because of my teachers and because of my mentor, I'm what I am today. And so I'm really thankful to CynoDent also, and Dr. Anmol and Dr. Ashish were very kind enough. And thanks to Anamika ma'am, आपने मेरा काम आधा कर दिया, so I'm really thank you. And hello, Dr. Malika. So that's all from my side. And if you have any queries, I know it was a little sleepy thing. So if you have any queries, you can anytime catch hold me on the social media. And we have a workshop coming on 17th March. That's on laser. And yeah, tomorrow also I have one workshop. So that's the reason why I'm hurrying up everything. So you can catch me on my social accounts. So that's all from my side. Thank you, dear.
Thank you, ma'am, for this enlightening lecture. We would now like to felicitate Dr. Shalu Patla ma'am, Director Zenith Academy, Center for Perio, Implant and Laser. She also is the runner-up and the winner and awardee for Author of the Year award.
Thank you. I'm really sorry. I've been covering a lot.
Dr. Shalu Batla, ma'am, Director, Zayt Academy, Center for Perio, Implant and Laser.
Thank you so much.
Thank you so much, ma'am, and thank you for the wonderful session. Now, I would like to invite Dr. Gaurav Isar sir, Professor and HOD of Prosthodontics, Institute of Dental Studies and Technologies, Modinagar, present his topic on lab communication in digital dentistry era. Please, can we have a round of applause?
I would just request all the delegates who are sitting and seated behind to kindly take their places a bit front row.
A very good afternoon to all of you. My name is Dr. Gaurav. I am head professor and head department of prosthodontics in IDST Dental College, Modinagar. So now coming to my topic, which is lab communication for implant rehabilitation. Actually, along with being a very complex procedure, if we take few points into consideration, it's very easy and very precise method which with which we can get excellent results if we follow all the few points which I have mentioned and I've tried to cover to make the implant impression slightly easier for all of you. So now, first of all, happy Mahashivratri to all the people present here, and also happy International Women's Day to all the women who are present here from my side. I This is the lab in which I am director admin. This is my own lab. We have opened up in Okhla for basically and majorly for the implant rehabilitation procedures. This is my dental college where I am heading the department of prosto, and this is my clinical practice. Okay, so now coming to the topic, what is CAD CAM? It is computer aided design and computer assisted manufacturing or milling. So digitization, as you have seen in other fields of communication in dentistry also, nowadays everything has been digitized and it has made our work more efficient, precise, and we can go in a much more predictable way if we follow all the procedures. Uh, so now coming, why do we need CAD CAM? The reason is in the conventional steps of manufacturing dental prosthesis, there are inaccuracies which come into play at each and every step. First is an impression making due to shrinkage of the material. There you might induce some inaccuracies in your impression. Then followed by pouring the cast. Again, the material with which you are pouring can cause bubbles and all those things can again make your impression or the cast you get inaccurate. After this step, when we do design a crown with wax, it again has its own limitations, which might make the inaccuracies come into our prosthesis, which is followed by casting. As all of you must have read in your BDS curriculum also, there are many casting defects, porosities, and many inaccuracies which can occur during this casting procedure. So this is followed by casting in the casting furnace, which again has inaccuracies. And the finally, when we get the prosthesis out of compensating with all those inaccuracies, there still is slight lack of precision which might be there in the final prosthesis. So to avoid all these, we should always remember that this fabrication of a prosthesis is a very cumbersome process and also not so accurate. But thanks to the computers, this whole process has been digitized now. So continuing further, what is CAD/CAM technology and how it can be used in dentistry? So, in the beginning, the components of CAD/CAM. First is the scanner with which you digitize your cast so that you can design and then fabricate a prosthesis. So for that, we require a scanner. It scans the dental model and then gives you a 3D image of the same in the computer so that you can further proceed with your prosthesis fabrication. These scanners can be of two types. Either they can be lab scanners or intraoral scanners. Lab scanners first require your physical impressions and then you need to scan them. But with intraoral scanners, you can directly scan in the patient's mouth and the file can be sent to the lab immediately without any delay. And also, if there is any inaccuracy in your scanning, the lab can report back to you and with your patient in the chair. For example, sometimes what happens is when we take an impression and we send off the patient, after getting the cast also, we find that there were some inaccuracies which were there. So we have to repeatedly again call patient back and then do that procedure again. But with intraoral scanners, it has the advantage that it has artificial intelligence. So it will then and there only tell you if there is less amount of intraocclusal clearance, if there is undercut, or if there is any other fault in the impression, which you can check while scanning only immediately after that. And then if there is some inaccuracy, you can correct it there and then. So after intraoral scanning, these are the two types of scanners which are there. This is followed by the exact procedure. So once you have the image with you, then you can go in for fabrication of the prosthesis either by additive process or by subtractive. Additive process for fabrication is 3D printing and subtractive process is milling from a block. So for milling from a block, you require dental milling units. These are the production war horses of the CAD/CAM systems, which produce the final prosthesis. So these milling units can also be of variety of types. So how to choose which type of milling machine you require, whether you require a 4-axis milling machine, a 5-axis milling machine, dry or wet. So it all depends on the number of cases you need to handle, the software intelligence or the technician which you are having, how many software he is aware of, and what all materials you need to mill. For example, for zirconia, you just require a dry milling machine. But if you want to mill metal, if you want to mill titanium, or if you want to mill PMMA, then you require wet milling. So choosing which milling machine or how many number of axes should there be in your milling machine is a good question. For this, I would like to tell, since most of you are undergraduate students, any machine which is created to mill has to have motion in 3 dimensions, which are horizontal axis, depth axis, and the vertical axis. So these can be there in the milling tool itself. But the milling tool, this diagram is just showing you how that milling tool will move in the 3 directions. So for any simple milling of any cuboid, these 3 axes are enough. But what if you need to mill such complex shapes or such complex prostheses wherein you have different kinds of cast partial frameworks, or you have precision attachments which you have to mill, or abutments or customized abutments which are milled at angulations? These all are very complicated and cannot be done by just the use of the 3 axes of the milling tool. So therefore, another example is in a crown. If you can appreciate that undercut, if the tool is moving in just 3 axes, then we'll not be able to access that depth area in the crown, and we'll not be able to give a precisely fitting prosthesis. So for milling in such areas, we require a 4th axis, which is in the milling block only, other than the 3 axes in the milling tool. So this additional axis is known as A axis, and it can give a rotation of around 360 degree to the block so that we can reach those difficult to reach undercut areas. And in 5-axis milling machine, both the axes of the milling block can be moved. So we have much more versatility in the amount of uh, axes or tilts we can give to our block while we are milling the prosthesis. So what are the benefits with the tilt? the rotatory axis working in unison, any facet of the milling component can be oriented in the upward direction. With the sudden ability to orient any facet towards the X, Y, Z axis in which the milling tool is moving, we are able to reproduce such complex prosthesis also with the help of simple digital guidelines. So with all this, no geometry, no matter how intricate, is not beyond the machine's capability to mill. So now comes the question whether a person who's interested in buying a milling machine should go in for a 5-axis or a 4-axis. So what is the difference? The difference lies in their ability to do the undercuts, the type of restoration which is to be milled, the amount of material which you are planning to use, the tool life. Each machine has its own disadvantages when it comes to tools because they are the most expensive component which has to be replaced while you are doing any milling. So the misconception with this is there is a difference in anatomy of crowns milled with 4-axis and 5-axis mills, which is not true. Exact same full contour crowns can be milled from both 4-axis as well as 5-axis machines, and there will be no evident difference between the two. The major difference will be in the amount of time taken in milling. 5-axis are more important when we have to mill mesh frame for partial dentures and also in cases of screw retained bars where the screw holes are arranged at various disparate angles which are not parallel. So these are the situations in which we need to mill with a 4-axis or a 5-axis machine. So now coming to a few cases in which we are taken help from digitalization in rehabilitating our patients. So this was a full mouth implant patient which had come to my practice. So while you are discussing with the lab about any full mouth implant case, the key points you have to discuss with the lab are what should be the vertical dimension to plan the restorative options, whether we should go in for a tooth implant supported overdenture, whether FP1, FP2, FP3, whether this patient is suitable for Malo bridge or not. So all those decisions have to come from the vertical dimension which is available with us and which has to be given by the patient. So sometimes if we tend to decide excitedly before checking all the vertical dimensions, we may not be able to deliver the best type of prosthesis to our patient. Other thing is we also have to order custom tray for open tray impression. Verification jig as per the prosthetic design has to be ordered and the lab has to be told which all implants you are planning to join so that the same can be splinted in the at the time of jig trial. Occlusal rims are also a must. Every dentist should order an occlusal rim in case of full mouth rehabilitation because they will be very helpful in deciding the vertical dimension. So, as already told to you, discussing the vertical dimension to plan restorative option should be the first things. Sometimes because of supra eruption of opposing teeth, when the patient comes to us, there might not be any space left for giving any type of implant prosthesis. And if in excitement we place the implant before discussing this vertical dimension, later on we might face severe trouble during rehabilitation. So according to the prosthesis design, each type of prosthesis has different amount of restorative requirements. There is different amount of vertical required for an overdenture. For a Malo bridge, it's different. For a screw retained FP3 prosthesis, again, it's different. So all this has to be discussed. And after doing the proper vertical only, we should commit anything to the patient. Few important lab points which we need to remember are once gingival formers are placed, we should make an impression and send to lab to fabricate a custom tray because that is the most accurate way to record your impression. We should avoid using prefabricated trays which are available in our clinics. In case we want to splint the impression copings, then we should priorly tell to the lab that they should make sufficient space for the same in the impression tray so that later on we don't feel any problem. So this is the design of the custom tray if you want to splint your impression copings, and in this you can appreciate the amount of space they have provided for the pattern resin. So how to go about the steps? First, you have to use a dental floss to tie all the impression copings together. After this, you need to slightly make it stiff with composite, followed by pattern resin. Composite or acrylic should not never be your final material which are used for splinting. They can just be used initially to support the floss, but final jig should be made only with pattern resin. So then comes, this is the open tray impression. Once we have retrieved it from the mouth, this is how the impression copings look like. Then this is the analogs attached to those impression copings. Once we have done that, then we pour the cast and we can get such a jig. At the time of this jig impression verification jig also, what we should remember is that we should always confirm it radiographically, because if any of these copings are not seating perfectly, then we will have a problem later. See, in this case, what we are trying to show, sometimes we need to discuss the prosthetic design with the lab. Which all implants are we planning to splint in the patient's mouth? And accordingly, the lab can only splint those implants together for better precision of your or better seating of your prosthesis. Also, always remember there should be a gap of 2 mm below the jig, so that in case if the impression jig trial is not seating passively, you can break it in those areas and then you can take a re-impression. And for that impression material to flow correctly and record all the tissue details, this 2 mm gap below the pattern resin is very important. Okay. So what all points we have to remember for jig trial? It should be passively seating. If we apply force and seat our jig trial, then because of the flexibility, the pattern resin might sit in the patient's mouth. But once the casting is done, that rigid metal will not flex. So always remember that your jig trial should be very passive seating. You should not apply much force on it while you are placing it, because otherwise, if you apply force and get a seating, do an x-ray, it is perfect, but later on when the metal is casted and it comes to you for metal trial, it will not flex, so you will have inaccuracies there. Also, you should ask the lab to resend one more custom tray along with the jig trial, because if there is any issue with the impression which was taken earlier, it can be repeated on the same seating. You don't have to again order a custom tray. And in case of a digital impression also, you should always ask your lab to send a custom tray in case you need to repeat a impression. And then in those cases, you can always do it physically with your uh, materials. Next thing is, after you have verified your jig trial, you should always ask lab for a screw retained wax bite to establish jaw relation. Otherwise, what happens is, if our bite is not screw retained, then it is just lying over the soft tissue. And sometimes because of the movement, we might be able to record a slightly inaccurate jaw relation. So after the screw retained bite comes the screw retained teeth trial, just to show the aesthetics of the final prosthesis to the patient. In this seating only, we can discuss with the patient that whether he likes the aesthetics of all the teeth or not, whether he wants larger teeth, smaller teeth, what is his feedback, whether the proclination of all teeth are correct or not. And if we give the patient such opportunity, then we are making him a part of our treatment planning, and he'll be more satisfied with the results in the later stages. Also, always remember that never you should make a verification jig using UCLA abutments, because they might get damaged and seat that time, but later, as I already told you, the final metal will not seat as those UCLA abutments did, because they were made of plastic. Also, we should remember, as told, we should not splint implants with composite resin, flowable composite, or acrylic resins. Always use pattern resin or BIS GMA like Protem. Now coming to one case which was done following the digital protocol. These are the scan bodies in a completely
With the diode. I'm not talking about the erbium yak. With the erbium yak, you can use a non-contact mode also for excision. Okay, with the soft tissue, you have to use contact mode, because The fiber optic delivery system delivers your laser energy in contact fashion. This photobiomodulation is done in non contact mode. If you want your cheeks to glow, take laser. Okay, this is for the girls out here. Take laser, put it on your cheek. Your cheeks will glow. They will be red. Why? Because laser is set to increase vascularity. Okay, vascular supply is increased. So, photobiomodulation works at the molecular and the cellular level. Vascularity is increased, growth factors are increased ATP synthesis from the mitochondria. Okay, cytochrome C oxidase, everything is at the molecular level. I have used LLLT for ortho patient. One case is going on. She was complaining of severe pain immediately after I've started with the ortho treatment. I gave her LLLT, immediate relief. Desensitization, I'll be showing you cases, immediate relief. TMJ disorders, immediate relief. But you have to repeat the session. Well, it follows the Arndt-Schulz law, where a therapeutic window basically exerts both effect, that is biostimulatory and bioinhibitory, and this is what is photobiomodulatory treatment and is the intended target for PBM treatment. I will not go into the detail. I will confine myself to lasers like photobiomodulation in periodontics. Otherwise, I can go on and on because laser is very, very vast. You can use it after ortho treatment, you can use it in perio, you can use it in prosthetics, whatsoever. You can use photobiomodulation after every treatment, that is post-operative care and immediately post-operatively, every orthodontic adjustment visit once or twice weekly. Now, as far as periodontitis is concerned, can you see this case? Massive destruction. Now, laser helps to stimulate periodontal fibroblasts. It reduces pocket depth, reduces gingival fluid, increases your MMMPs. It is all acting at the molecular level. Bone regeneration. How? Because it allows for bone remodeling. It stimulates your osteoblasts, which helps in formation of bone. A very interesting case where I've used photobiomodulation. See, why I've written LLLT? You should say photobiomodulation because the previous term was LLLT. Now the term has been changed to photobiomodulatory treatment. So this case, a case of management of intra-bony defect with photobiomodulation, you can appreciate the defect depth measurement after a mucoperiosteal flap is raised. Now, my power, please remember and please listen, my power for photobiomodulation will be 0.5 or 0.1. It will not be 1.5 or 1.2 or 1. That is all preset because this is low level laser treatment. Less amount of energy is reaching the tissue. So the power will be 0.5 watt because as I mentioned, it is between 50 to 500 milliwatt. So 0.5 watt diode laser applied for 2 minutes, repeated after 5 minutes for 90 seconds. DFDBA, that is allograft, was placed here, followed by suturing. Now, you can do photobiomodulation or biostimulation immediately after suturing. You can lace both the buccal and the lingual flap. Recall the patient after 48 hours, recall the patient after a week. There will be no side effect of photobiomodulation. No adverse effects have been reported with photobiomodulatory treatment. And just see the results. This is 1 year follow-up of the case. Can you see that circle? Can you see the bone regeneration which has happened? So laser is set to regenerate bone. Why? Because it is stimulating the osteoblasts. Bone remodeling is taking place. 1 year follow-up of the case. Now, another area where you can use photobiomodulation is, I don't know how many of you have seen or done, when you harvest a free gingival graft from the palate, massive, like profuse bleeding is encountered. Okay. How do you stop bleeding? Obviously, application of pressure. You can use laser to achieve immediate hemostasis. So this case, again, a 940 nanometer diode laser used here, 0.5 watt. LLLT is done in non-contact mode. You can lace the area for 30 to 60 seconds, and that is immediate post-operatively, where immediate hemostasis is achieved. I talked about This is out of perio, but a very interesting case. Massive tongue bite, profuse bleeding happening after the tongue bite. I used laser for hemostasis. How do you use laser? Can you please play the video? So hemostasis, the mode is 0.5 watt. See, it is all preset. Laser machine comes with preset values, so you have to set it. Now this is 0.5 watt for hemostasis. This is the clinical armamentarium. This is Epic X 940 nanometer diode laser. So biostimulation was done at different points. See, you don't have to keep the laser at one point only. Please, if you place the laser at one point, you will end up having heat buildup. Okay, just use a scanning motion and just laze all the areas. So this is in non-contact mode. You cannot touch the tongue with this. This is in a non-contact mode. And laze it for 60 seconds. That is sufficient. And just see, this is immediate post-operatively. This is 2 days. That is the normal course of healing, 12 days and 7 months post-operatively. The patient is very, very happy because see, laser helps in good hemostasis. Now, another interesting case, desensitization. Again, this is a part of photobiomodulation. Laser is used as an adjunct to your desensitizing paste. The combination therapy is of much interest nowadays. Again, this case, a 940 nanometer diode laser was used in continuous mode, 0.8 watt. Can you please play the video? So the first step is application of your desensitizing paste. Leave it in place for 10 to 20 seconds. 20 seconds is sufficient. For desensitization, you have to laze points. Okay, that is the mesiobuccal, the mid-buccal, and the distobuccal. I'll be showing you. So this is the Epic X. So laze the mesiobuccal, 20 second, mid-buccal, 20 second, and distobuccal, 20 second, 60 second per tooth. And believe me, the results are just amazing for desensitization with the laser. Non-contact mode. You're not touching the tooth because you're using a soft tissue laser. You're not using a hard tissue laser. It is not meant for hard tissue. So likewise, you laze all the teeth. Except for 2 teeth where I had to do root canal treatment. See, the first sitting, this patient reported with 100% sensitivity. Okay. Except for 2 teeth when she reported to me second time saying from VAS score of 10, she had come down to 1. I have a video also, except for 2 teeth where she was still complaining of sensitivity, and those 2 teeth were meant to be taken care by root canal treatment. So 2 teeth root canal treatment was done. See, when do you decide whether you have to do a root canal treatment? When you've already given 4 to 6 joules of energy per root and your patient is not responding, please do root canal treatment for that particular patient. If you can play the video and if I have time to play, then that will be appreciated. So this patient was very, very happy with the treatment.
मैं आपके पास 23rd December को आई
So you can ask the patient a recent case of ortho, very, very happy. So all these are,
मीठा ठंडा गरम बहुत लग रहा था but after laser treatment I am feeling much better. Almost 100% है जो फ्रंट के टीथ है, बाकी में रूट कनाल किया है और उससे आज क्राउन लगाने के बाद में और भी बेटर हो जाएगा, बट लेजर से आई एम फीलिंग मच बेटर.
Another case, an NRI I'll show you his video. When he actually stepped into my clinic, he said, he came for some other reason, like he had some RCTs, crowns, and everything. So he didn't know that his sensitivity can be treated with laser. He had a chief complaint of not having ice cream since he was a child. Okay, so he was so happy to know that that can be treated. I used the similar protocol I showed you. EpicX 940 nanometer diode laser used at zero point 0.8 watt in non-contact mode. All sides, all teeth were lased, and this is what the patient had to say. Can I play the video, please? Can you please play the video?
I came to Guns Scholars to meet Dr. Malika Sethi, and after coming here, the experiences and the treatments that I've had has been a life-changing experience for me. Why I say that is because since childhood, I had a sensitivity problem that even as a child, when I was in standard three, I could not enjoy ice cream because I couldn't bite it because the sensitivity levels were beyond sparkling in my head. So getting my treatments done here, I spoke to her, and after speaking to her, she told me about this new technology that she has, and that is the laser treatment and sensitivity that she performed on me. And I can tell you this that if it was about 100 earlier, now it's come down to let's say 1% or probably not even noticeable. So it's a life changing experience. Now, I've met a lot of doctors, and I've met where I live in Australia, and I've met a lot of dentists overseas as well who have not communicated this thing to me. Coming down to Dr. Sethi, I have seen the way that she's performing that treatment. It has been mind blowing because it was painless. It was something that I actually enjoyed. And I'm walking away today with this sense of confidence that now I can enjoy my experience, which I couldn't fulfill my dreams as a kid. I can do it now after meeting Dr. Sethi. So it's been a mind blowing experience. I would like to thank you for the way that you've taken care of me because I've come from Australia and I've had my treatments there, but this is probably the best treatment that I've had in all these years that I want to spend outside. Thank you.
So the other day I was at Max Vaishali performing for cancer patients. Okay, there was a case of leukoplakia. I've not talked about lesions. I've not talked about ortho, prostho. I'm just limiting myself to perio. Photobiomodulation for a case of leukoplakia. Instant relief of pain, lichen planus, instant relief with photobiomodulatory treatment. So, well, right here, important points to remember. LLLT is said to be non invasive, non pharmaceutical. The impact of low level laser treatment is through its non heating effect. There is no heating which is happening there. There are no true side effects, myriad of positive effects like positive functions like accelerated wound healing, regeneration, and immune enhancement. Please remember this point. The effect is most prominent in cells with reduced redox potential. Effect on healthy cells is less as compared to cells having reduced redox potential. Well, light energy is said to be more easily transmitted through mucosa and fat than muscle, and you can improve or increase your penetration by moving the laser close to your target area. Well, these are the treatment dosages which have been suggested. As I mentioned, photobiomodulation is said to promote tissue healing, reduce edema, inflammation, and pain. Little bit about dental laser safety. Well, what is laser plume? Laser plume is the white fume which generally comes out, and it is made up of carbonaceous material, particulate matter, cellular debris, etc. I will not go into the detail, but you have to wear protective eyewear, use gauze dipped in saline, and use high volume suction. Protect the patient's eyes, throat, and the oral tissues outside the target area. Otherwise, you will end up having retinal and corneal damage. Retinal damage, well, I'm just finishing my lecture, just 2 minutes, I think. So, retinal damage with deeply penetrating laser, corneal damage with superficial lasers like the erbium family, retinal damage with the diode, that is the the NDR. They are deeply penetrating lasers. Now, important points here: do not operate the laser in the presence of flammable or explosive material. No nitrous oxide should be in your vicinity. That is why in children, conscious sedation, you cannot use laser. One should always remove the fiber cleaved remnants, throw it in a sharp container, dispose it off that way. You don't have to keep it here and there. The fiber connector should always be covered either by the fiber or the protective cap. You should always remove your finger rings, watches, everything. Do not place the metal instrument right in front of the laser, because what will happen, your laser energy after striking the metal instrument will directly hit the eye. Do not look at the laser directly. Okay, wear your protective goggles. If there is cracking or they are like getting worn off, please replace it. One more important point as far as your goggles are concerned, if you're using a 940 nanometer diode laser, please do not use goggles of a 980 nanometer diode laser. Goggles are specific for specific laser machine. You cannot use a hard tissue laser and wear a 940 nanometer diode laser goggle. Well, I would like to end my presentation with this American Academy of Periodontology best consensus statement on the efficacy of laser treatment used alone or as an adjunct to non-surgical periodontal treatment. Well, this was quoted by Mills in the year 2018 and Hong Lei Wang et al. The first question which was addressed was, in patients with moderate to advanced or severe periodontitis, do lasers used alone or as an adjunct is beneficial? And the authors concluded that slightly better clinical outcome compared with laser treatment used alone. Please remember, laser is always used as an adjunct and not a mono treatment. Current evidence fails to demonstrate a relatively long-term effect. Short-term effect has been demonstrated. See, I believe in evidence-based dentistry. The third part, adjunctive use of two lasers, that is the erbium family and the Nd:Arg, they have been found to be superior in deeper pockets. If you have pockets which are more than 5 millimeter, laser will work very well. Now, as far as the second question was concerned, which was related to mucositis or periimplantitis, no substantial evidence of using laser in mucositis has been demonstrated. But yes, short-term benefit as far as periimplantitis is concerned. Mucositis is just the inflammation of the mucosa, but when it reaches the bone, it leads to what is periimplantitis. So no long-term effects have been demonstrated. Third is, I've not talked about APDT because that was not my topic today, but APDT, that is photodynamic treatment, that is laser, light, and a dye, or a decent, that is a dye. You can use methylene blue, indocyanine green. So the effect is bactericidal effect, that is killing of the bacteria. And APDT provide improvements in residual probing depth and clinical attachment level in pockets, especially if they are more than equal to 5 millimeter, that is deeper pockets. Expert opinion suggests that the use of laser on healthy sites can cause harm rather than benefit. And as I mentioned before, if lasers are not used according to the proper protocol, damage can occur to the teeth, implant, or surrounding tissue. Well, thank you so much. And this has been my journey. I have lectured at various national and international platforms. So this was at Dhaka, where I conducted a laser workshop. This was in Lucknow, IDA Faridabad, and UP Dental Show 2022. Delhi Dental Show, well, consecutively, 1920 was not there, 2022. This was at the recently concluding the most prestigious conference, 46th National Conference of Indian Society of Periodontology at Orissa. This was a CD program at Agra. This was at Shree Aurobindo College of Dentistry, Indore. 40th IDA MP State Dental Conference in Bhopal in 2023. Well, this was a workshop at Mansarovar Dental College. This was a 3-day laser workshop. I was invited by the government of Bangladesh to conduct a workshop at Chittagong Medical College in March-April 2023, where I also delivered a lecture at the International Symposium of ABCD, that is the Academic Based Clinical Dentistry. This was at Rishikesh, Seema Dental College. Well, this was, I think, the last year, Sharda Dental College, April 2023. This was a keynote lecture in my own college, ITS Dental College, in June 2023. Well, I was also one of the panelists, and I'm also into, uh, while I'm a certified tobacco cessation specialist as well, and I was a panelist at the first master's training in tobacco cessation at Faridabad. This was a keynote lecture at KGMU Lucknow, where I conducted a workshop also, and this was recently at Government Medical College Sealet, where I was invited for the third time in October 2023. Well, this was at Max Vaishali. This was at IP Dental College. And this is my own venture in the heart of Gurugram by the name of Gamzopolis. Well, thank you, ladies and gentlemen, for your patient listening. And this is my website, my email, and my contact number. If anything you would want to ask later, you're most welcome. Thank you once again.
Thank you so much, ma'am, for your kind words. Now, I would like to call on stage Dr. Ashish Chandra sir, Dr. Anmol Bagaria ma'am, to kindly felicitate our speakers. I would like to call Dr. Gaurav Isar sir, Professor and HOD of Prosthodontics, Institute of Dental Studies and Technology, Nagar, for felicitation. Can we have a huge round of applause, please? Dr. Gaurav Isar sir. Thank you, sir. Now, I would like to call Dr. Malika Sethi ma'am, MDS, Periodontology and Implantology, for felicitation. Dr. Malika Sethi ma'am. Thank you so much, ma'am. Now, I would like to call Dr. Monish Raza sir, Associate Professor, Department, Orthodontics, IDST, Nagar, for felicitation. Dr. Monish Raza sir. Thank you, sir. Thank you, ma'am. Thank you, sir. I would like to request Dr. Muniz Raza sir to please continue on the stage with his topic, Unraveling Impacted Maxillary Incisors, the why, when, and how.
Have to go back. Yeah, it's only going forward. Good afternoon, everyone. The topic that I'm going to discuss today is unraveling impacted maxillary incisors, the why, when, and how. So, impacted incisors are one of the most common anomalies that can be seen clinically. And most often, the patients come to us with the chief complaint of aesthetics, the compromised aesthetics. Imagine someone who has a missing incisor, especially imagine someone who has a missing maxillary incisor.
So how compromised the aesthetics would be. So as an orthodontist, I have seen almost like in last 1 year, I have seen 5 6 cases, which is speaking a lot because 5 6 cases of impacted maxillary incisor, or for that matter, missing maxillary incisor, is something that should have been rare, because impaction is a word that is commonly associated with third molars, or for that matter, to certain extent, lower premolars, or to certain extent, the canines. But incisors, it was supposed to be very uncommon. So it is usually detected between 7 to 9 years. It has a variable incidence reported in literature, 0.06 to 2%, 0.2%. It is the third most commonly impacted tooth after the third molars and the canines. It is more common in males, and it is frequently associated with other dental anomalies, enamel hypoplasia, supernumerary teeth, or ectopic teeth. Delayed eruption. The terminology delayed eruption is generally considered when the eruption of the contralateral incisor has already happened 6 months prior. Second thing is the maxillary incisors are not erupted 1 year after eruption of the mandibular incisors. And third situation would be significant deviation from normal eruption sequence. So we all know that there are specific times and there is a specific sequence when the teeth erupt. And if there is a specific amount of deviation, and that too, it exceeds for a period of, let's say, 1 year, then you can clearly state that that particular, for that matter, might be impacted. The most common causative factor are local factors. Now, among the local factors, it can be a retained primary tooth, it can be an early loss of a primary teeth, or it can be without space loss. Like if at all there has been a loss of a primary dentition, but the space has already been occupied by the mesial drifting of the lateral incisor or the distal drifting of the contralateral central incisor. So as you can see, this is a CBCT image, the occlusal photograph. You can see that apart from the normal regular teeth, there are too many supernumerary teeth, which has led to a lot of crowding and obviously some amount of obstruction. There might be a history of trauma. Then there might be a localized pathology like a supernumerary tooth, most commonly an odontome or maybe a cyst as well. Supernumerary teeth in premaxilla resulted in failure of eruption in between 28 to 60% of cases. Ectopic position of a tooth bud, maybe because of trauma or maybe because of some kind of genetic factor. Other reason could be a case that already has a cleft lip and palate. Trauma can lead to premature loss of a deciduous tooth. It can also lead to dilaceration, which, as we all know in our BDS curriculum, we have read that it is nothing but an acute bend, either in the crown or the root portion of a particular tooth. Now, if at all there is a case where the tooth has been exposed to some amount of trauma, or maybe a deciduous dentition was exposed to trauma, which would have led to a deviation in the pathway of the permanent tooth bud, or if at all the permanent tooth bud had evolved and then there was a trauma, then it could have led to a dilaceration. Dilacerated tooth rarely come into the right path. Okay. Apart from that, there can be an arrested root development. Arrested root development will inhibit any kind of potential for the incisor to come out. Then we have intrusive luxation, a very common injury in early childhood because of trauma that children can get exposed to, which will lead to an intrusive luxation. What all is requirement when you're considering any kind of case where there is an impacted incisor? I'm not talking about specifically impacted incisor. This is a general protocol, whether it's impacted canine or an impacted premolar. So one thing would be a detailed medical and dental history. There might be syndromes, there might be drugs that might be, just aggravating the whole process of getting the tooth impacted. Then there can be a history of trauma, as I stated earlier. Clinical examination, you need to observe whether or not there is a retained primary tooth. If at all there is a retained primary tooth, then you can imagine that, okay, fine, it is well beyond the time of exfoliation. So there might be a cause or relationship between the cause and effect of an impacted incisor. Apart from that, what you can do is you can palpate. When you observe the vestibule, when you palpate the oral cavity, and if you suspect that there might be a case of impacted incisor, then you can palpate. If at all you feel a bony prominence or a protuberance on the buccal aspect or on the palatal aspect, you can be sure of that there might be an impaction. Space available. Okay. Now, this is also a very important factor. Whenever you are considering a tooth to erupt in the oral cavity, specifically the incisors, that is the lateral and the central incisor, then certain amount of space, specific amount of space has to be there. For that matters, 9 mm is for central incisor and 7 mm is for a lateral incisor. If you feel that there is loss of space, then in those cases, you can be rest assured that this can lead to impaction. Palpation, as I stated earlier, unerupted tooth may be palpated high in the sulcus. It has to be a labial or palatal bulge. And then alveolar ridge widening may be present at the level of impaction, as it's clearly evident in the clinical photograph. Dilacerated incisors need to be palpated high in the sulcus. Now, this is a little bit more important if you're comparing the etiology, like if the etiology was simply an odontome or maybe a retained maxillary deciduous incisor, then the palpation would be just above the crestal bone, just above the crestal bone. But when you're talking about a deep, impaction, specifically because of dilaceration of an incisor, then you need to palpate deep into the vestibule, maybe up to the anterior nasal spine, okay, just below the nose. Now, radiographic examination. The most common radiograph that any dentist would take is an IOPA. All right. You have a missing tooth, you simply go for an IOPA and then you visualize whether a tooth is present or not. If you want to assess whether the tooth is present buccally or lingually, you can go for a slot technique. I think you must be aware about that. There is horizontal parallax, there is a vertical parallax. Horizontal, same lingual, opposite buccal. Vertical, in this, we usually go for an occlusal radiograph and a bite wing radiograph. Angulation, 70 degrees, simple. Apart from that, you can have um, advanced radiographic techniques. You can go for an OPG, you can go for a lateral ceph, and of course, you can go for a CBCT. Now, the best case scenario would be you go for a CBCT and then you are able to visualize, even without going for slop, horizontal and vertical, you'll be able to visualize where exactly is the position of the crown, where exactly is the position of root. All right. It's a 3D MRP simulation that you can obtain, and you can actually calculate the linear distances from the apex of the bone. You can calculate the linear distance as to how much is the depth of the impaction. You can also calculate the amount of distance that the crown is separated from the adjacent tooth, whether the root is separated or not, what is the thickness of the cortical bone, what is the thickness of the cortical bone buccal, what is the thickness of cortical bone palatal, if at all there is any chance of fenestration. Just a little bit about the classification system. We usually follow one particular classification, that is Mitchell and Bennett classification. It is totally based on the vertical distance, as you can see in the diagram. So what we usually classify it as, if it is vertical distance is within the coronal one-third of the adjacent tooth. So in the first case scenario, the adjacent tooth is a lateral incisor. So if the vertical distance, the D, is near to the incisal one-third of the lateral incisor, then it is known as near. If it is in the middle one-third, then it is mid. And if it is more than that, then it is known as a greater displacement. More the depth, more the complexity, more will be the time taken to get that incisor into the arch. All right. Another one is the Swex classification. This is also grade 1, 2, 3, 4. It is basically based on the development of the root. Apart from that, we have Bryan et al.'s classification. It is based on the angulation from the mid-sagittal plane. So if you have a patient, you draw a midline and then you calculate the angulation. What is the angulation of the impacted tooth? The greater the angulation, the more unfavorable the treatment would be. The more complex the treatment would be. The more time taking the treatment would be. Less the angulation, that is more vertical impaction, the chances are that you will be able to finish the treatment, let's say in the stipulated period, maybe 6 months plus minus. Apart from that, we have Smilane's et al. Classification. This is again based on the adjacent teeth, but we are not specifically taking one particular adjacent teeth. We are taking the entire anterior dentition. Now, what are the general principles of management of these kind of impactions? So the general principle is that you need to have adequate space. There is a reason that maxilla is shaped in a certain manner, and there's a reason mandible is shaped in a certain manner. The maxilla has to accommodate a certain number of teeth, mandible has to accommodate a certain number of. This is just not science. This is just simple, what we have, understood over the period of years. So if you have lack of space, it will lead to crowding. Crowding will only happen when the tooth has actually erupted into the oral cavity. But if the tooth has not erupted into the oral cavity and the path is getting deflected, it will definitely lead to impaction. That's for sure. The next would be removal of obstruction. In general, whenever you're talking about impaction, there has to be some kind of roadblock. You need to remove that roadblock. Whether it's a supernumerary tooth, whether it's a thick gingiva, you have to remove that. Unless you don't remove the obstruction, you will never be able to imagine a tooth coming into the proper position. As simple as that. The next thing is spontaneous eruption. It has been observed. It's God's gift, actually nature's gift, that when you remove the obstruction, and let's say the patient is in the age of 9 to 10 years of age, you remove the obstruction, you don't have to do anything, you don't have to probably do orthodontic treatment, you don't have to go for an surgical exposure. The tooth will erupt spontaneously on its own. All right. Apart from that, surgical exposure with without traction. Now traction simply means किसी चीज को खींच के लेके आना. ठीक है. तो अगर दांत हड्डी के अंदर है तो we need to get it out. Okay, and that can only be done through surgical traction. So what we usually do is, I'll explain in later slide. We go for an exposure, we remove the gingiva, we drill the bone, expose the tooth, get the tooth down through orthodontic treatment. Definitive principles. All right. Definitive treatment depends on patient and dental factors. Potential risks of treatment can be failure of eruption, there can be an ankylosis, there can be an external root resorption, and there can be poor gingival aesthetic. What are the patient factors? Medical history, dental history, compliance, age. Now, age is very important. Spontaneous eruption can only be imagined at a certain age group. You cannot imagine a 30-year-old male patient or female patient for that matter to suddenly have an appearance of an impacted maxillary central incisor. Spontaneous, it is not going to happen. Be realistic. Next is optimal age for surgical removal is unknown. Now, I went through every literature possible. You know, there are recent guidelines that were given by Royal College of Surgeons. They were given in 2022, I believe. That is the latest one. There is no specific age when to go for surgical intervention. So what we generally follow is a general guideline. अगर दांत impacted है or adult patient है, root development is proper, ankylosis is not there, go for surgical exposure. Don't try to complicate things. Don't have this notion that it is going to erupt spontaneously. That's not going to happen. Now, dental factors, just brief, three factors: position of the impacted incisor, stage of development, type of supernumerary. As I've discussed in the previous classifications, position of impacted incisor, the more the high an impacted incisor is inside the bone, the more complex the treatment, the poorer the prognosis. Second thing is stage of development. Now, if you feel that 2/3 of root development has happened and still the incisor hasn't erupted, then you need to intervene. If 2/3 of root formation has not happened, see, we have learned in our basic sciences that whenever you're talking about tooth eruption as such, then we know that there are no last stages of development. All right. First, there is the bud, then it's the crown, then it's the root, and then final is the apical foramen closure. So what happens is that when you're imagining a development as such, the actual potential of to erupt in the oral cavity lies in the concept that, okay, fine, 2/3 of root formation is still left. That means there is still some potential in that particular to erupt in the oral cavity. That potential is lost once the entire root formation has already happened inside the bone. So you need to take that into consideration. Apart from that, type of supernumerary. Tuberculate and odontomes are more likely to obstruct with greater displacement of incisor. 1/3 compound, half complex odontomes prevent eruption. That has been clearly dictated by the systematic review given by CATS. Dilaceration I've already discussed. We know that dilaceration can be one of the very common factors that can lead to impacted incisors. Now, management options. First is removal of obstruction. Second is removal of obstruction with creation of space. Third would be surgical exposure. Fourth is incisor removal. Fifth is autotransplantation. Removal of obstruction. As I stated earlier as well, most of the times, if you are imagining any kind of case where there might be a chance of spontaneous eruption, you need to remove the obstruction, whether it's a supernumerary or the odontome or whether it's a thick gingival fiber. Create adequate space. Now, this is where the orthodontic treatment comes into play. So, 30 to 55% of incisors will require surgical intervention and orthodontic alignment. 82% incisors reported to erupt when combined with expansion. Expansion means maxillary arch expansion, I'm talking about. With or without extraction of primary canines and sectional or full arch fixed appliances. four aspects that are very important. First is appliance should be able to level, rotate with controlled crown root movement and open adequate space. Hold space during an after surgical procedure should generate light control extrusive force and final detailing. Now, this is a little bit too much for probably you guys, but this is simply as an orthodontist what general guidelines we follow. So, in simple words, this is now rocket science. Whenever you're talking about orthodontic treatment and when you're seriously considering taking orthodontic treatment for space creation, for disimpacting that particular tooth, you need to take into consideration that the appliance should apply low possible forces, low continuous forces. The appliance should be able to hold space if you're opening the space. The appliance should have some amount of extrusive component. I'll discuss it later. And the appliance should be able to 3D control that particular incisor. Surgical exposure. First of all, there is lack of evidence. There are two surgical protocols that we usually follow, but there are no concrete guidelines that are still available with respect to the type of surgical procedure that we usually opt for. What I'm going to discuss is what the South Asian countries usually follow. There are European ideologies, there is American ideology, and the South Asian ideology. So South Asian ideology is generally a culmination or a, more of like an additive factor that has taken best of the both ideologies, and they have created their own. So surgical exposure, you extract that particular supernumerary tooth, and in the same exposure you have already given local anesthesia, you have gone for extraction of the supernumerary. In the same appointment you go for widening of that socket, you go and expose that particular incisor, you place a bondable attachment, and with the help of orthodontic treatment you get that tooth out. As simple as that. So now coming to the exact protocol with respect to surgical exposure. Now, there are two kinds of exposures. There is one known as open exposure, the other one is known as a closed exposure. So, I believe all of you are through with perio as a subject. No. You are in which year? PG first year endo. तो BDS तो किया ही होगा. So, whenever we are talking about perio treatment, I am not the expert. I'm an orthodontist. I'm not a periodontist, but little bit knowledge that I have is that whenever we are talking about periodontal treatment, we talk in terms of the thickness of the flap. So there are two major kind of thicknesses that a flap curtails, and one is the apically positioned flap. The other one is a full thickness mucoperiosteal flap. Apical thickness flap is simply raising a flap and positioning it apically, just adjacent to a particular tooth. And full thickness mucoperiosteal flap is raising through the thickness of the periosteum up till the mucosa, raising the flap, exposing the incisor, closing the flap. Getting my point? While in apically repositioned flap, we are not opening and closing it entirely. We are just opening, taking it apically, and suturing it. All right. So there are two techniques that we usually follow whenever you are talking about open and closed exposure. Open exposure simply means कि एक window create करनी है. Now window create करने के लिए we go for an apically repositioned flap. Then there is a closed technique. The closed technique means that you have to raise a full thickness mucoperiosteal flap. Okay. The advantage of open technique is that since suppose I'll just show you no. So suppose let's hypothetically there is an impacted maxillary central incisor in the second quadrant. So you went for OPG, you saw that the positioning, the vertical positioning of the incisor is not too deep. So in that case, what you did was you raised an apically positioned flap, you expose that incisor, you place a bondable attachment, and with the help of orthodontic treatment, you were able to get that tooth down. The closed technique would be to raise a full mucoperiosteal flap, you place an attachment, attach a wire, close the flap, suture it back. All right. The advantage, ideal attachment, low profile, bonded to palatal surface to reduce risk of fenestration. Take photographs with flap raised and attachment bonded to plan the direction of traction. And superior results for closed technique, gingival and periodontal status is definitely better. Open eruption is associated with longer clinical crowns and decreased bone support. Incisor removal. Now, when do you consider removing an incisor? The most common ones are ankylosis. So there is significant dilaceration. You can think of entire surgical removal of that particular incisor or ankylosis. Then you can plan a prosthetic replacement with an implant. You can plan for sufficient alveolar bone, may leave the interrupted tooth in situ or bring tooth in line of arch even if extraction is planned later. Move lateral to the central incisor position and allow spontaneous space closure and reopen space prior to replacement. Now, in simple words, if at all you feel that the dilaceration is too severe, go for extraction. If you feel the ankylosis is there, go for extraction. The other situation would be if at all you're going for extraction, then you need to preserve that bone. We all know that once we extract a particular tooth, there is a lot of bone loss that happens. What I am talking about may be a patient who's 10 or 11-year-old. 10-11 साल की उम्र में you extracted a particular incisor and then you say that okay fine and maybe at the age of 16, 17, 18 I'm going to place an implant, but there's a gap of let's say 7 years. 7 years there will be a lot of bone resorption, so you need to maintain the thickness of the bone and the vertical level of bone. So in those cases what we usually do is even if the prognosis is bad, you try to get that tooth into the arch. I'm not talking about ankylosed tooth, I'm talking about dilacerated tooth. You try to bring that tooth into the arch so that the level of the bone is maintained, and later on when the patient has come of age you can go for extraction of that incisor and then straight away go for implant. What the benefit out of it would be the width of the alveolar bone and the vertical level of the alveolar bone is maintained. So as you can see in that particular on the right lower corner, you can see that there's a crown with negligible root, and you can see that this is a clear-cut case of trauma which has led to an intrusive luxation. Ankylosed incisor, composite buildup if infraocclusion is minor. All right, you can go for simple infraocclusion cases and go for a composite buildup. This will give you a good enough aesthetics. Apart from that, you can go for a repositioning of ankylosed tooth with osteotomy or distraction osteogenesis, like a localized distraction osteogenesis, just to bring that particular incisor into the right position. Apart from that, you can go for extraction of incisor followed by space closure, as I stated earlier. Decoronation of incisor to preserve the bone. Remove the crown, let the root be there. This will preserve the bone. Later on, when the patient comes of age, you can go for an implant. Apart from that, extraction followed by prosthetic replacement. Auto-transplantation is one another feasible option. Most often, we go for second premolars, lower second premolars. So the advantage is that the same patient is donating a one particular premolar and it is placed auto-transplanted into the cavity of a central incisor. Later on, aesthetic treatments can be done just to simulate the central incisor. Now, these are the Royal College of Surgeons guidelines that are given in 2022, as I stated earlier. Now, these are just the rule books that we follow in the Department of Orthodontics. So patients aged between 7 to 9 years presenting with eruption disturbance of maxillary central incisors should be sent for orthodontic assessment. Secondly, remove the obstruction and create space. This is a rule. It has to be followed in every case. Third is less than 9 years with immature incisors, allow 9 to 12 months for spontaneous eruption. More than 9 years with mature incisors, that means mature incisor simply means that two-third root formation has already happened. Now, in those cases, go for a surgical exposure at the time of removal of the obstruction and followed by bonding of orthodontic attachment. Desirable to avoid multiple procedures under anesthesia. So you don't need to go for surgical exposure multiple times. You are extracting your supernumerary in that same appointment when the flap has already been raised. You can go for your exposure. Apart from that, assess patients' compliance for surgical exposure and orthodontic traction. That is very important because ultimately it all boils down to the compliance of the patient. Dilacerated maxillary incisors should be aligned in the arch with close traction if possible, and multidisciplinary approach is recommended. As an orthodontist, I can get the tooth into the arch. I cannot alter the anatomy. I cannot give you aesthetic modality like composite restorations of the crowns. Now, these are some of the few cases that I treated in the last, let's say, 3 years, 4 years, I believe. These all were cases treated by me in Department of Orthodontics. All of the cases were of impacted incisors. So this is a 10-year-old girl. She complained of missing tooth in the upper front tooth region. These are the intraoral photographs. You can see that she has a retained, not retained, she is in a mixed dentition stage, and there is a maxillary incisor that is missing in the second quadrant. And this is the OPG. The vertical level is high, but it is not that much angulated. So since the angulation is less, it is more vertical, so the prognosis is good. This is the CBCT. You can see Now, interesting fact about this particular patient was that when she reported she was 10-year-old and almost 5 to 6 months back, she underwent a few extractions in some other dental clinic, and we contacted that particular dentist. So he stated that there were too many supernumerary teeth present in the anterior maxilla. So we were able to corroborate and correlate the etiology. So too many supernumerary in the anterior maxilla could have led to the impacted incisor. So next we went for a CBCT. We thought after the vertical positioning, we saw that, okay, fine, the angulation is fine. Yes, the vertical height would be a little more, but I think a surgical exposure, probably a closed eruption technique can be followed and we can bring the incisor into the arch. So we created space. We have placed a Nance palatal arch. We created the space with an open coil spring. Then we went for an closed eruption technique. We raised the flap, we bonded the incisor, and we closed the flap, sutured it back, and brought it down. Now, this is a second exposure that we did because, during the traction over the period of 5 to 6 months, once we were taking the, follow-up IOPs, we saw that the attachment had broken. And but the good point about it was that the incisor had already come to the gingival level. So we went for an open eruption technique, and then we placed an attachment, and through an E-chain we brought the tooth into the arch. These are the post-treatment photographs. You can appreciate that we have a full unit class 2 molars, class 1 canines, and perfectly positioned incisors, and a happy patient. Second case, this was Ishan, 14-year-old. He came with a chief complaint of missing tooth since 2 to 3 years. These are the intraoral photographs. You can appreciate he already has a class 1 molar, class 1 canine relationship with missing incisor. This again was a case of supernumerary. This is the OPG. As you can appreciate, there were two particular supernumerary teeth in the first quadrant. This is the CBCT. Apart from, if you see the occlusal aspect of the first quadrant, I believe, there's a central incisor. There are two lateral incisors. There is a C and there is a canine. So we clearly stated that, okay, fine, the etiology is a supernumerary tooth. This is the MPR section. There's a little bit of dilaceration that was there. So we went for an open exposure. We created space, and just by extracting the supernumerary and creating the space, we were able to get a spontaneous eruption. You can see that the lateral incisor is clearly visible, the central incisor is clearly visible, and these are the post-treatment photographs. You can appreciate the patient has class 1 molar, class 1 canine, class 1 British standard incisor classification, perfect aesthetics, and a happy patient again. Another case, Mridul, chief complaint, missing teeth. So this was a little bit complex because the angulation was too much. So we thought that maybe we should just defer the treatment and maybe we should go for proper extraction of the incisor. But because of the lack of bony support, we thought otherwise, and we said that okay, fine, we'll go for maybe some amount of surgical exposure. So this is a lateral ceph. We went for an open exposure. Uh, Flap was raised. We created space. We brought the incisor into the arch, as you can appreciate. Next case, Abhishek, 15-year-old, again, missing tooth. You can see that in the second quadrant, the patient has a missing incisor. This is the OPG. The laterals have, sorry for the poor quality. Actually, this was a photograph that I took out of it because we had lacked digital models and digital records. This is an occlusal radiograph. You can see that there is an impaction. The angulation. We raised a flap, we created space, we bonded an attachment, brought the tooth into the arch. Last case, Yarak, my favorite patient, missing teeth since 1 year. He was a 7-year-old guy, and there was a missing incisor in the second quadrant. And now, as you can appreciate, that there is a palatal bulge. So it was clearly evident that this might be a case of palatal impaction. This is the OPG, lateral set. Now, the problem is that as you can appreciate that there is some amount of dilaceration. So we went for an CBCT, and then we realized that this was a severe case of dilaceration. Like you can appreciate that the crown is actually palatal and the root is positioned buccally, and there is a smooth curvature with respect to the crown and the root. So the goal of the orthodontic therapy was not just to correct or bring the tooth into the arch, but to also get enough biological width, enough bone on the buccal and the palatal aspect, avoiding any kind of fenestration. So we went for a palatal loop. This was a modified nickel titanium loop that we created. And with the help of a palatal loop, we tried to bring that traction in the buccal direction, as you can appreciate in the second photograph. So as the tooth came out, the root was moving in the palatal direction and the crown was coming to the buccal direction. Now you can appreciate that post treatment, this was the situation. The root, the curvature went on the palatal aspect, and the crown we were able to get on the buccal aspect. Pre treatment, post treatment. These are the current stage photographs. This was just a phase 1 treatment. Phase 2 treatment is currently going on. Again, a happy patient. So to conclude, monitor further dental development to rule out canine impaction apart from incisor impaction, and evidence of a significant association between unadapted incisors, enamel hypoplasia, hypodontia, ectopic teeth needs to be elucidated. Thank you so much. Are there any questions? No? All right. Thank you. Yes, sir. Hello, sir. Sir, I saw you, but you were busy. I was about to come after the presentation. I'm just coming.
Thank you for this wonderful session on unraveling implanted maxillary incisors, the why, when, and how. We would like to thank all our audience who has joined us today physically as well as online. Some wise words once said: use your smile to change the world. Don't let the world change your smile. With this thought, we would proceed further with our scientific presentation soon. Therefore, kindly take your respective seats. We'll be starting with paper presentations for slot 1, and the judges are going to be Dr. Malika Sethi, Dr. Sakshi, and Dr. Sumit Goyal, sir.
Are the presentations ready upstairs? So shall we start with the first presentation? So who's the first presenter? So we'll call, you both are coming first, come. Come this way. Start. So this is your, so all the best. Adhere to the time.
Good afternoon, everyone. I, Saman Raza and Anshu Kataria are going to present our case report on capillary hemangioma. So, we have a patient, 27 years old male, who reported to the Department of Oral Medicine and Radiology with the chief complaint of swelling on the right side of the cheek. The swelling was not painful, it is painless, and it is not associated with any pain. And the patient gives the history of trauma 12 years back. The patient has difficulty in mastication also. So as you can appreciate in the picture, on the right side, you can see a very mild swelling. It is not very clear in the picture. So the patient has adequate mouth opening. No abnormality is seen anywhere, but we can appreciate also on the palate region. So in the inspection, the swelling was fluctuant and tender on palpation, and in inspection, we can see a diffuse swelling approximately 2 into 2 centimeter in measurement. In the below 1.5 below the allotragus line on the right side, in the right side of the cheek region. So here are some differential diagnosis of capillary hemangioma. It can be any venous malformation, AV malformation, anterior venous malformation, hematoma, or lymphatic malformation. So for the investigation, we advise the patient for coagulation profile, complete blood profile, ultrasonography, and MRI. As you can see in the MRI reports, on the right side, you can appreciate the radiolucent lesions. For the treatment, we proceed with the parts preparation of povidone iodine 5% and 2% local anesthesia. We inject it and it is a work as a sclerosing agent which necrose the tissue, and then we do the debridement. Now, what is hemangioma? It is the malformation in the blood vessels. It can be congenital. It can be due to any trauma. We have here we have types of hemangioma. It can be capillary, it can be cavernous. Etiology, as we discussed earlier, it can be congenital or most commonly seen in infants. Very less cases are seen in early adulthood. So, for the diagnostic images, we can advise the patient for blood coagulation profile, complete blood profile, MRI, CBCT, ultrasonography, and for the management, we can advise the patient laser surgery, or as we do in our patient, the sclerosing agent, and we can go for radiotherapy or radiation therapy, or we can do cyrosurgery with dry eyes. So thank you. Thank you so much.
This is for the panorama question now. Background question.
What is your name? Some nice presentation.
Thank you, ma'am. Any questions?
No.
Okay, thank you so much, ma'am. A very pleasant evening to respected dignitaries present here. Myself, Sejal Sharma of BDS 2019 batch of Subharti Dental College, would like to present today a rather interesting topic, which is the use of graphoanalysis as a diagnostic aid in evaluating psychological attitude of a complete denture patient. Graphoanalysis is basically a systematic analysis of how words and letters are written, which means it expresses the disposition of an individual, that is, the characteristics of an individual. Moreover, understanding the mental attitude is one of the most important factor in diagnosis of a prosthodontic treatment. As it is said, that a dentist has to fit the denture in the patient's mind along with the patient's mouth. The psychological factors are varied, which include the preparedness of the patient, the mental attitude towards its denture, and much more. Handwriting is an essential tool, which is basically a brain writing, and pen is merely a tool. There exists a correlation between the emotional state and a handwriting of the individual. Therefore, using the concept of graphoanalysis in complete denture patients were analyzed based on their writing into having realistic or unrealistic expectations. So, I'll be presenting a few sample of patients who reported an OPD in prosthodontics department in various colleges in India. They were classified in the following criteria. For example, the age groups were under 50 to 75 years. Everyone was able to read and write English. And following that, the writing was submitted to a graphoanalyst and the evaluation was noted. So in this picture, we see the writing is slanting to the right, which means the individual is an extrovert. Simultaneously, slanting to the left indicates repressal or withholding of emotions, that is, individual's introvertedness. And similarly, writing vertically is to be very objective and clear in thoughts. Similarly, the signature of a person also tells us about the qualities of an individual. For example, in the above picture, we see if a person writes with a heavy pressure, he is an extrovert. With light pressure, the person could be uncertain in life. Underlined below the signature means the person could be sensitive. Connected or cursive writing also tells us that the person is a logical thinker. Few are also basic elements of handwriting, giving the various characteristics of an individual. For example, the bars above T indicate goal orientation, enthusiasm. The I dots indicate the ability to pay attention.
So these are few handwriting samples. And the requirements were basically the sentence is really important. A quick brown fox jumps right into over the lazy dog. It includes all the 26 letters of the alphabet. And the patient was also told to write about the requirements for the denture he or she needs. So the first patient, he was 50 years of age, male. This was the handwriting. So here we see that the handwriting is going upwards and the words are not connected with each other, resulting into the clinician's opinion, that is the dental surgeon's opinion, was that the patient was quite anxious for the denture. He was very worried about the aesthetics, required some conviction during the try-on procedure. Whereas the analyst opinion was also matching, which was that it would be really difficult to satisfy this patient. The writing was also classified on these 13 points, which were understanding, cooperativeness, suggestive by the graphoanalyst and not by the dental surgeon, which means how much important graphoanalysis can be. The second sample was this handwriting. Here the words are quite spaced and small in size, and even they are not very tidy. The clinician's opinion was that the patient was cooperative but not understanding and was not satisfied easily. Whereas the graphoanalyst suggestion was that it would be difficult to handle this patient, so the doctor should try to build up his confidence during the treatment with conviction. These were also the 13 elements which the analyst told. We must remember the adage, never treat a stranger. Therefore, the above study leads to the suggestive conclusion that graphology is an established science and helps in gaining an insight of patients' mental makeup in dentistry and to the ultimate success of the prosthodontic service. Thank you.
Your Sejal?
Good
Sejal.
evening, ma'am. Yes.
Okay, a very interesting topic you've chosen.
Thank you, ma'am.
Very interesting and something very new. So, you've like, have you done a survey or something, or you just put down cases?
Ma'am, my mother is a prosthodontist and my father is an orthodontist. So we all three sat together and we came to the conclusion that this is an interesting topic.
No,
So I
like,
did
so,
this research because my mother also did something like this in her thesis in the year 1998. So she was guiding me through this.
okay, so maybe in future, like, you can publish or you can do some research on graphoanalysis because it seems to be a very, very interesting topic and a very innovative one also. So, this can, is there any index for graphoanalysis?
Ma'am, there's Cornell Medical Index based on this. Apart from the M house classification, which is the regular classification of behavior like hysterical, indifferent, we have the regular Prosto classification, but Cornell Medical Index is specially for the graph analysis.
That was given in which year?
Sorry, ma'am.
Anyways, it's a good one. Nice presentation.
Thank you, ma'am.
Nice presentation.
Thank you.
So, Sejal, one more thing I wanted to ask you, if any patient comes to your clinic or your practice or your college, so maybe you can examine, like you can look into this part also before starting with the procedure.
Definitely, ma'am. I feel that this should be in the curriculum of dental
Yeah,
college.
that's what, so that, like we come to know about the behavior management part and how to deal with the patient thereafter.
Yes, ma'am, because in final year we see that the patients are hardly satisfied with the dentures. So it's aesthetic wise and the structural balance, they are fine, but we do have to understand their mental attitude towards it.
Very correct. Yeah. Thank you.
Jai Hind everyone, I am Sanskriti Agarwal and she is my colleague Riya Chaudhary, and we are here to talk to you all about on the topic tobacco cessation in Subharti Dental College. So as you all know that tobacco is the largest cause of illness and premature death in today's world, and it causes 5 million deaths, 9% of all deaths annually. Tobacco use is the largest single preventable cause of illness and premature deaths. Tobacco use currently causes about 5 million deaths annually. Approximately 1.6 million deaths are CVD related. If current smoking patterns continue by 2030, about 10 million deaths would be caused by tobacco use annually. Tobacco use has been the leading cause of cancer, death in men and since 1955, and in women since 1986. India is ranked the world's second largest producer and consumer of tobacco. This tobacco epidemic is taking death toll to 7 million globally. In India alone, mortality because of tobacco is more than 1.3 million. 31% of tobacco grown in India is used for manufacturing of cigarettes. So these are some of the tobacco products: cigarettes, bidis, hookah, and cheroot. So as you all can see on my screen, he's Shah Rukh Khan, and he's been considered as a real hero, but actually he's not the real hero. He's zero in his life because he's using tobacco in public, and he was banned in Wankhede Stadium last year for 5 years because of the use of cigarettes in public. So these are the WHO introduce, implement, empower measures to reduce tobacco use and save lives. So these are monitor, then protect, then offer, warn, enforce, and raise. And this is boom these days, as some of you may be using it also. It is a vape, it is an electronic nicotine delivery system, and in this e-liquid tobacco is there. And these are some tobacco chewing products, which is Khaini, Gutka, Pan Masala. So now I will talk about that how as a clinician we can actually motivate and seize the patients which will come to our clinic. So it is advise, assist, and arrange the follow-up. Then there are some R's, which is relevance, risk, rewards, roadblocks, and repetition. And this is the tobacco cessation clinic in our own Subharti Dental College, where we basically motivate our patients to quit the tobacco. This is the article based study which was given by our own faculty members, Dr. Sumit Goyal sir, Dr. Swati Gupta ma'am, and Nagaraju sir. And this is basically that it is an 8-year-old study, and it says that every dental college should have a tobacco cessation center. This is a trans-theoretical model which says how we can help our patients to quit the tobacco. And number one is pre-contemplation. So, as a clinician, what all we can do is we can raise doubts to our patients, we can discuss natural consequences. Second is contemplation. As a clinician, what all we can do, we can discuss cost and benefits, explore ambivalence, critical thinking, develop change options, and provide education. Preparation. How, as a clinician, we can set goals and action plans, identify barriers, provide encouragement, and connect with resources. Action. We can normalize loss of comfortable old days, continue to work on step by step realistic goals, stabilizing new routines, and provide positive reinforcement. Fifth is how we can tell them to maintain the schedule. We can continue goal planning, we can relapse prevention planning, we can provide support and encouragement to them, and we can reinforce commitment. Relapse. So it focuses on elements of past progress, recognition of warning signs, encourage recovery, re engaging, and back to basics.
So, as Sanskriti told us about the tobacco cessation, here in our clinics, what we are doing is we are doing OPDs, which are 170 to 180 OPDs in our oral medicine department, and our cause of concern is that we are seeing 3 to 4 cancer patient on the on per week, which is a huge number. So what we are doing is we are recording these cases and making an atlas so that we can show that to the patients and motivate them as visual aid. We are using it, and as a oral healthcare profession, it is our duty to promote tobacco cessation. Thank you.
Thank you and Jai Hind.
What is your name?
Ma'am Sanskriti Agarwal.
Can you classify smokers? Different types of smokers.
Ma'am, chronic smokers and passive smokers.
Anything else?
Ma'am, high dependence, medium dependence, and low dependence smokers. A person who is smoking 20 cigarettes per day, or it is within 30 minutes, as soon as he wake up, he is considered as high smoking or high smokers. And medium are those who are taking after 30 minutes of by after they wake up, and uh, they have less than 20 cigarettes per day, and the low consumers are who are consuming less than 20 and not within 60 minutes or more than so.
What are pack years? Okay, so can you enumerate few tobacco-related pre-malignant lesions?
Ma'am, there is leukoplakia, there is OSMF, and there is squamous cell carcinomas, and there's other oral cancers also, like verrucous carcinoma. Ma'am, they are all mainly because of tobacco only.
Can you put some in nicotine replacement therapy?
Ma'am, they are nicotine patch, they are nicotine gums, they are nicotine lozenges, which we are giving to the patient as they have the flavor of hookahs and gutkhas, so they can slowly replace the tobacco.
Any commercially available ones which you know of recent nicotine replacement tablets, capsules, or whatever, like recently some commercially available names, if you can tell me. What are e-cigarettes?
Ma'am, they are vapes only. E-cigarettes.
Ma'am, these are vapes only, which are used as nicotine delivery systems.
So are they like there you being used, or it is just like a theoretical part? People are using.
Yes, ma'am.
Do you have any app for this, for tobacco cessation in your college or something? Any app like for the patients which come to your department?
No, actually, we don't have an app, but we have a form which we tell them to fill.
Okay.
And ma'am, we already have a clinic and we are doing many things.
Okay, according to you, which is the most important step for tobacco cessation?
Ma'am, knowledge about the tobacco, tobacco is causing, and what's the bad effect of tobacco on health, and what is their families are going to deal. As what we are seeing is many oral cancer patients are in their 30s only, so their life is already compromised, and with them, their family life is also compromised.
Out of those steps which you mentioned in your presentation, pre-contemplation, contemplation, and others also, which is the most important step to motivate the patient?
Ma'am, contemplation is the as they are ready to quit, but pre-contemplations are patients who are not ready to quit the tobacco.
So, according to you, what's most important?
Ma'am, pre-contemplation is more important as we have to motivate them to tobacco cessation.
Okay, thank you.
Thank you, ma'am.
A very pleasant evening to one and all present here. Today, we, Dr. Eben and Dr. Tanya, we are going to present a case report on multiple myeloma. So, my patient, Mrs. Murthy Devi, reported to the Department of Oral Medicine and Radiology in Subharti Dental College with a chief complaint of swelling in her upper right back tooth region since 1.5 months. History of present illness states that patient was apparently well 1.5 months back. Then she developed a swelling in her upper right back tooth region, which was of short duration, and it was asymptomatic. The swelling was sudden in onset. Initially, the swelling was of small size. Later, it increased in size, causing discomfort to the patient. She had no history of trauma, associated pain, swelling, fever, or fluctuation, and any other similar swellings elsewhere in the part of her body. There was no relevant past dental history. Past medical history states that she was diabetic. She was on insulin injection, which was injected once a week. Oral hygiene of the patient was fair. The clinical examination, we could see that the clubbing, jaundice, cyanosis, these all were absent. Coming on to the local examination, an extraoral examination, facial symmetry. A gross facial asymmetry was present on right side of middle one third of the face. A solitary diffuse extraoral swelling that extends superior inferiorly from infraorbital margin to the angle of the mouth and mediolaterally from ala of the nose to outer canthus of the eye, which was obliterating the nasolabial fold. The color of the overlying skin was normal. While seeing on TMJ, the mouth opening was normal and muscles of mastications were non-tender. On clinical examination, the lymph nodes were non-tender and non-palpable. Coming on to intraoral examination, if we see the palate, we could see that the swelling extends buccopalatally from buccal vestibule to the mid-palatal raphe. We could also appreciate few superficial ulcers with a characteristic erythematous halo and a central gray floor. And these ulcers are ovoid or round in shape. The periodontal status of the patient says that there was generalized bleeding on probing. The saliva was thin watery fluid and examination of area of chief contrast. On inspection, unilateral solitary diffuse swelling was present on upper right back tooth region that extends from maxillary second premolar to maxillary second molar. The skin over the swelling was smooth and shiny. Few superficial ulcers would be well appreciated. On palpation, the swelling was non-tender and was firm to hard in consistency. There was no rise in temperature. Based on clinical finding, a provisional diagnosis of odontogenic myxoma or a cement-ossifying fibroma or a mucoepidermoid carcinoma was made. Mucoepidermoid carcinoma was because it was common in palate and because of the inflammation of minor salivary glands. Differential diagnosis was plasmacytoma and metastatic high-grade neuroendocrine carcinoma. These were the investigations that were done for the patient. If we could see the OPG, we could see a unilateral large ill-defined radiolucency with respect to 1/6 and with a well-defined border that extends from 1/4 till 1/7, and obliteration of inferior border of maxillary sinus could be well appreciated. Moving on to CBCT sagittal view, we could see 1 to 2 straight septa, giving a characteristic tennis racket appearance suggestive of odontogenic myxoma. In CBCT axial view, we could see in right maxilla there is buccopalatal soft tissue expansion. Then we did incisional biopsy, and the findings were such that there was large round cells with characteristics ovoid nuclei and saltpeter chromatin. There was nuclear pleomorphism and abnormal mitosis was seen, and these features were suggestive of round cell malignancies. Then we did immunohistochemistry stain that was done in Ames, and tumor cells were immunopositive for LCA, CD138, and kappa light chain, and these features were suggestive of plasmacytoma. Further biochemical tests were done. Serum B2 microglobulin was high. Nephrometry in total IgG was high. And in serum protein electrophoresis, M spike was seen, which was characteristic of multiple myeloma. Further, PET-CT was done in which osteolytic lesions was seen with increased metabolism involving the right maxilla, and the mild metabolism was seen with respect to sternum, right iliac, and both femur. Based on clinical, histological, and radiological finding, a final diagnosis of multiple myeloma was made, and these were the treatment regimen that was done for the patient. The medicines include injection bortezomib, which is an anti-neoplastic agent, capsule lenalidomide, tablet dexamethasone, injection zoledronic acid, and follow-up was taken after 5 months, and there was slight decrease in the size of the swelling with this pharmacological therapy. Thank you.
What is incisional biopsy and punch biopsy?
Ma'am, in incisional biopsy, we take, with the help of scalpel, we take the lesion as a whole. And in punch biopsy, we could see there's a called true cut through which we take that specific portion which we need to visualize.
Thank you.
Thank you.
How do you differentiate between multiple myeloma and the various lesions you've mentioned?
Ma'am, for various differential diagnosis of multiple myeloma includes like plasmacytoma. This plasmacytoma is solitary plasmacytoma, which only involves bone, and extravasous plasmacytoma that involves soft tissues. In multiple myeloma, we could see Benz-Jones protein in 24-hour urine collection. That is characteristic of multiple myeloma. And we could also, there are special tests that is done to diagnose multiple myeloma, like Phelan test and Tinel test.
Is multiple myeloma related to diabetics? Diabetes patients, like, do they have increased tendency of developing this lesion?
No, ma'am. Basically, multiple myeloma is
I think you've put that as an exclusion criteria.
Yes, ma'am.
Why?
Sorry, ma'am.
Not sorry, I'm asking you. Does like diabetes, they have an increased tendency of developing this lesion? Diabetics.
Ma'am, in diabetes,
Like, are they related, multiple myeloma and diabetes?
ma'am, patient can be immunocompromised through diabetes because in diabetes we see poor healing as well as in basically the multiple myeloma is a B cell neoplasm where there is a clonal proliferation. So indirectly they are both are different, but as diabetes can cause the patient as immunocompromised.
Find out. Okay.
Yes, ma'am.
Thank you.
Welcome.
Good evening and Jai Hind everyone. I Shubham Gupta.
And I'm Muskan Khan.
Today we are present here to present a case report on squamous cell carcinoma. So a patient named Vinod Kumar, 60 years old male patient, presented to the Department of Oral Medicine and Radiology, Subharti Dental College, with a chief complaint of pain and swelling in his lower right back tooth region since 1 year. Patient was apparently asymptomatic 1 year back when he experienced pain in his lower right back tooth region and also developed an intraoral swelling. The swelling initially was a very small that resembled a size of a rice and then it gradually increased to a size of a pea. Patient was having burning sensation while eating food and there was no history of discharge and radiating pain. Patient did not take any kind of medication for the same. On history taking, he was found to be a chronic bidi and alcoholic. On clinical examination, extraorally, there was nothing abnormality detected, but however, on intraoral examination, a nodular growth on the buccal mucosa, which was proliferative in nature, was found to be in the lower right back tooth region. On inspection, a nodular erythematous with proliferation growth seen on alveolar mucosa, pterygopalatine raphe, and medial border. On palpation, uh, there was slight pain and there was no kind of bleeding. Lymph nodes was non-tender and non-palpable. Based on the history taking and clinical examination, a provisional diagnosis of alveolar mucosal carcinoma was made. After that, patient was sent for the biopsy to the oral pathology department, and based on the histopathological examination, the final diagnosis of well differentiated squamous cell carcinoma was made. For the treatment, after confirmation of the lesion, the patient was sent to the oral surgery department for further surgical excision of the lesion. Thank you.
What is the differential diagnosis of squamous cell carcinoma?
Ma'am, differential diagnosis can be fibroma, pyogenic granuloma.
What is pyogenic granuloma?
Ma'am, pyogenic granuloma is basically uh, a reactive lesion that occurs in response to chronic irritation. Its most common site occurs on the gingiva.
Is alcohol related to squamous cell carcinoma? You mentioned about the second part. Smoking is fine. Is alcohol related?
Yes, ma'am.
How?
Ma'am, it acts as an aggravating factor.
Okay, how do you like treat squamous cell carcinoma?
Ma'am, squamous cell carcinoma is treated basically upon the grading. If, ma'am, it basically depends on the extent of the lesion. It can be treated either surgically, radiologically, or with a combination of both of the therapies.
Radiation, you mean?
Yes, ma'am.
And chemotherapy?
Ma'am, chemotherapy can also be done.
Drugs. Name some drugs. Some drugs for treatment of cancer.
Sorry, ma'am.
Okay, thank you.
Thank you, ma'am.
स्टार्ट करें मोरी चेंज चलाएंगे तो the future is completely open and we are writing it moment to moment, and hence the theme of the conference, bringing the future is of dentistry now and beyond. Jai Hind to one and all present here. My name is Rohan Gupta and my topic is erosive lichen planus. My patient name is Jay Bhagwan and his age is 51-year-old male patient. And patient come to the oral medicine department with the chief complaint of patient burning sensation and pain on both sides of the cheek since 1 year. According to the history of present illness, the patient was apparently asymptomatic 1 year back when he noticed burning sensation and pain in his right and left buccal mucosa. Burning sensation was gradually in onset, continuous in nature with severe intensity, and aggravates on having spicy foods. There was no absence. There was absence of relieving factor. Patient noticed red area on his buccal mucosa and gingiva. Patient are also having bleeding gums. There was no past dental history and medical history, and patient having the personal history of having stress since 1.5 year back. On clinical examination, patient patient having white radiating striae and erythematous area on the buccal mucosa, and border appear irregular and ill-defined. On palpation, that on tender was present. As you can see, on the buccal mucosa there was red erythematous area and white lines are present, and these are desquamated gingivitis. Based on clinical examination, the treatment plan was made, and the topical steroids and systemic steroids are given to the patient. And after a few follow-ups, the patient recover with these lesions, and patient recover very well. Thank you.
What most important characteristic feature of lichen planus?
Ma'am, white, if you, erosive lichen planus, there are other red erythematous area, but can, if we talk about lichen planus, there is a white radiating striae are present on the buccal
What
mucosa.
are they known as?
Ma'am, Vikram striae.
What are the different types of lesions like lichen planus?
Ma'am, they can be normal linear alba is,
No, like lichen planus, other types.
ma'am,
One is erosive, you mentioned.
ma'am,
Other,
speckle leukoplakia,
not leukoplakia, lichen planus.
ma'am, plaque like lichen planus can be present, ma'am.
How do you manage lichen planus?
Ma'am, we can give top steroids on the by the tapering doses. We can give steroids.
What other?
Ma'am, prednisolone or topical we can use say 0.1% triamcinolone.
Okay, thank you.
Thank you, ma'am.
Uh, Good evening, judges. I am Jaspreet, and with my colleague Akesh, we are here to present the topic Dentistry 4.0. New technological advancements are essential to make the dentist work quicker, patient comfortable, and process reliable. So, here we are with our topic. As we can see, old era dental chair. It is the first dental chair which was used, and now as we move with the new technologies, we are in the new era of dentistry. We are discussing about the new technologies of dentistry. like teledentistry, artificial intelligence, Internet of Dental Things, 5G and robotics, 3D printing, etc. Dentistry 4.0 is the fourth dentistry revolution, which uses new modern technologies to treat dental patients better. It provides innovation, problem solving with new manufacturing opportunities and automation and data exchange. It refers to a variety of method by which machines are designed to perform with human-like intelligence. Artificial intelligence is effective in healthcare by enhancing old system and enhancing innovation. It is used for medical research and development, diagnosis individuals, assessing public health consequences. Internet of Dental Things. The dentist can evaluate the individual teeth based on the data collected by the camera. It provides us with greater freedom and less time lost on home work journey. Augmentation and virtual reality. These are being marketed as long-term solution for content capture, development and delivery. CAD. CAD software, computer aided design, requires the user to log in to a specific machine that enables design work and help customize numerous medical instruments. It would allow designers to connect from home to their office computers and continue work as usual. 5G and robotics. Robotics are the new development. The 5G revolution revolutionized the healthcare treatment process. Robots are used to treat patients at medical facilities in order to reduce human to human contact. These technologies were important and progressed during the COVID 19 era, like teledentistry and robotics. 3D printing. While several imaging technologies are being employed in the field of dentistry, dental laboratory scanners are also suitable to build a 3D digital model from an accurate physical dental model. It consumes lesser time and cost. Thank you.
What is the role of artificial intelligence in periodontology?
Ma'am, artificial intelligence and robotics nowadays, like in we robots like medical robots, patient were admitted for delivering medicines to the patient. Contact, human to human contact is made less. Like we are focusing mainly on the technologies which got like promoted during the COVID 19 era. So, like robotics, this reduce the human to human contact.
Any drawback of teledentistry?
Ma'am, network like teledentistry is mainly used in the remote areas like villages. Doctor is sitting somewhere else. People are calling the doctor. Like very remote areas, and people are not aware about it. So, teledentistry is not well known right now.
It's a nice topic. If you can enumerate it like using artificial intelligence in different aspects of dentistry, like she's asked about perio, what about specialities? other specialities, can you enumerate few areas like where artificial intelligence is incorporated recently?
Ma'am, 3D scanners in perio will be useful.
The other
Ma'am, in oral medicine radiology department also.
That's what I'm asking. If you can name some.
Biostats, CAD CAM.
That is artificial intelligence. You can just look into this. This is the recent thing, no? That's what I'm asking you.
Yes, ma'am.
Thank you.
Thank you, ma'am.
Hello. Good evening, everyone. Myself, Ikrasna. Good evening, everyone. Myself, Ikra Aslam. I'm from first year BDS IDST, and my topic is merging artistic dentistry and technology, the AI renaissance in reconstructive and aesthetic surgery.
Slide change करने की.
And you must be wondering why I have taken this topic. It's a it's a sad story, but one of my relative gone through a major oral surgery. It was in Pune. Then I realized our dentistry has taken over so much into AI. Can you please? Oh, AI has taken over all the things. Then why you left the AI in oral surgery or any other things dentistry? Are you skeptical or are you excited? How safe it will be? And will it advance or will it hamper? My research will be divided into two topics: facial aesthetic, oral maxillofacial surgery. The first we go as a facial aesthetics. Then my topics will be skin analysis, imaging lighting. The skin analysis. How does it work? As you have already can see, there's a screen and a skin arm. The patient will be inserting his face and it will be telling the oil penetration, dehydration, any allergies present, and it is been connected to the very good into entrepreneurial skills. It's been connected to the app which will tell you to improvise your skin by the medical products. Then we go to the LED therapy. With a small light of frequency, you can change your appearance so much. It's been from the red light, you can do the whitening in the skin, the oil lightening, and melanin removal of acne scars. The removal of acne scars. The, now my topic will go dental, oral and maxillofacial surgery, and it will divide into dental implant, Vinci suture, VR, and 3D printing. Dental implant has taken over so much. It's very much in. Can you just back it? Little more. Can you do the previous slide? Previous slide. One more, please. One more. The dental implant procedure has now been done in one day, which takes 3 to 4 months. It's all because of our artificial intelligence. We notice so much anxiety in the patient when they go, but now the anxiety has been reduced because less drilling and effective procedures. As you can see, there's so much things happening. It's already been in use in European countries. You can even see the penetration of our files. And it also, there's one thing, there's reduce of human work there. No hygienist, much less of dental assistants has been required. Now my other topic is Vinci suture system. It's an it's a mechanical arm which is used for the procedure of surgeries. The Vinci system is consists of surgeon's console that is typically in the same room as the patient and the doctor there. It's a robotic arm which holds the object, scalpel, scissor, and it can be used for the major surgery and the small surgeries. For the gums, gingiva, as you can see, there's very precise needles. It's just 5 mm of needles has been put and does such a precise work, such a beautiful work, and it's the revolution of the surgery. And the one most beautiful thing about it is connected with a HD camera, which can see from the precise things and inner anatomy of your human body. And there's no need of larger incision to see the inner anatomy, and the recovery is very much easier. My next topic is visual reality. It's so much booming nowadays. Everyone is using visual reality, VRs. VRs are emerged into dentistry medicine already. It can reduce the pain management in the patient and can do so much better when the doctors are discussing. As you can see, there's already been, this is the patient been seeing. And the one most beautiful thing that shows is we see anterior posterior anatomy, but VR makes it possible to see 3D by merging it. My next topic is 3D printing. 3D printing is now very much common, as you know, and it can be for the customization of single tooth, single denture, or a whole crown, or for the critical oral and maxillofacial surgery. You can just do a whole customized skull for the say every patient for the critical. As you can see in this video, you can just modify it in any application, and it's very nice for the person or the patient that's seeing to tell them the placement of implants and any other mandible, chin overbite, lower bite, chin surgeries. This is the model. It's been taken from the our department. My references. Thank you so much for your attention.
Nice presentation.
Thank you so much, ma'am.
What is the role of artificial intelligence in implants?
So it's taken such a big role, I think, dental implant. As dental implant has been, the procedure takes 3 to 4 months for the patient. But from the this machine, you can just take one day for the procedure, and it is very much. There's less drilling. There's more precise way. You can see the files going in. You can see the angle going in, and there's you even the patient is much more relaxed, and they can see the procedures, how it going and how it works. It's a less complicated, and no there's less much of human work is required.
You've chosen a very good topic and you've like talked about three things which are recently coming up. So what is the importance of virtual reality in dentistry?
Virtual reality in dentistry is such good use as patient can see their case and critical case inside anatomy, which is very much hard for a doctor to realize.
uh, to tell the patient that how you can do that, the procedure will go like this. But it was very much easy for the patient to see the inner anatomy, and for the doctors doing their discussion. If there is more doctors are involved, they can easily tell other doctors how it is. And one more fun thing that I think is, in pediatric we can put VRs on our kids, so they can distract from this dental anxiety, and they don't care about the procedure and surgery much. We can play videos for them, and it is more of a like visual for them, and they forgot about all the incisions and happening to them.
Okay, can you quote any studies? Like, have you come across any articles or studies which have actually elaborated on virtual reality? Any study in India or anything being done in our
There's
country?
one major surgery that's been done in Europe that I have across. There was one lady who had his accident been done. So the implant, his mandible was all gone, and the thing that inserted in his while the accident was a rod. It's gone through the brain. The surgery was very complicated. It required oral and maxillofacial surgeons and a neurosurgeons. So it was very much easier for the patient. The patient was well educated. It was very easier for the patient to realize how the procedure is been done and how it will go. So they already made the video about that.
Any Indian study?
Not really, it's been not done yet.
I don't think so. There is
Yeah.
any Indian study which has been done.
No, not much article I have written about
But
Indian
what about
doctors.
3D printing?
3D printing is so much common in nowadays in India also. I have read so much. There's such a beautiful doctor. I think he's my inspiration. Dr. Richard. He's from Pune. He's oral and maxillofacial surgeon. He does so much good for the patient. He makes the customized skulls for them just to tell that how that will go, the the fabrication of bone, how the fabrication of bone will be done, how the implant will be put in, or how your mandible will be fractured. They tell about the fracture has been done there, it will be cured by this. It's very nice, I
Are
think.
you working on this? As in, like, are you doing some research on these
Yeah,
three topics?
yeah, I'm doing my research. There's one research that I'm doing trying to do is about the lesions that we see in our oral path that can be more hazardous. So I have seen the skin analysis. So there's one tool that I'm trying to do is, there's one tool that will be inserted in your mouth, open mouth, in open mouth, and then you can see is there any lesion or anything. Then the lesion will be detected, and it will tell you is it hazardous tumor. It will turn into tumor, or it's just a normal um, one like bite or anything.
Okay, thank you.
Thank you, ma'am. Thank you, guys.
Good evening, everyone. I am Vishaka Gupta, BDS first year student from ITSD Dental College. My topic is Say Goodbye to Dental Anxiety. Hello, Laser Dentistry. Fyodor Myamin in 1960 has introduced first solid state ruby laser. Laser technology was introduced in field of dentistry with novel idea of overcoming the drawback that was posed by the conventional method. We can classify laser as hard tissue laser, soft tissue laser, non-surgical laser, and also as low power, moderate power, and high power laser. Soft tissue laser basically deals with the gums. It is used in wound healing, phenectomies, abscess ulcer. While hard tissue laser deals with the teeth, it is used in caries detection, cavity preparation, hard tissue cutting, pulp therapy. Laser tissue interaction depend upon the laser wavelength. Any one of four interaction can occur at tissue interface like absorption, reflection, scattering, transmission. Why to choose laser? As it stimulates body own healing process and increases the recovery time. It also reduces free radical and oxidative stress. Now let's talk about diode laser. It is commonly used in our dental field. It is a type of soft tissue laser with relatively smaller in size. It is used in gingivectomy, teeth whitening procedure. Low level laser therapy is also a recent technique which is using in dental field. It is used in dentinal hypersensitivity, TMJ disorder. There are so many uses and benefit also. The benefit is that there is minimum mechanical trauma, less damage to the surrounding tissue, no need of anesthesia with some procedure, reduced risk of bacterial infection, minimum bleeding as it promotes the blood clotting. Some disadvantages also there, like single laser wavelength cannot optimally treat all disease, so more than one laser is required for the procedure. There is eye damage is a serious condition that can occur due to its high financial cost. It is non-accessible to all dental setup, and specialized training is required. There are many clinical uses, like it is used in crown lengthening procedure, aphthous ulcer, phenectomies, leukoplakia, pyogenic granuloma, teeth whitening procedure, root canal disinfection, TMJ disorder. We must have to follow some instruction also, like wearing of eyewear in the vicinity of the region. Warning sign must be placed outside the nominal hazard zone. It should be ensuring that laser is in good working order. My conclusion is that it is the most obvious advanced technique in our dental practice for our patient. It is also non-invasive in nature. Blood thinning patient, diabetic patient, medically compromised patient, or anybody who basically scares to dental procedure. It kills the fear and the anxiety out. Now we all can say goodbye to dental anxiety. Thank you.
How will you reduce the stress of the patient on dental chair?
मैम अगर उसका ट्रीटमेंट लेज़र के थ्रू हो सकता है तो मैम कहीं कहीं प्रोसीजर पे सूचर्स की ज़रूरत नहीं पड़ेगी तो पेशेंट को पेन नहीं होगा और उसे जो एनजाइटी होती है वो भी नहीं होगी.
Is there any stress reduction protocol to be followed?
Yes मैम, ड्यूरिंग प्रोसीजर हम ट्राई अपना बेस्ट ट्राई कर सकते हैं.
Study about this, it is important.
मैम क्या?
Study about the stress reduction protocol.
You mentioned about laser should not be used adjacent to fillings. Why? Amalgam. Okay, what is photobiomodulation? You talked about low level laser treatment. What is that?
Ma'am, low level laser therapy. In this, there is minimum wavelength laser is used.
What is the wavelength range for low level laser? Or what is the power? If you know, tell me the power for LLLT.
Ma'am, I don't know the power.
Okay, and can you enumerate few contraindications? Are there any contraindications of using laser?
Yes, ma'am.
Tell me. If you can
Ma'am,
mention
eye damage can occur.
contraindication, talking about adverse effects, any area where laser is not indicated, any contraindication you can think of. You can tell me relative contraindications also, no problem. Can you use laser on like patients having pacemaker?
No, ma'am.
So is that an absolute contraindication or relative? Absolute का मतलब पता है आपको ना?
Yes, ma'am. Ma'am, it is relative.
Relative. Okay. And You talked about so many procedures you do with laser frenectomy, depigmentation. You've shown cases, also pictures.
Yes, ma'am.
So, do you prescribe antibiotics after laser surgery? Is there any need?
Ma'am, it depends on the patient condition.
No. So, what is the advantage of laser, like over normal scalpel?
Ma'am, it increases recovery time, less damage to the surrounding tissue.
Okay, thank you. Okay.
Good morning, ladies and gentlemen. My name is Bhavna Sakuja, and I'm a student of Subharti Dental College and Hospital, Meerut. And today I'm going to present my case, malignant melanoma. It's a case study I've done under my mentor, Dr. Sumit Goyal, sir. So basically, what is malignant melanoma? Malignant melanoma is a type of skin cancer which originates in melanocytes, the cell which are responsible for production of melanin, a pigment which gives color to our hair, to our nails, and to our eyes. So this is my case. A female of age 61 came to the Department of Oral Medicine and Radiology with a chief complaint of pain and swelling and pus discharge from her lower right back tooth region. On taking the entire history of the patient, we got to know that patient recently got her extraction done of of the teeth in the same region by a local dentist on his consultation. And on further examining the case and taking the entire history of the patient, we did some extraoral as well as the intraoral examination. On examining the patient intraorally, there was reddish brown discoloration in the right lower mandible region in over the alveolar ridge and extending to the floor of the oral cavity. And as you can see, the lesion is reddish brown in color, extending to the floor and present over the alveolar ridge. And there is very evident gingival pigmentation that can also be seen. And extraorally, you can see there is enlargement in the submandibular lymph nodes or lymph node of the right side. And the lymph node was palpable, was mobile, and was tender. In intraoral examination, especially for the patients of malignant melanoma, what is the most important thing? It's A, B, C, D, E of malignant melanoma. A stands for asymmetry, which was there, it was quite evident. B stands for border, it should be irregular, ragged, as we saw that. C stands for color, it was reddish brown, and diameter should be more than 6 mm. And E stands for evolving, which says that it should evolve with time, as it is initially it's a small lesion, then it evolves and becomes a big lesion with time. On the basis of the entire history and the investigations and the clinical examination, a provisional diagnosis of malignant melanoma was made, and then further investigations like complete blood count of the patient, OPG, CBCT examination, FNAC, and biopsy were also done. As we can see in the OPG, there is evident bone loss in the same region. It is a CBCT report which shows that there are presence of osteolytic bony changes evident in the right mandible region of the patient. And this is the normal blood investigation of the patient. This is the biopsy of the patient which shows the features suggestive of malignant melanoma. So the treatment will be surgical excision. Now, what is the most important thing in this is a radical surgery is performed for malignant melanoma, and a wide local excision is given. After the wide local excision, sentinel lymph node biopsy is done. What is that? Sentinel lymph node biopsy is a dye is injected in the region of malignant melanoma. And the lymph node which takes up the dye is the lymph node which has the metastatic cells of the cancer. This is the surgical procedure which was done, and there are certain therapeutic strategies of melanoma which are done after the surgery is performed, which is topical therapy, immunotherapy, targeted therapy, gene therapy, nanotherapy, and chemotherapy. So this is the entire discussion of my case. There are certain risk factors which increases the risk of malignant melanoma, which are increased sun exposure, presence of numerous moles, family history of melanoma. But the point is, when we talk about intraoral malignant melanoma, there is no sun exposure. So how can sun exposure be a point? So sun exposure is a point, is a risk factor for melanoma of the skin in general. But the oral melanomas, there it's de novo. So there is no such risk factor for that. So if we talk about the pathophysiology, there are two gene mutations which are important. One is a gene mutation of CKIT gene and another is gene mutation BRAF gene. So this is the ABCDE of melanoma, and you can see there is very evident, it's very evident how all the benign and the malignant changes of a melanoma. These are the most prominent four types of malignant melanoma which are generally seen, which are the superficial spreading, nodular, lenticulomaligna, and acral lentiginous melanoma. So as you can see, they are different from each other. There are different stages of growth in melanoma. As it proceeds, it goes through radial growth phase, vertical growth phase, and then it proceeds to tumor ulceration and then metastasis of the tumor. So histopathological features, histopathology shows some atypical melanocytes present. And this is the sentinel lymph node biopsy I was telling you about. And then we can do skin grafts and reconstructive surgeries. If the lesion is wide and there is a lot of excision, then we'll go for grafts and reconstructive surgeries. And these are some complications like xerostomia, candidiasis, hypernasal speech, and surgical excision can also lead to loss of tissues and prolonged healing and etc. Thank you. Ma- Ma'am, it's a white patch which is generally seen in the oral cavity on the buccal mucosa. So it is due to improper oral hygiene maintenance and habits of the patients generally. Ma'am, my name is Bhavna Sakuja. Thank you so much, ma'am.
Now, I would like to call on the stage Adya from IDST College. Present. Now we are starting up with the poster presentation. Adya is our first contestant.
Can you please zoom out? So, first of all, a very good afternoon to respected judges and everyone present here. I am Adya Sharma, BDS first year from IDST Dental College, and my topic for my poster presentation is Smile Intelligence, the Smile Revolution with 3D printing and CAD/CAM technology in dentistry. So, smiles are powerful communicators, and they play a very crucial role in our whole well being. And dentists work very hard to put on those smiles on the faces. Coming to the topic, according to Elon Musk, 2040 is going to be the year when AI takes place over the entire world. Although that might not be possible, but as we know, traditional dentistry has always been relied upon manual processing. But the ever evolving relationship between artificial intelligence and dentistry has become a game changer in the lives of a dentist and the patient as well, in providing precision and efficiency in achieving the perfect smile. Computer designing begins with taking digital impression of the patient's mouth by using intraoral scanners and then designing by CAD software and making precise and customized dental restorations, such as crowns and bridges, inlays and onlays, implants and veneers, ensuring accurate fit, natural appearance, and proper functionality, followed by material selection using biocompatible materials such as resins, polymers, and metals. The CAD file is then loaded into the 3D printer and it builds the file in a 3D pattern layer by layer by using technologies such as stereolithography, digital light processing, and selective laser sintering. After washing and curing the dental prosthetics, they are then loaded into the patient's mouth for further treatment. The market of dental 3D printers is been increasing day by day in the entire world. At last, the integration of 3D printing and CAD/CAM technology has revolutionized in precision, efficiency, and customization. The fusion of advanced technologies and dental expertise has bring about many new avenues, ushering in an era where precision meets artistry in creating confident and radiant smiles. At last, thank you for your attention. Thank you. Thank you, ma'am.
Now, I would like to call Alina from IDST College to present her poster.
Good evening, distinguished guests and dignitaries present here. I am Alina Hassan of first year from IDST Dental College, going to presenting about the role of artificial intelligence in diagnosing oral cancer. The occurrence of oral cancer has increased in recent years and become possible to detect the oral cancer for medical professionals. So, firstly, let me walk you through the traditional method of diagnosis of oral cancer. Firstly, the biopsy test has to be taken, then histology, slide preparation, image acquisition, capturing images, then feature extraction, then oral cancer detected. But with the advancement of artificial intelligence, we move towards the non invasive processes of diagnosing. Like here, the image of the patient's oral cavity has to be taken. With the help of any device, we can take images with the help of a phone. Then, with the help of a RoboFlow software, which pathologists can analyze, annotate the areas of suspicious lesions. Here, another method is used, which is the fluorescent technique. In this, the pathologist can analyze with the help of an oral scanner. In this, the pathologist can analyze into the patient's oral cavity and analyze the oral cavity with the help of a monitor. And hence, this method has proved to be easier for both patients and the doctors than any other traditional method are used since decades. At last, I would like to say that these methods are proved to be the game changer in the field of dentistry. The promise of early diagnosis increase the efficacy and enhance the patient outcome. Thus, I would like to say that we embrace this innovation and it's hope for the best and healthier community. Thank you.
Now, I would like to call Samriddhi from IDST College to present her poster.
Can you please zoom out? Good evening, esteemed guests and all my dental professionals. Today, I'm Samriddhi Gautam, BDS first year student from Institute of Dental Studies and Technology. Let's embark on this journey together and explore the endless opportunities. Let's all picture this a world where dental appointments are seamlessly managed. Your personalized treatment plans are at your fingertips, and your dentist is always equipped with the latest advancement in technology. Today, I'm excited to share with you a revolutionary development in the field of dentistry the AI powered virtual dental assistant. This assistant is designed to assist various tasks related to patient care, practice management, and communication. One of the most significant features of this AI powered virtual dental assistant is its ability to streamline administrative tasks related to patient care. Um, Moreover, virtual dental assistant can also enhance patient education and engagement. Furthermore, I would like to say that, however, virtual dental assistant is better for everyone. It is not meant to replace dental dentists. It is more. Thank you.
Now, I would like to call Sakshi from IDST College to present her poster.
Good evening to one and all present here. I am Sakshi Singh from BDS first year, IDST Dental College, presenting you the topic of regenerative dentistry. Dentistry is the field that encounters new techniques, researches, and inventions every passing day by day, and regenerative dentistry is one of it. So, regenerative dentistry is the field that deals with the repair and rejuvenation of oral tissues that have lost their capability of healing due to any traumatic injuries, caries, and genetic pathologies. And the pioneer of the regenerative dentistry are these stem cells that have the ability to rejuvenate. They are derived from the periodontal ligament, dental pulp chamber, and the alveolar bones. Now, I'm diving into the techniques. I came across the term stem cell therapy, in which, with the amalgamation of laser light and the stem cells and growth factors present there, leads to the activation of stem cells into the dentinal structure. Further, I will move on to the dental biomaterials, which aims to mimic the natural structure and tissue regeneration. For this, we have a great example of bioceramics. Next comes our tissue engineering, in which, with the use of scaffolds and the growth factors and stem cells, leads to the create an environment which is facile for rejuvenation. Next comes our gene therapy, in which genes are introduced that leads to the that stimulates the growth and differentiation of to damaged teeth and the repair of the damaged tissues. And now comes the hot topic of today's time artificial intelligence. Artificial intelligence is indulged in the regenerative dentistry by giving it a pivotal point. And as now, dental algorithms are in use for early diagnosing by the use of dental images, CT scans, and intraoral images for the early prevention of any disease progression. In all, regenerative dentistry plays a cumulative effect of repairing, preparing, and healing smiles. Thank you so much.
Now we are continuing with the paper presentations. I would like to call Ashibad sir on the stage from 2020 batch.
So next week, इससे पीछे होएगा ठीक है
Jai Hind everyone. A very good evening to all the faculty members, jury, and my dear colleagues. I stand before you to present my case, crown lengthening procedure in the amelogenesis imperfecta. So, what is amelogenesis imperfecta? It is a hereditary disorder that is typically affecting the enamel in both primary and permanent dentition. Okay. Guys. बैक करना है बैक करना है टेक्निकल टीम प्लीज हेल्प बैक करना है नहीं हो रहा back. Thank you. So these are some of the genes: MLX, NM, KLK4, DLX3, and mutation in this gene leads to amelogenesis imperfecta. So these are some of the names: hereditary enamel dysplasia, brown opalescent teeth, and hereditary brown enamel. These are the terms that is enamel amelogenesis imperfecta is called. So, what is crown lengthening? It is a surgical removal of the soft tissue and the hard tissue for gaining the supracastal tooth length, allowing for a longer clinical crowns. So, what's the rationale? Obviously, to gain a biological width and also to avoid a violation that may lead to attachment loss, gingival recession, inflammation, and hypertrophy. So, what's the importance of biological width? To reduce the risk of periodontal loss, to protect the gingiva for passing any bacteria into it, and for placing the margin no more than 0.5 into the gingival sulcus to avoid the plaque formation. So, what is the case study? It is the joint uh, intervention of periodontics, prosthodontics, and endodontics to treat the case of amelogenesis imperfecta. So I will be presenting a case which I have assisted under the guidance of Dr. Mayur Kaushik in the Department of Periodontics and Implantology. 28 patient year patient works into the clinic having a chief complaint of sensitivity, uh, not properly chewing food, and obviously the unpleasant small crowns. So we have done the OPG like you see, and after the restorative phase, restoration done in all the teeth. So as you can see, the gingiva is perfectly fine. We have placed an internal bevel incision, and after raising the flap, we have done the after osseous integration. So sutures are placed, and as you can see, this is an awesome picture after post-operative. 2 months after post-op, prostheses are placed, and the patient is very, very delightful. So what's the indication of crown lengthening? For cervical, as you can see, subgingival caries, crown fractures, and short teeth. Also to create a ferrule for restoration, to relocate impinging crown margins and uneven gingival contours. So there are also some contraindications for crown lengthening: inadequate crown to root ratio, root fractures, aesthetic compromise, high furcation, inadequate predictability, tooth arch relations inadequacy, compromised adjacent periodontium, inefficient restorative phase, and no maintainability. So these are some of the pictures that is pre of image and post of image after 1 month. As you can see, the crown are properly visible. And after 2 month follow-up, prosthesis has been placed. So these are some of the points we have to keep in mind during the crown lengthening procedures. At least 3 between the restorations margin and the bone should be present. So to conclude, surgical intervention with prosthodontic post-op follow should be needed in managing a patient of amelogenesis imperfecta. Thank you, everyone. Thank you.
I would now like to call our next participant from 2020 batch.
Jai Hind and a very good evening to all of you. Myself is Stuti Bishnoi from Medias 2020 and here's my friend Tarun Sharma. We are presenting on the topic, Can Dentists Be Mobile? The insight for this topic or the inspiration for this topic was once with my mother, I visited a orphanage. It was for the mentally challenged and the physically handicapped children. So I saw that their medical treatment was available there for them, but the thing that was most neglected was their oral health. So let's so here we'll start to provide the quality, compassionate dental care to the homebound in the comfort of their home. We need to educate the patients and those that take care for them on the importance of good oral health and how it affects the patient's overall well-being. Our oral cavity is referred as the mirror of the overall health, reinforcing that oral health is an integral part of general health. So, can dentists do home visits? Yes, definitely. In our Subharti, we ourselves practice the camp visits. It's just like we are taking the health care, dentistry care to the personals who cannot visit to us. People who cannot come to the dentist can avail of the mobile care. For example, those people who are bedridden are in the nursing homes, geriatric care, independent living homes, assisted living facilities, private homes, etc. Generally, patients suffering from one or more of the following conditions are eligible in home dental services: Alzheimer's disease, visually impaired, dementia, heart disease, cognitive disabilities, arthritis, paralysis. These are all the patients who cannot visit us in our clinics or the hospitals for their dental care. Why is good hygiene so important for these? Because there the some common health conditions are linked to the poor health. For example, the most common problems seen in these patients are of periodontitis because of the poor oral hygiene, because they are not able to brush. The other problems can be the reducing the risk of oral cancer, because if they are coming for the regular checkups, then we can see the pre-malignant lesions or certain discrepancies in the oral cavity, which will help us to go for the further evaluation, testing, and the diagnosis. But when they are not approaching us, if they are they are not getting that facility, so we going there reduces their risk to these conditions. Now Tarun will take over with the services we can all provide with this home visits.
So services provided are oral exams and consultations, treatment of emergencies, teeth cleanings like prophylaxis, digital x-rays, restorations for cavities, extractions, root canal treatments, gum diseases, oral hygiene advices. So benefits of mobile dentistry. First, accessibility. It increases the accessibility, ease of dental care, compassion, convenience, and comfort at your doorstep. Quality of mobile dentistry treatment. Doorstep services from a known time tested branch which follows standard operating procedures. It saves time to travel for the multiple appointments. if we have advantages, so on another hand, we have disadvantages also of the mobile model. Basically, disadvantages are from the dentist point of view because treating residential patients requires more time and patience than treating those in an office. Travel and consultation times reduces the number of daily patients. Equipment requires movement to and from a car, and sterilization procedures are performed elsewhere. Flexibility is an essential dental treatment plans as for the compromised patients, medical requirements are first. Oral hygiene tips for the bedridden patients. We can use disposable teeth cleaning swabs, use of pre-made flossers. We can use antibacterial mouthwash or warm saline gargles. Uh, these are the conditions of denture of bedridden patients because of poor oral hygiene or neglect to the oral health. So traditional or mobile dentistry. Mobile dentistry is an alternative to traditional setup for people who cannot travel far from their homes due to age or health limitations. Conclusion. So we are concluding this by asking whether mobile dentistry is good or not. Yes, it is good, as well as it has some cons also, like uh, because some people due to age or due to their poor health they cannot travel, so they will be able to get the treatment at their doorstep, and disadvantages are also there. Mobile dentistry is a good choice for elderly or disabled people, and they will be able to provide the services you need in the clinic and then monitor your oral health under a mobile care plan. Thank you.
We are resting the paper presentation here only. After 5 minutes, we will soon start with the cultural and award show program, followed by gala night, dinner, and DJ. So please be seated and thank you for being patient.
Good evening, everyone. We welcome you all to this prestigious occasion of Dentist Award 2024, an impression culture night organized by CynoDent and Indian Society of Dentistry at Swami Vivekanand Subharti University, Meerut. Now, I would like to call upon the stage Dr. Anmol Bagaria ma'am, founder and CEO of CynoDent, president of Indian Society of Dentistry, and organizing chairperson of the conference. Dr. Ashish Chandra sir, co-director of CynoDent, vice president of Indian Society of Dentistry, organizing secretary of the conference, and Dr. Sumit Goyal sir, to begin with the award ceremony. So the award for the best laser dentist of the year goes to Dr. Malika Sethi Rishi ma'am. And also, we are felicitating her for the Women's Day.
Thank you, sir. Thank you, ma'am.
Now, we will be starting with our cultural night.
Our first performance for today is by Gaurish Patra from 2021 batch.
Hello, hello. Shik, ऐसी बहता शिक, क्यों मैं तुम्हें विश्वासिक, जा- जिस राह मैं तुझे अक्सर वहाँ से जाऊँ Oh, Chana, Chana, Chana है दीवाना किसी से लगाना तुझे याद के बाद साथ याद की कसम जिस जिस
That was a magnificent performance. What a melody. Those who wish to sing always find a song. And we have amongst us such a singer. Dr. Samriddhi Singh ma'am from 2020, who will be our next performer for the category. Jai Hind and good evening, everyone, to all our respected dignitaries, eminent speakers, and delegates. Our cultural program tonight is a certain spectacle round to take you on a journey across the rich to present that is our diverse culture.
We would like to invite the group performance children for today's performance. And we're going to start with the vibrant performance that is a wonderful blend of grace. And I'd like to call upon Meet, Nishit, Anvesha, Paridhi Varshne, Anushka Rati, Pratna Krishna, and Riddhi Mittal for their performance.
Please give a huge round of applause.
जटाओं से है जिनके जल प्रवाह नाट्य गंग का गली में जिनके सज रहा है विश्व जंग का कमल 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 कर रहा शिवाय शिवम भरल भली कजु पापी शिवाय शिव शंकर से पार्वती बड़ी शंकर से सुनिए भोले नाथ जी रहना है एक जन्म मुझे तुम्हारे साथ बचन छोड़ भोले बचन
Thank you so much for this mesmerizing performance.
Dance is indeed the loveliest of all arts because it gives us the slightest excuse to feel and be completely beautiful. Therefore, it is no mere extraction from life, yet it is life itself. With this, I'd like to start off with the solo dance category, and our first performance under this category in this evening is Dr. Ria Rastogi, a BDS third year student. Since Dr. Ria Rastogi is not here, I'd like to move on to the next participants. That is Pernika Jain. She is a BDS first year student. You showed us the loveliest of expressions, which vibed immensely with the music so well. Thank you, Parnika. I would again request Priya Rastogi, ma'am, a BDS third year student, to kindly have a performance here. Thank you, ma'am. There are shortcuts to happiness, and dancing is one of them. With that, I'd like to call upon the next performer for the evening, and that is Shanvi Sachdeva, a BDS first year student.